There is some technical glitch. Women have attained great feats and contributed to the realms of nephrology across the globe. Their work towards clinical and research-based enrichment of subject has been exemplary. An offshoot of International Society of Nephrology, Women in Nephrology was founded in the year 1983 and has successfully helped women to nurture their careers in this field. Women in Nephrology India intends to ignite interest in nephrology among young practitioners to effectively and meticulously mentor them in various aspects of kidney diseases. WIN India has been the dream child of Dr. Vidya Acharya. Dr. Vidya Acharya, affectionately known all over the country as the mother of nephrology, the first lady nephrologist of India. She started her illustrious medical career, completing her undergraduate and postgraduate studies from the prestigious Seth GS Medical College and KM Hospital. She dedicated herself completely to these institutions, where she joined as faculty and contributed immensely to the development of the departments of medicine and nephrology. Even after her retirement, she continued to remain a great teacher and a researcher, and devoted herself wholeheartedly in training the students of nephrology and encouraging them to conduct research. For all contributions in the field of nephrology, she received numerous awards, including Lifetime Achievement Award from the Indian Society of Nephrology and South Asia Region Pioneer Award from the International Society of Nephrology. The Indian Society of Nephrology West Zone chapter has instituted an oration in her honor at its annual meeting. Madam will always be the guiding force and inspiration for a lot of women in India and abroad. I'm sure she has touched the lives of many. Let's seek her blessings and start today's session. I invite today's Mistress of Ceremony, Dr. Haritha Harindranath, Senior Resident, Department of Nephrology, Institute of Nephrology, Bengaluru, to take over the podium. Thank you.
Good morning, one and all. I welcome each one of you to the scientific program. Without further ado, let us begin this scientific journey. Our first program is a pre-conference workshop. The topic of discussion is nutrition assessment in chronic kidney disease. To chair the session, I would like to call upon Dr. Dhanalakshmi, Senior Consultant Nephrologist, Glen Eagles Global Hospital, Hyderabad, Dr. Jasmine Sethi, Assistant Professor Nephrology, PGI Chandigarh, Dr. Monica, Consultant Nephrologist, Arogyadharma Hospital, Karnataka, Mrs. Sunita Rao, Chief Dietitian and Nutritionist, India Hospital, Bangalore. And I now invite our chairperson to introduce the speakers.
Yeah.
You know, just put this here.
I can give it to you.
Can you just wait?
It's in online. You need the physical.
I need the secret.
Good morning, everybody. I would like to welcome to this scientific session, which is going to be there for the next 2 days, and excellent topics. And today, this being the first session, I would like to introduce call upon Dr. Arpana Iyengar, Professor, Department of Pediatric Nephrology, St. John's Medical College, Bangalore. And also Dr. Sukanya Govindan, Consultant Pediatric Nephrologist, Mehta Hospitals, Chennai, India. Thank you.
Good morning, everybody. It gives me immense pleasure to be here today as part of this WinICon 2023. And also thanks to the organizers for inviting us and also for selecting nutrition as the topic to be discussed. It's often missed or neglected. I'm also very happy to be presenting along with Dr. Arpana Iyengar, probably the only person who's done individual original work in nutrition in children in India. And she's also been a mentor of sorts to me. Her counsel and advice has helped me a lot throughout my career. And for today's talk and today for the session, for the first 40 minutes, in fact, we'll be presenting side by side together as a team. We also would like to introduce Sheba Collins. She's the dietitian at St. John's Medical College. She's also very much part of the team and she's contributed so much to nutrition in children with CKD. So we'll be presenting this as a team together. So moving on. This one is not. This one is also not. How do we move the slides? We have this. किसी को मिस करना? Thank you. So in the next few minutes, we'll be discussing about the growth impairment that we see in CKD, factors affecting growth. We'll take you through what is meant by the nutrition care process and in detail about nutritional assessment, briefly about diet prescription and the resources that one would have to look up to if you want to prescribe nutrition for your kids with chronic kidney disease. So growth faltering is very much a part of pediatric kidney disease, and all of us time and again see children who are very short and not growing well when they have chronic kidney disease. But there are certain subgroups which have more growth faltering. So younger the child diagnosed with CKD, younger the onset of CKD, more is going to be the growth faltering. A patient who has the least GFR obviously will have the most growth faltering. And also, to some extent, the etiology of CKD determines how much of growth impairment one could expect in the child. Diseases like aplasia or dysplasia, reflux nephropathy, and obstructive uropathy, or the complex or the phenomenon of Charcot in per se, would have more growth impairment compared to other causes of chronic kidney disease like glomerular disease. Does poor growth impact anything other than just your linear height and your weight? Yes, poor growth increases mortality, and there are many evidence-based literature available for this. For each decrease by 1 standard deviation in height, it increases almost the risk of death by 14%. And also for each 1 standard deviation decrease in growth velocity, which is often that we use in our practice, the risk of death has been shown to increase by 12%. So poor growth does impact a lot more than what we see. And also, does this impact stop when you offer kidney transplant or renal replacement therapy to kids? it's not true. So a child who is a short stature, a child who is underweight is more likely to have lower kidney transplantation rates, and after transplant is more likely to have higher graft failure rates and also have a higher mortality risk even after transplant. So having a kid with poor stature would impact all of the other RRP outcomes as well. What are the factors that would affect growth? So there are many non-modifiable and modifiable factors, and some of the social factors which we could perhaps modify. The non-modifiable factors are the birth weight and gestational age. A child with very low birth weight and a preterm child is obviously going to be born with lesser nephrons. So that is something that we would be unable to modify. And also many complex congenital anomalies, we might not be able to improve their growth with the available measures that we have now. And especially non-renal anomalies influence growth of these children. There are many modifiable clinical factors. Of most important is the residual renal function, followed by nutrition. And nutrition is one of the most cheapest and the most easily remediable clinical factor that would impact growth. Salt wasting, acidosis, mineral bone disease, anemia, inadequate dialysis, and a dysfunctional growth hormone axis are all other factors which could be modified by medications and by proper diet. But what is more important is the modifiable social factors, which we are very late to recognize and don't have currently many tools at our disposal to, rectify this, and which has a huge impact on how our children with chronic kidney disease grow. Late referral is one common problem that all of us face. Many of our children come to us in the end-stage kidney disease where we have no other option but to start them on dialysis. Access to a pediatric renal dietitian, who is probably the best person to prescribe nutritional management to our kids. Many of us do not have access to a pediatric renal dietitian, and economic factors obviously play a role in how we deliver nutrition to our patients. And how does nutrition per se influences growth? So there are many factors that influence growth, and how much of an impact does nutrition cause in this growth? So nutrition is very important, especially in the early phases of life. So when we divide the growth phases into fetal, infantile, childhood, and puberty, the infantile phase and the early childhood phase are the most important phases that is impacted by nutrition. And the hormonal influences come later, like the growth hormone and the sex hormone influence. And the more younger the child, the more calories per day is incorporated into new tissue. So more feeding, improved feeding for a younger child would directly result in improved weight gain and increased linear height. This is true especially for energy and protein, where energy and protein is more important to younger children, and they have the most growth deficit that is possible. And especially optimizing feeding, like using enteral feeding like gastrostomy, improves their energy and protein intake and has resulted in very significant improvement in their growth. The next greater influence on growth comes from the calcium phosphate and the PTH influence. It has the greatest influence on linear growth for a child. And our children often with problems in this axis, like secondary hyperparathyroidism and adynamic bone disease, have bony deformities and increased fracture risk. I would now invite Dr. Arpana to speak about the nutrition care process and take us through nutritional assessment. So the nutritional care process is a standardized process for the provision of nutrition care. It can be divided into four main criteria or main four divisions, like the assessment, diagnosis, intervention, and monitoring and evaluation. And assessment is the part that we are going to focus majorly on today. So the food or nutrition related history, nutrition focused physical findings, anthropometric measurements complemented by biochemical data will sort of give you an idea of how much of growth deficit and how much of nutrition related deficit that your child has. And then this will help you, a comprehensive assessment would help you identify the problem and also evaluate why this child has this problem. And then you can go on to design or determine your intervention and prescription, and also have defined goals of treatment before prescribing your intervention. And always keep monitoring and revising your plans.
Yeah. Thank you, Sukanya. Good morning. First and foremost, I would like to thank Will, not just for giving me this opportunity and giving us this opportunity, but if you can see here, we have a good collaboration between clinicians and nutrition experts. I think that's the way forward. And Vin has always been supportive of this concept. So we have chairpersons from both nephrologists and nutritionists. We have speakers today in this session, both nephrologists, both pediatric, adult, and nutritionists. So thank you very much for that. So Sukanya has just left us with a nutrition care process. So there's something like that already in place. So is there any doubt that we, to use this in practice, we should be using in practice, but how many of us actually do it? So if you look at not only our own regional perspectives, but the survey of the ISN, ISRNM, formal assessment of nutrition status in adults with CKD happens only in 44% of countries across the globe. And of course, it's expected that high-income countries would have a better formal assessment in place compared to low middle income and low income countries. Why is nutrition assessment not taken up as a mandate? I think the first thing that comes to your mind is it's time consuming. But as pediatricians, I can talk from that angle, that as general pediatricians, we know how much nutrition, growth, and development have been grilled into our minds right from day one of our training. So as pediatric nephrologists, I think it should come very naturally to us to look after these children, assess them, and manage them. But the challenges in nutritional assessment in patients with CKD, be it adults or children, is definitely more complex compared to healthy population. And some of the reasons for that is that the changes in body composition profile, the fat compartment, the muscle compartment, the water compartment of the body changes with age. And in children with CKD, these changes do not reflect healthy children. So that's a challenge. We don't know what is happening. Is the fat actually preserved? Is it less? Is the muscle getting wasted and so on? Then we know that a very important confounding factor is the edema, fluid retention. So, for example, if you have a BMI which is not below the cutoff for undernutrition, it may be because the edema and the fluid retention has caused weight gain. And therefore, you actually underestimate the undernutrition status. Even mid-arm circumference, you could have the same problem if there is edema of the hand. So the fluid retention and edema becomes a very important confounding factor. Etiology of CKD, like she just mentioned, Charcot or non-glomerular diseases, they progress slowly. So during the phase of growth, the child can get affected most. Medications can affect growth. The most important factor would be steroids, comorbidities like mineral bone disease, especially in children with rickets and bony deformities. And most importantly, there is no single ideal tool for nutrition status. And that's why we're still in the dark, and we have several tools still evolving, and we don't have the one reference tool that one can use in practice. So if you have to go through nutrition assessment, we could probably divide them into 5 domains: the dietary assessment, the appetite, taste, smell, and assessment, which is actually part of dietary assessment. And that's something new because we don't give that kind of importance to otherwise a regular diet assessment. Anthropometric measures and biochemical measures, and to end with a point of care assessment, which is going to be very relevant to every clinician. Nothing, no rocket science, just clinical assessment for nutrition status. So in the diet assessment, as I mentioned, appetite is something that we need to start off with. Usually patients are anorexic, and we know the pathophysiological factors for this. So that itself can come in the way of optimal dietary intake. Children with tubular disorders, especially the ones which have polyuria, they drink a lot of water, 6 to 7 liters per day, and therefore they have no space in their tummy to have normal food. So obviously over time they become calorie deficient. If they are polyuric, that means they're also polydipsic, or if they are oliguric, then we all know how we stress on restricting fluid. It's very easy to say that, but for children or even adults, it's very difficult to restrict fluid. And children especially, they crave for salty food in between, even without a tubular disorder. So the salt in that diet again aggravates the thirst center, and they're thirsty all the time. So this again, the fluid balance and fluid management is a big challenge. We don't really give importance to bowel habits. We always ask about urine output, urine stream, but bowel is a very, very important integral part of our assessment. We got to see that our kids are not constipated. The fiber in their diet should be optimal, and some of them have bowel bladder dysfunction, and then that's a totally different scenario that we need to take care of. Smell and taste there is evidence to say that are altered in patients with CKD in adults. In children, we don't have enough evidence, but the pathophysiology behind that is the same, so we should be expecting the same in children. Dietary assessment involves briefly the diet 24-hour recall, which you'll know a little in a bit in more detail. And then you have a reference method called diet diary. That is a prospective way of recording what you take. So there are advantages, there are disadvantages. The food frequency questionnaire is at a community level. So it depends whether you are looking at a diet assessment in your clinic, at a community level, as a research tool, as a clinical tool, and so on. Diet assessment, the frequency with which you do is more frequent if the child is younger. I think this slide just gives that message. The younger the child, you do it more often. The more severe the stage of CKD, you do it more often. So at this juncture, I would invite Sheba Collins, who has joined our department as a general dietitian. So I want to make this point very clear that if we clinicians are looking for renal dietitians already trained in renal nutrition, then we may have to wait many, many years. So the journey starts there. As clinicians, let's include general dietitians, and over time, believe me, she's been here for 3 years with us. She has learned what CKD is, how children on dialysis need to be taken care of. So it comes with time, and I think we need to nurture these faculty. So Sheba will tell us about what she does in our clinic on diet assessment.
Good morning, everyone. I thank Win India for giving me this opportunity, and I thank Dr. Arpana for molding me to this level. As we see in the slide, in the clinical practice, the important tools for the dietary recall, and this tool is a bridge between the patient and the dietitians. So I usually take 3 days dietary intake. One is Saturday and one is Sunday, and one more is weekdays or school going days. As you know, like Sunday will be different food intake comparing to the school days. So lead question need to be asked to get a specific answer. So if I ask a parent, what did your child had in the morning? The usual answer is, my child will not have anything except the milk. So what is that milk? So with the milk, I can't take anything. So I need to show this tumbler how much milk the child is taking. And the mother will say, only plain milk, madam, nothing else. So then I'll ask, is there sugar is added, or jaggery is added, or honey is added? So then say, yeah, yes, I will add little sugar. So then again, I have to show the spoon how much sugar is being added. Then then the mother will say that big spoon, which is almost some 70 to 80 calories. So by this, I start the journey of dietary intake. So moving on to it, so I need to know when the breakfast is happening or what is being sent to the school. So mother will slowly start with, I'll pack 2 idlis or 3 idlis and then send it to school. So again, I have to dig it, like if it is a dosa, how many dosas? It is a small dosa or medium dosa or big dosa. And then the ratio of rice and dal, or it is a ragi dosa or jowar, or these all need to be understand and need to be questioned to get a specific answer. The same way, like I need to check with breakfast, lunch, dinner, and keep moving on. So this will be 24 hours recall. So when I take all this 24 hours recall and fed in a system, so I get all this nutrient. Apart from this, I get many nutrients, but for pediatric renal, I take only calories, protein, fat, sodium, potassium, and phosphorus. So this will give an idea like how much the child has taken This is for 1 day. I'll be feeding for 3 days and I'll take an average. So coming to this is almost present in everybody's house. So this fast food or ready-made food or fascinated food, I need to understand and I need to know how often the child is being consumed and how many days in a week or a month or a week. So this has to be, this cover will show us, or at the backside of cover will know the label, which we can understand as a dietitians how much is he or she is consumed, and this is being calculated and added to the 24 hours recall. So as a part of a study, we made this phosphorus pyramid. So we educate a parent to know this. So what we will do, you can see bottom lane is a high phosphorus diet. It's a low phosphorus diet. So this the patient can have without a guilt-free. And then as we move on to the top, we ask them to avoid or restrict depending upon the patient condition. And definitely I insist to use the pressure cooking method for using the pulse and legumes, like overnight soaking pulse and legumes, remove the water and then adding a fresh water, excess water, pressure cooking, and then removing that water so that the phosphorus level is absorbed less. So this is similarly another pyramid, acid alkaline pyramid. We used to educate the parents to see that dietary acid is not excess in the diet. So as we know, this is one of the reasons for metabolic acidosis. So how do we look at the acid load? We measure PRAL, nothing but potential renal acid load. So it is divided into two types, acidic food and alkaline food. So acidic foods are nothing but protein and phosphorus, and alkaline food is nothing but calcium, potassium, and magnesium. So the difference between the acidic and alkaline will give us a PRAL value. So what I do in my clinic, I have entered everything in the software like a simple Excel sheet. So when I enter phosphorus, protein, potassium, calcium, and magnesium, I'll get a value. Either it will be a plus or it is a minus. More the plus is acidic and more the minus is an alkaline. So if the patient is having, so I will take everything from 24 hours recall. This value is being fed in the Excel sheet and I will know the PRAL value. If it is more acidic, then we will balance the food and we will explain what all to be included and what all to be excluded. So over to Doctor.
So after our dietitians have done the most difficult task, what we clinicians should be attempting to do at probably every clinic visit is to measure the growth parameters of a child to see whether the given nutrition has impacted their growth, whether how much of growth deficit is there and how much of catch up that a child has to do. The primary measurements for this would include the common things that we do in our clinic, like the weight, the length or height depending on the age of the child. And with regards to weight, you should be attempting to use the dry weight as much as possible. As Arpana ma'am said, edema often plays an important role, and you have to assess the dry weight as with the available clinical methods and use the dry euvolemic weight as much as possible. For children who are less than 2 years, we use the recombinant length, and for other children, we use the standing height. And for head circumference and weight for length are usually used for younger children. So use it when appropriate, and use the BMI for children who are 2 years or older. Rather than a single measurement, we should rely mostly on the trends in growth parameters rather than a single measurement. And which growth charts to use? You can use either the WHO growth charts or the IAP growth charts, which are India specific. So I'll show you how to plot things on the IAP growth chart today. And also when there is a specific disorder or a genetic condition, especially like trisomy 21, you can try and use growth charts that are available for specific conditions. And also to complement these weight, height, and BMI, you should always use the Z-scores, especially if the weight and height is less than the 3rd centile, to assess the degree of the impairment, complement by using the Z-score charts. And also always use the height or the length velocity, which is seen over a minimum period of 6 months.
And as I said, use the Z-scores when the height is less than 3rd centile, and also to get a target at what is the maximum growth potential of the child. Calculate the target height using the mid-parental height. I've given the mid-parental formula below. And also for premature infants, use a weight for length for both for the gestational age and for the chronological age. So all these are few parameters or few nits and bits that you have to do it for your children based on whether they are preterm, whether they are stunted very much, or they are having a specific genetic disorder. So again, how frequently should you be doing this anthropometry assessment? Again, as for the diet assessment, it is the same. The more younger the child, the more frequently you will have to do the anthropometry measurements. And also the more advanced the stage of CKD, again, more frequently you would have to do these assessments. So this is the IAP chart. For people who are more used to mobile devices and iPads, this is an excellent app that IAP has. So you have to just put in all the numbers, and all the parameters just come to you with nice graphs and nice trends. So this here. So here I've given the anthropometry measures of a 15-year-old male child who has posterior urethral valves, and he's currently on peritoneal dialysis. So at 15 years, his height is 113 centimeters, which if you see the is going to be the downward, the pink line that is there. So that is very much below the 3rd centile for his age. And so his height is less than the 3rd centile. In the same graph, also look at the green central line, which sort of gives you the 50th centile. So there's something, there is a term called the height for age, or the height age of the patient. So the height age of the patient corresponds to the 50th centile on the place on the 50th centile where the child's height falls. So this 113 centimeters for this child falls on the green line somewhere for the age of 7 years. So the height age of the child is 7 years. So that is something that you would want to note when you're especially going to the weight parameters. The next one is the Z-score. So the calculated Z-score for this child also falls below -3 standard deviations. And also I marked on this chart the target height of this patient, which is calculated from the mid-parental height of the parents. So the mid-parental height, with that, the target height is 157 centimeters. So you know the actual potential of the child, if he were not to have CKD, would be 157. And try and optimize your nutrition prescription and all your medications to see if you can go nearer to that height. And this is the height and Z-score trends. As I said, a single value is not enough. You should be looking at the trends. So the blue chart here shows how much of a deficit is there that the child has to reach the target height of 157. And you can see a very, very slow increase in his height over the years. When you look at the Z-score, that gives you an actual a picture of what's happening in the background. If you see, the deficit has only gone higher and higher. So the child has a much higher deficit as he moves across his age, and the deficit is only compared to his target height, the deficit is more pronounced as he advances in age. These are height velocity charts, and these can be used to plot and see the trend of the child's growth over a period of a minimum of 6 months. So we tend to define persistent growth failure as having a less than 3rd centile height velocity for a period of at least 6 months. So coming to the weight parameters. So if you see that the child's current weight is 20.6 kilos, and that again falls below the 3rd centile. And this is where the concept of height age comes, because most of our children are very much stunted, very much stunted. The weight probably is, when you use it for their age, you might get a bigger deficit than what is truly there. So when you plot the same weight against the target or the height age of the patient, so the height is 113 centimeters and it falls at 7 years of age at the 50th centile. So the patient's height age is only 7 years, although he's 15 years of age. So for the height age of 7 years, his weight should have been around 21 kilos and the child is around 20.6. So there's not much of a weight deficit here. So this is something that is very important when you calculate a nutrition prescription for a child who's severely stunted. Although the expected weight for the actual age comes to 55.2, the child's ideal weight could be anywhere between 21 to 22 kilos. So that is what I wanted to say here. Again, I plotted the BMI here, which is sort of adequate for this child. So can we supplement these anthropometry measures by any of the biochemical parameters? So the probably the only tool that we regularly use is the serum albumin, but that has a lot of disadvantages if you want to rely on the serum albumin alone as a nutritional marker. It could be an indicator of nutritional status only after you've ruled out the other causes of low serum albumin. And there are plenty of causes for that in a child with CKD. So you can have inflammation in itself is a very strong factor for pulling down the albumin in the blood. So make sure that that is all ruled out before you take a decision based on the serum albumin for the child. The only other proven biochemical marker that has been beneficial is in children and adolescent patients on hemodialysis, and that is the normalized protein catabolic rate. And that can be utilized, and whenever a value of greater than 1 is there, it is an indicator of adequate protein intake. And this is only standardized for children, adolescent children on hemodialysis. Are there any other secondary measurements that can be considered or used to supplement the primary anthropometric measurements? A general physical examination, which Dr. Arpana will be going into in detail, the waist-height ratio, mid-upper arm circumference, and always make sure that there is no edema, and do not project these values for clinical use when the child has edema. Hand grip strength, bioelectrical impedance are some other factors that you could use. Among the biochemical parameters, serum urea or the BUN can sort of reflect the protein intake, but can also be very high when the patient is catabolic. So please make note of it. Cholesterol, transthyretin, the bicarbonate values, anemia, creatinine, and other inflammatory markers can all sort of give you together a rough idea of where your child stands, whether it's too much of inflammation or cachexia, or very much an undernutrition or decreased nutritional intake. Now I invite Dr. Arpana to speak about malnutrition and protein energy wasting.
So having gone through the traditional tools, we now look at a new evolving entity. This entity is not new to adult nephrologists, but definitely not familiar to pediatric nephrologists, and that is protein energy wasting. Protein energy wasting, or PEW, is very different from PEM that we pediatricians are very familiar with. In PEM, you would have increased appetite. There could be fat which is lost, but muscle is usually not lost. And what we see is when we give nutrition supplementation, the child regains weight, and there's a good response to nutrition supplementation. In contrast, in PEW, what happens is there is a problem with appetite. The child could be anorexic. The patient will have fat may be variable, preserved or lost. Muscle wasting is seen, and usually just nutritional supplementation doesn't suffice. So this is PEW, and we have many factors that contribute to this entity. And this entity again has clinical adverse outcomes. So the proposed PEW criteria, most of these criteria are always adapted from adult criteria. And this is one example that the pediatric CKIT cohort group adapted from the ISN-RNM criteria of adults. But there's a difference. We have 5 criteria here. The biochemistry, in that CRP is included in the pediatric criteria, but in the adult criteria, there is no inflammation as a component included. In pediatrics, we have body mass, which is similar to the adults, reduced muscle mass through mid-arm circumference, similar to the adults. And in adults, you have dietary intake, but in children, we actually use appetite to reflect dietary intake. And the last, which is a very unique criteria for pediatrics, would be growth. So PW is further categorized based on severity as mild, standard, and modified. And modified would mean adding the short stature or growth. So this is one entity. Now in adult CKD patients, you do use SGA as a tool, as a valid tool. It is KDIGO recommends SGA as a valid tool to screen for PW. Now, not much is known about SGNA. In pediatrics, we call it SGNA because SGA is small for gestation age, so we don't want people to get confused with that. So it's the same thing. It's SGNA, which has 10 domains, 5 on the medical history, 7 on the medical history, and 3 on the physical examination. And we have studied this tool to screen for PW in children. So there's still a lot to be done in terms of studying this tool, and we are not yet there like in adults to recommend it as a valid tool. And overall, we rate the child as having malnutrition, moderate, severe, or the child is well nourished. The physical examination is something which we can all use in clinic at any level, hospital level, clinic level, community level. And I think it's important for us to recognize that the signs are very different for loss of subcutaneous fat versus muscle wasting. For example, loss of subcutaneous fat is looked at in the eyes, hollowing of the under the eye, or the biceps and triceps, the buttocks, or the ribs, the chest. And muscle wasting is looked at the clavicle, the shoulder, the scapula, and the calf, the knees, and the quadriceps. So we have studied physical signs of muscle wasting and subcutaneous loss as a screening tool for PW in children. Now we have, I have already stated that edema and fluid retention can come in the way of neutral assessment. And it's also important to know that it's not just the weight is made up of many compartments in the body. And that's where we come to body composition. So in body composition, you have fat mass, fat-free mass, and the fat-free mass is again constitutes the cellular tissue, the water part, the bone part. And the cellular tissue again consists of body cell mass, which is actually the most vital compartment of our body. That includes all living cells, the oxygen consuming, metabolically active part of the compartment. So bioimpedance can be used to look at total body water. DEXA is a reference tool for fat assessment and bone mineral content. For adiposity and fat assessment, we can also have other tools which are much more like bedside tools, like the air displacement plethysmography, DEXA, which is a reference tool, bioimpedance spectrometry. And to look at visceral versus subcutaneous adipose tissue, then we have imaging techniques like CT and MRI. So if, I'm sure many of you adult nephrologists would be using bioimpedance in your practice. And this is the usual parameters, list of parameters that comes out as an output in the bioimpedance analyzer. And if we take the resistance and the reactance, so there's a lot of physics here, and we are actually measuring the impedance. Impedance consists of resistance and reactance, and we plot this in an ellipse form. So here we have taken 50 normal kids and actually constructed reference ellipse forms. So what are we actually doing here? There are 4 quadrants if you see. There's overhydration, there's decreased body cell mass, there's dehydration, and there's increased body cell mass. So we know that tissue hydration is present, and bioimpedance analysis is not hydration independent. So it is confounded by tissue hydration. So whatever results you get may not be accurate, because bioimpedance does not take off the hydration part within the tissues. So there is a newer assessment which has stemmed from bioimpedance analysis called BIVA, bioimpedance vector analysis. And I'm sure many adult nephrologists are familiar with this. So we created BIVA. And the way we use BIVA now in clinic is the points are, the reactance and the resistance are plotted. This is the overhydration compartment. So any point which comes outside this ellipse would suggest overhydration. You dialyze the child, and then you see the next point could go here. And then you dialyze the child next, you could go here. So what is within this 50th centile or 75th centile is normal. So we tried tracking the hydration status alongside the nutrition status. So this is more valid than just using total body water or ECW, ICW in a bioimpedance analysis strip measurement. So why do we do this? We do this because we are trying to track and target dry weight. So we've spoken about dry weight. All of us, even adults, you want the dry weight. So how do you know what the dry weight is? We do a lot of assumptions in clinical practice, but we look at probably the symptoms that the patient is on dialysis and having symptoms of hypotension, and then you say, okay, this is I think the dry weight. But we don't want patients to go through that kind of symptomatology to assess dry weight. So BIVA can be used as a method to target dry weight. Going back to Sukanya.
Thank you, ma'am. So now we have taken you through how do you assess this patient based on the gaps in diet, the gaps in growth parameters, and biochemical parameters wherever necessary, and also additional tools like Dr. Arpana just mentioned. So now at the end of it, you should be able to identify the problem, evaluate the cause, whether it's poor diet, whether it's inadequate dialysis, or the protein energy wasting that you see with chronic kidney disease, or a combination of all of this. And with this, you determine the intervention and go ahead and give a diet prescription. So before that, you need to define what are your goals of treatment. So the nutritional goals should be to maintain adequate nutritional intake for the child's age and for any additional growth requirements that are needed. You should always look at promoting linear growth followed by supporting weight gain, and also at the same time ensuring appropriate biochemistry as much as possible in your child with chronic kidney disease based on the stage of CKD that they are in. So do we have targets? Do we have any references for this? Many of you might heard about it or might already be using these resources from the Pediatric Renal Nutrition Task Force. So this is a group of doctors and pediatric nephrologists and dietitians from across North America and Europe who have put together probably the best and the most used guidelines, nutritional guidelines for children with chronic kidney disease. And we closely follow that, and we as an Indian working group are now putting out guidelines and food guides for Indian children as well. So for them, the expected daily weight gain is, there are target weight gains for children who are up to 2 years of life from infancy, from neonatal period to 2 years of life. So the daily weight gain is roughly between 15 to 20 grams per day for a neonate who's premature, and it can be up to 4 to 9 grams per day for a child who's around 2 years of age. And we also define persistent growth failure as a persistently low height percentile of less than 3rd centile, and a height velocity which is below the 25th centile. If any of these persist beyond a period of 3 months in infants or 6 months in children and adolescents, then your child is suffering from persistent growth failure and absolutely needs a better nutritional prescription and a team effort from your nephrologist and the dietitian and the parents. So I know many of us in the audience are doctors today, and many of us do not give a diet prescription per se, we are not qualified in that area. So what I'm going to give today is an overall approach to how a diet prescription should be given to the patients. As I said, many of us do not have the luxury of having a pediatric renal nutrition or a renal nutrition in our system, and often the job comes to us. It falls on us to give at least a sort of a patched up nutrition prescription for our patients. So if you are in such a situation, this overview and these points should be definitely considered. The initial prescription for energy should approximately be that of a healthy child of the same chronological age. And if the child has a severe weight deficit, adjust the energy intake towards the higher end of the SDI. So the SDI is a term, so we have had many other values like the RDA and all that. So the SDI is the term that is used by the Pediatric Renal Nutrition Task Force. It is sort of an amalgamation of all these different terminologies, the daily dietary recommendation or the RDA, and everything put together is the SDI. And this is probably the best tool or the best term to use. So the energy intake should be adjusted towards the higher end of the SDI, and use height age when you're prescribing energy for all these children with poor growth, where the height is less than 3rd centile. For protein, target the protein to the upper end of the requirement for optimal growth for the child. And we do often struggle with children who have persistently high urea levels. So how do you prescribe protein for them? Keep the protein intake not lesser than the SDI, but towards the lower end of the SDI after excluding other causes of urea. Like poor feeding, poor energy itself can often cause a high urea due to increased catabolism. Always, even while reducing protein, ensure that there is adequate energy intake from other sources like carbohydrate and fats, and do not ever reduce the protein intake below the lower end of SDI, which is very unsafe. So these are the SDI values. You can look at these resources. I'll tell you where to look for it. And this is available right from birth till 17 years of age. And how you go about writing a diet prescription, especially in an infant, which are often the most difficult patients to handle. Always promote breastfeeding. And when breastfeeding is not possible, use express breast milk. So that is the dictum. At least till 6 months of age, breast milk is still the best diet that you can give to your child. And for some other reason, when you're not able to breastfeed or use express breast milk, always use a whey dominant infant formula. And when to fortify breastfeeds or infant formula, you often see us adding a few powders and few oils to these breast milk. So when to attempt that? Whenever your child requires fluid restriction, you might have to pack in a large amount of energy and protein within a small quantity of fluid. So think about fortifying the breastfeeds or infant formula. More energy dense feed, if you might need for meet the requirements, then always use fortification. And you can just use the infant formula per se to concentrate the feed. So the normal dilution for any infant formula is adding roughly 6 grams to 100 ml. You can slowly increase the powder that you're adding to the milk, and you can gradually go up to 20 grams to 100 ml, and that would sort of up to give 5 to 6 kilocalories per ml. So you can make it energy dense, but keep a watch for symptoms like diarrhea, gastroesophageal reflux, and also concentrating infant formula might give more of potassium and phosphate, which might be not the best thing that you want for your patients. And also sometimes fat soluble vitamins like vitamin A can be given in higher quantities, which is again can be detrimental to your patients. There are many glucose polymers and fat emulsions that are available, which can be added without any of the above said difficulties for the patient. And for bigger children, always look to fortify foods by adding vegetable margarines or oils to savory foods and adding sweets, jams, and sugar syrups to sweeten the food and also to increase the caloric intake, but with the same volume of food that you're going to give. I've given certain examples of high energy, low protein foods, which you might have to consider when your child has higher urea levels. So these are usually refined carbohydrates, candies, not chocolates, but candies. And also pastries and cakes can be used to increase the energy, but with a lesser protein. And also high protein foods, especially when you're dealing with a child with nephrotic syndrome, there'll be a lot of protein losses. You might not be exactly looking to restrict protein, rather you have to give more protein to these children. So dairy, egg, meat, fish, legumes, and lentils are all good sources of proteins. And also you might encounter GAR in many of your patients because of the disease per se. So look to use feed thickeners. Cornstarch is an excellent feed thickener that is readily available in everybody's kitchen. Antacids, H2 blockers, PPIs, all of these could help into better feeding for your child. And always look whether there's acidosis, volume overload, and inadequate dialysis interfering with your nutrition prescription. Quickly going on to what to do about calcium and phosphate, which again will impact the growth of the child. So calcium can come from diet, medications, or from dialysis. And again, calcium intake should be within the SDI or maximum up to twice the SDI, because some of these children can be hypocalcemic, but do not go to more than 2 times the SDI for a longer period. Use it only for a shorter period and maintain calcium and phosphate in the normal level. Always look at the vitamin D status before attempting to correct calcium, because unless you correct the vitamin D status, the calcium, whatever intervention you do, might not be enough. Again, dietary phosphate intake, you would want to limit it when the values are higher, and keep the dietary phosphate intake within the SDI as much as possible, and always limit phosphate from additives. So these are the biggest source of phosphate, which is readily bioavailable. You might have to use phosphate supplements for some children with persistent hypophosphatemia, especially in tubular disorders. And this is again the SDI values. Roughly, what are the dietary sources of calcium and phosphate? Most of them, milk products and cereals and fish, meat are all good sources of calcium and phosphate. A word about bioavailability of these methods, why we rely so much on medications. Not all of the calcium from foods are readily bioavailable. Breast milk has more bioavailable calcium, but infant formula has a higher concentration of calcium, so it offsets the comparison between breast milk and infant formula. Vegetables and cereals although they have good sources of calcium, they have lesser bioavailable calcium. It's because of the presence of oxalates and phytates. And again, the absorption depends on the vitamin D status. For phosphate especially, the most important thing is to consider whether your phosphate comes from natural sources or it's from additives in the food. The natural sources of phosphate are not readily bioavailable, but the inorganic phosphate from the additives are almost 100% bioavailable. So if you're looking to restrict phosphate, please cut down the additives first. And now invite Sheba. I've given you all the information, but how do you put it into practice? Right from the nutritional assessment and to the diet prescription. Sheba will take you briefly through how she does it in her clinic for her patients. We have 5 minutes. All right. Yeah, fine. So, so this is a template that is used at St. John's here, and it's been very useful for these patients. We might share it with you after the end of the meeting if you want. And in summary, nutrition influences growth in CKD like no other factor. It is the cheapest, it's the most readily available, and the most sustainable option for growth in our children. So our goal should be to promote linear growth, supporting weight gain, normalize biochemical parameters as much as possible and avoid complications. And also high energy controlled protein, ensuring adequate calcium, low phosphorus, and also reassessing often, and especially in infants, assess the need for an enteral feeding and introduce enteral feeding as early as possible. But the most important thing I think to take away from today's session would be to look for partners. Each of us individually, whether you're a nephrologist or a pediatric nephrologist or a dietitian, we individually are currently not adapted or enough to deal with nutritional challenges in our patients. So to look for partners in your own institution, doesn't matter if they're a general dietitian, they take care of adults also, or they take care of children or pediatrics and deal with children other than kidney disease. Look for partners, learn from each other, and go forward and make this better for our patients. So this is something, these are the nutritional resources that we use in our practice. This comes from the Pediatric Renal Nutrition Task Force. These are available in online. These are all free access. And also in the website below, you could find patient and caregiver and also healthcare professional guides for all of these modules. And please use these resources. Again, they are free of free access. Moving on, this is something that the work that our group has done. We have put together the food guide for managing currently the potassium intake for children eating an Indian diet. And we've also coming out and we'll be putting out guides, region specific guides. India is a very large country and we'll be coming out with further guides, not only for potassium, for phosphorus, energy, protein, and sodium in the near future. So look out for this. These are really comprehensive and they've been prepared by this excellent Indian working group, which consists of many pediatric nephrologists and many pediatric dietitians. And there's no dearth of talent here. It's just that we have to come together and work together. And thank you very much for the opportunity to speak today.
So Nancy is joining us online. Yes, please do while they're connected.
The next speaker is Dr. Nancy Sani, dietitian from PJ Chandika, who will be joining us virtually.
Hi, good morning, everyone. Should I share my screen? Good morning, everyone.
Yes,
Morning.
Yeah, I'm audible. So should I go ahead and share screen?
yeah.
Yeah, Dr. Nancy, please start with your session.
Can you see my presentation? No.
Yes, Dr. Nancy.
Yes, ma'am. We can see the presentation.
Yeah, can you see my? Okay, fine.
This is the.
Yeah. So I begin by thanking WinCon to have given me this opportunity to present a nutritional assessment in CKD. This is a topic I was given, and it is like, you know, after listening to Dr. Sukanya and all the speakers, like, such a overall picture they have presented in pediatric thing. So I'll be talking about the adults. Now, this the audience over here is quite known of this fact that the importance of assessing nutritional status in patients with CKD is unquestionable due to its known close relationship with hard outcomes at all stages of the disease. Since there is no universal marker of nutritional status, measurement of anthropometry, biochemistry, food consumption, and more recently, functional capacity parameters are widely recommended. Diagnosis of malnutrition requires that 2 or more of the following: insufficient energy intake, weight loss, loss of muscle mass, loss of fat mass, fluid accumulation, diminished functional status. Hence, the nutritional status is likely to be compromised if there is unintentional weight loss or fluid accumulation together with reduced food intake. And this is true in all the sectors, whether it is pediatrics or adults. So already it has been taken care of. Now I'll be talking in terms of the CKD recommendations of assessment of nutritional status 2010 versus 2020, and see what these what improvements or what the thought process has gone into it. Like talking about the nutritional assessment, it has been updated in 2020 guidelines as routine nutritional assessment, which was first as initial assessment and reassessment in 2010 guidelines. So this is a welcome change because in adults with CKD or post-transplantation, it is reasonable that a registered dietitian, nutritionist conducts a comprehensive nutritional assessment, including but not limited to appetite, history of disease intake, body weight and body mass index, biochemical data, anthropometric measurements, and nutrition-focused physical findings, at least within the first 90 days of starting dialysis, annually or when indicated by nutrition screening or provider referral. Now, if we again compare the guidelines, they have been updated on assessing the body weight, on assessment of body composition, the frequency of body weight, on which frequency the body weight should be measured, and methodologies for body composition assessment. So they have been updated and some new recommendations have been put. So I'll be talking on those. Now, body weight is a complicated measurement, as you all know, in CKD because of so many factors, edema or polycystic disease, amputation. So assessing anthropometrics for individuals with CKD, it involves monitoring anthropometric measurements like BMI, and if possible, skin fold measurements, waist circumference, and creatinine kinetics routinely, and to assess for changes. And these routines are like monthly for maintenance hemodialysis patients or peritoneal dialysis patients, and for stage 4 to 5 and post-transplant, at least 3 monthly, and for stage 1 to 3, at least 6 monthly. And the main focus is routine monitoring and watch for changes in usual body weight. Instead of ideal body weight or actual body weight or standard body weight, they have taken it as usual body weight the patient was having. Now, everybody is aware of the fact that why monitoring body weight alone is not sufficient for assessing changes in nutritional stores. Obviously, because the metabolic changes that occur with declining kidney function often result in altered appetite and changes in food intake. And due to this restricted or reduced intake, it results in fat and lean tissue loss, which is, if coupled with volume expansion and edema, may remain undetected. So body weight may remain stable in state of negative energy balance or undernutrition if edema develops. So there are statements on ideal body weight measurement, that what it should be. Now, the new guidelines 2020 suggest no best standard reference for ideal body weight and states that in adults with CKD 1 to 5D or post-transplant, it is reasonable for the dietitian to use clinical judgment to determine the method for measuring body weight, that is actual measured weight, history of weight changes, or any sudden changes in the body weight which are unintentional. They can indicate serious changes in health state. Serial weight measurement is very important. Adjustment for suspected impact of edema, ascites, or any other thing is important due to absence of standard reference norms. But they do not include that the dietitian may use other published weight norms in anthropometric assessment of individuals with CKD, like to compare them with the standards. Now, KDOQI 2010 mentions methodologies for body composition assessment, but did not mention statements on technical devices and anthropometric measurements to assess body composition. Now, if we see the 2010, it is suggested that the RD may use any valid measurement methodologies, like anthropometric, like waist circumference, body mass index, and body compartment estimates, and did not mention reference standards for assessing body composition in CKD patients, and stated that studies did not show that any one test is superior to another. In fact, it is true today also that it is difficult in a practical setup to say that okay, this test is a gold standard and this is not. Then basically it's a combination of all. In 2020, the bioelectrical impedance for patients on maintenance hemodialysis and dual energy X-ray absorptiometry for body composition assessment can be used to assess the body composition. Now, they have stated that in adults with CKD 5D on maintenance hemodialysis, use of bioelectrical impedance to assess body composition when available is suggested. And in adults with CKD 1 to 5D or post-transplantation, it is reasonable to use DEXA when feasible, as it remains the gold standard for measuring body composition, despite being influenced by volume states. So this is how we measure DEXA. This I can skip. Now, if we see the other parameters like, the assessing the biochemical parameters or, routine nutritional assessment. So everything has been updated and some new recommendations are there. And the new recommendations are the conicity index, the creatinine kinetics, and statement on hand grip strength, which, which can we can be attentive to. Now, if we talk about BMI and protein energy wasting in adults with CKD 1 to 5D or post-transplantation, BMI alone, of course, is not sufficient to establish a diagnosis of BEW unless the BMI is very low. If it is less than 18, then yes, it can be. Then skin fold thickness in absence of edema, using skin fold thickness measures to assess body fat is suggested. However, for the measurements to be useful to a practitioner, longitudinal assessment must be done. Then waist circumference may be used to assess abdominal obesity, but its reliability in assessing changes over time is low. Now, coming to the conicity index in adults with CKD 5D or maintenance hemodialysis, this index may be used to assess nutritional status and as a predictor of mortality. And creatinine kinetics, they may be used to estimate muscle mass, though very high or very low dietary intake of meat and or creatine supplements will influence accuracy of this measurement. Now, if we see this conicity index, this is a formula. So it can be used as a new index for of anthropometric measurement to assess central obesity, and which can be a predictor of mortality in hemodialysis patients. Then BMI, which might not be a reliable anthropometric measurement, as it indicates overall body fat distribution and muscle mass. If we talk about the creatinine index, studies in dialysis patients have repeatedly reported loss of muscle mass is strongly associated with an increased risk of mortality. And such simple screening tests are required for everyday clinical practice. And the routine samples obtained when peritoneal dialysis patients attend for assessment of peritoneal membrane function allow estimation of lean body mass by calculating the creatinine index. If we talk about serum creatinine and the creatinine index, individuals with low pre-dialysis or stabilized serum creatinine should be evaluated for protein energy malnutrition and wasting of skeletal muscles, and a low serum creatinine index, and in absence of substantial endogenous urinary creatinine clearance, a low serum creatinine concentration suggests low dietary protein intake or diminished skeletal muscles and are associated with increased mortality. So coming to the assessment with laboratory measurements, Biomarkers such as normalized protein catabolic rate, which Dr. Sukanya also talked about in kids, serum albumin and serum pre-albumin, if available, may be considered the good tools to assess nutritional status. However, they should not be interpreted in isolation to assess nutritional status, as they are influenced by many non-nutritional factors, as already mentioned by Dr. Sukanya. And in adults with CKD on maintenance hemodialysis, serum albumin may be used as a predictor of hospitalization and mortality, with lower levels associated with higher risk. Now, this is hand grip strength, which is measured using a calibrated grip dynamometer. Serially in an individual, it can detect a decrease in physical function and protein energy status when baseline data are available for comparison. So all this is summed up into this, that there's an emphasis on global or composite scores now, because we have to take care of the non-nutritional factors which influence all this. Then statements on serum albumin, it no longer specifies that albumin more than 4 or higher albumin levels are associated with better outcome and lower albumins are associated with higher mortality, and use albumin in combination with other assessment tools, not a standalone. Now, coming to the composite nutritional indices, these are all new in the 2020 guidelines, like 7-point subjective global assessment and malnutrition inflammation score. Now, if we see the SGA, which is a valid, assessor of nutritional status, it is practical, non-invasive, inexpensive composite tool that is widely used in clinical practice, and use of 7-point SGA is recommended as a reliable tool for assessing nutritional status. Now, if you see these points, like there is like these points: dietary intake past 2 weeks, and GI symptoms, functional status, disease state. So depletion of fat stores can easily be detected under the eyes and the upper arms. Fluid accumulation in the extremities or ascites can mask body mass loss if assessed by weight alone. Then this MIS, malnutrition inflammation score, again, you can see this. It has the following points: changes in the end dialysis, dry weight, dietary intake changes, GI changes, and all are scored accordingly. Functional capacity changes, comorbidities including number of years on dialysis. Then there's a physical examination, decreased fat stores or loss of subcutaneous fat, signs of muscle wasting. So all these are scored and summed up. 0 to 30 is a score, and sum of above 10 components is there in this. It is very, practical in the setups, in hospital setups. Now, some other new recommendations in nutritional status evaluation in 2020 guidelines are statements on tools or methods used to assess protein and caloric rate, considerations when assessing dietary intake, 3-day food records, and alternative methods of assessing dietary intake. So these are like what to consider when assessing dietary intake. It is reasonable to assess factors beyond dietary intake, like medication use, knowledge, beliefs, attitudes. Now, I had a full paper on this knowledge, beliefs, and attitudes, that food perceptions of chronic kidney disease adults, they listen so many things from so many people around them, from the patients, from whatnot, and they build up their perceptions about food, and the foods which are very important for them to have to improve their nutritional status, to improve their antioxidants, they are just scared of eating that. Like, for example, khatta nahi khana hai. They don't eat curd also. They don't eat pineapple and it is fruit which is like lower in potassium. So they have these norms. They stop adding the all the spices which are actually not harmful, like tamarind and all. So all these things. So
5 minutes.
okay. So then the next is the 3-day food records to assess the dietary intake. This is conducted during both dialysis and non-dialysis treatments as a preferred method. Then alternate method of assessing is 24-hour food recalls, food frequency questionnaire, and NPCR may be considered. And a new way of assessing nutritional status in HD patients, as Dr. Sukanya also mentioned, in adolescents HD patients, is to use the NCPR. NPCR. Now, the dietitian in the last talk mentioned the tools that can assist in estimation of portion size, and this is extremely important to have a correct nutritional intake. So we show the patients all these models and tell them to relate to one of them what they have, so that we can have an accurate intake. So all the cups and beakers and ladles, and they are then taught the measurements. And a more detailed account of frequency of consumption of specific, for example, if I am concerned about the phosphorus content or the calcium content, so I have to, point out those things in my the recall. Yeah. So to conclude, anthropometric measurements for assessment of body composition should be done routinely in patients with CKD, and these include skin fold measurements, waist circumference, and creatinine kinetics. BMI should be used routinely to assess weight status in patients with CKD because it is useful in predicting mortality. However, in isolation, BMI is not sufficient to establish a diagnosis of PEW unless it is very low. Although absolute body weight and BMI are useful indicators of nutrition status, percent change in usual body weight is very important. Dual energy X-ray, which is DEXA, is a direct method that is considered the gold standard for assessing body composition. And the guidelines for BIA and DEXA and skin fold measurements requires specialized equipment. However, because of the cost associated with some of these measures, there is insufficient evidence for the work group to suggest the use of these measurements on a routine basis in clinical practice. Measuring hand grip strength is simple. However, it is not routinely used in clinical practice. Routine nutritional screening for adults diagnosed with CKD stage 1, 5D should occur to allow for the identification and further assessment and treatment of nutritional concerns. A comprehensive nutritional assessment using a composite nutritional index should be conducted at the initial visit and completed whenever there is a suspicion of any change in health status. So, regardless of method selected to assess body composition, none are perfect and errors surrounding them should not be ignored. Errors may have clinical relevance, especially if the individual is treated and observed over time. Moreover, the results of the measures are only as useful as availability of suitable reference data from a group of persons of at least the same age, sex, race, and disease status. Thank you.
Thank you, speakers and chairperson. So we have 10 minutes for Q&A. Thank you, Nancy. May I call upon the previous speakers to come on to the base? A wonderful presentation to be. It was like walking the practice, regular practice, and the pediatric nutritional assessment team, basically Dr. Ratna and team. Not only went through the assessment techniques, but also went on to suggest recommendations, which was very comprehensive and useful for most of us in our everyday practice. So basically, I would suggest, that wherever there is pediatric renal patient population, a robust team, building a robust team would be the first thing I think to, tackle the whole situation. As nutritionists, when we train for assessments, train for counseling, and then train in the clinical background, certain things come first. I would like to share a few things that really, matter when it comes to the everyday practice. One thing is, as such, pediatric nutrition is challenging. It's a dynamic process as the child grows. But when it comes to a chronic disease underlying the pediatric nutritional requirement, it would be even more challenging. I'm sure everybody agrees with that. Compounded with that, what happens is once you know that these are the requirements and this is what the patient or the family as such has to do for the child, most practical problems that come through are that somehow the family feels that the child is deprived, frustrated, the family is frustrated. But then they tend to be very obliging parents and try to cover up all the other deficiencies during the disease process that the child is going through diet. So we often see that though they know that fast food with food additives are detrimental because the inorganic phosphates that come in the food chemicals are the ones that are most absorbed and most detrimental. And in the growing phase, the bone deformities we see are really bad. But even then, we see that the parents are very obliging when it comes to fast food, a bag of chips, and things like that. So, like this was one of the challenges I just wanted to share with the whole team over here. Ma'am, Dr.
Where is Arpana and the team? So we always see in your diet plans and assessment, you have a phosphorus pyramid, you have an acid-base pyramid. You don't have a potassium pyramid, no?
So now the reason, the potassium.
Is it because yours is all interstitial disease, potassium is not, or potassium should be found given in Kakura?
So many groups are actually working towards that to bring out potassium. But I think even in when we prepare the Indian renal food guide, we realize that most of our foodstuffs are high in potassium. Most of our foodstuffs, because we use a lot of vegetables, we use a lot of high potassium basin and all that, which are all high in potassium. So definitely, but potassium pyramid, I'm told it's in the making. So let's see.
Because if you look into your, especially the acid-base pyramid, and even in your phosphorus pyramid, the areas where you put a message that these are all greens are actually very high on potassium.
Yeah. Yeah, so it's always a balance. It's never it's not an easy task at all. So you are not only looking at phosphate for a patient, you're not only looking at protein for a patient, you're actually looking at so many factors. And
You
picking
should
out
have
the
a
right
pyramid kind of a thing that is green, and then you go to the
I would like to add.
Practically, like myself, so one thing I have seen, because we were bound to see many children as pediatric nephrology was not well developed in public sector in Kolkata. At least when I was doing my student life, then it was not there. So what we had seen repeatedly, that children are quite more tolerant to the potassium level. Suppose an obstructive nephropathy child comes with a potassium of 7.5, yet not manifests the clinical signs of the tissue hyperkalemia. So it was quite usual that the alarm we used to take with an adult 50-year-old male, that alarm was not that strong with the children. So I can't remember whether I had read it somewhere, but in practice I have seen that they are more tolerant to potassium.
in units and infants and
Driving them of all food is a difficult thing.
Per se, we do not recommend potassium restriction for anyone unless you have hyperkalemia. Potassium restriction does not fit into our diet plan as a rule. So that is something we all of us should understand. I think, and we have seen it many times with the same observation with Dr. So we do think that the children slightly are more tolerant to the hyperkalemia, a level of 6 or 6.5 wouldn't alarm us too much, as you could see. That's what we tend to take measures to reduce it, but yes, we do see that as a quite okay.
Yeah, and to give the full benefit, I think we have, if we can do it some hyperkalemia medications. We can continue if we allow the nutrition.
Yeah, sometimes to enable better nutrition, we do design the binders.
I have another question with the permission of the House.
Okay,
The PCM that we use, is there any way we can use a body composition monitor and have calculations for a vector analysis? We work from those parameters. It's advertised. I know Arpana is very interested in Viva, but I think Viva needs to move beyond the slides to critical practice.
I think it also needs a bit more measurements and.
Madam, can I answer the
Yeah. How do we take Viva into our clinical practice?
We are, especially now we was in HKPs.
So before dialysis and after dialysis.
No, but what equipments, what infrastructure you need for all units to have a
So
base?
it's a simple, small equipments we can carry over anywhere. And it's a small box size. Actually, you don't have to. Madam, can I answer my questions? We don't really need any complicated equipment for Viva. What we need is the regular bioimpedance analyzer. Any multi-frequency
or whatever.
any multi-frequency bioimpedance analyzer will give. What we want is basically what is the resistance at 50 hertz and what is the reactance at 50 hertz. There's a very simple formula with which actually we can convert which is a vector. What we need is basically a graph paper. This inputs at 50 hertz. It's not literally plotting the resistance and reactance. We have to like sort of.
Do we have a sort of a software to help us to do that?
There is a software, but even without the software, it can be done. It can be done in our day-to-day practice.
So the next nutrition seminar should have that.
I think actually in the previous seminar itself, I addressed, but probably Viva is a new concept, so you will not able which studies. Maybe sometime in the future, we can have one session on vector analysis.
If I can put in, at our unit, what we are doing objective nutritional assessment. So it's a subjective HGA scoring. We do bioelectrical impedance and we put everything together. So you have a historical view, you have a biochemical view, you have an SGA. So it's not one parameter which is going to be telling you what is the nutritional status of this patient. It is a composite parameter of malnutrition, inflammation, which is going to tell you how your patient is doing. So we have to put all this, and these machines are quite simple. So if we can place a machine in the dialysis unit and have the residents who are rounding in the dialysis unit do simple SDAs, it is quite helpful. In fact, we have a paper on objective nutrition assessment which is describing that.
I think what is also essential is we all do it in our own way, in our own institution and tend to get, see whether that's enough or not. You have to come together and because nutrition as such is not being concentrated and put together in a big way or in a uniform way across our country. And that needs to definitely.
Actually, Dr. Anita Saxena madam was doing it. Unfortunately, she was part of our team. We lost her very unfortunately. I think someone of you have to take this forward. Priyambada is very interested. She wants to take it forward and no, we definitely is doing bits and pieces, but we want somebody who.
We have regional nutrition for MSc dietitians also. We have on nephrologists and
Last 2 minutes.
that at every subdivision have to have a renal nutrition course going.
Yeah, so because we realize that this is a huge impact on our patient, and that's the reason we are now for the pediatric patient will come up with the Indian which is combining dietitians and pediatric pathologists. So we are one of the problem with solution. So I'm just we pool together our common talent pool we have that it's able to really come together. It's not and it's going to take a longer time to have some people who are persistently working towards
Natural doctors.
Thank you.
Can I answer one small question? Doing the technology sector, actually attached to the hospital where, but I was also my colleague. And I headed the department of laboratory director. As a pathologist, what I want to know is whether histology does it throw any light on your assessment of nutrition and dietary practice, or you based on biological parameters. So histology comes a long way in taking the etiology of the chronic kidney disease, and etiology sort of impacts how much growth impairment is needed. So that is where for now we would take the idea of histology. But otherwise, many patients when they progress to chronic disease, this histology stops mapping and it is all the complications that we see as chronic. Yeah, when it comes to end stage renal disease, the complications and other biochemical alterations are more common for all these. I think we'll move on to the next session.
Yeah, thank you all the speakers and thank you speaker and the chairpersons. Moving on to our next scientific program. The topic is transition of care at 18 years. I would like to invite on stage the chairperson, Dr. Susan Uttam, additional professor and head pediatric nephrology, Trivandrum Medical College, Dr. Vishwanath Siddhini, head of department and consultant department of nephrology, Manipal Hospitals, Bangalore, Dr. Nagmani, consultant nephrologist, Davangere. I request the chairperson to introduce the speakers and moderators.
It is indeed a great privilege to be given an opportunity to be on the stage by the WinCon. And I congratulate the WinCon organizers for this great mammoth effort, and the topics which are chosen are so apt. And moving on from nutrition assessment to transitional care at 18 years. And we all know that there is a lot of progress that has happened in the recent years in the pediatric nephrology, so that children are growing, they are passing through adolescent time, and it is time to give them to the adult care. And actually, are we equipped and are we doing it in a justified manner? One referral letter, is it enough? Lot of discussions and lot of work has to go on in this subject. A hand-holding has to happen, and an intermediate team, whether it is required for transitional care, and a coordinated effort so that the child who is growing to be an adolescent and adult and young adult, are they getting enough care, the tender loving care that is given from the pediatrician and the pediatric nephrologist? Once they reach the adult side, are they getting lost, and what we can do about it? So for this important topic, we have got Dr. Edwin Fernando. He is the professor of nephrology, Stanley Medical College. He is already there on the virtual platform. And I invite Dr. Priyamada, professor of nephrology, Jigmar, Dr. Priya Payas, professor and head of pediatric nephrology, St. John's Medical College, Bangalore, and Dr. Anuradha, consultant nephrologist from Hyderabad, to enlighten us on this pertinent topic.
Susan, for that introduction, and good morning to all at Bangalore. I thank the WinCon team for including me in this important deliberation. I shall be sharing a few PowerPoint slides. Let me share.
Maximize the screen, sir. Sir, can you maximize the screen?
Sir, should we share the PowerPoint from our end?
Can you see it now?
Sir, can you maximize the screen?
Yeah, 1 minute. Can you see it now?
Sir, no, sir,
You're not able to see?
not full screen.
Can you see the next slide now?
It's not moving, sir.
Can you see it now?
Yes. It's moving, sir. Yes, sir.
Okay, shall we start?
Yes, sir.
Okay, so thank you all, and this is a very important topic both for the pediatricians as well as the adults dealing with children who transit care. So I have named this Caring for the Blooming Buds. And what is transition? Transition was defined in 1993 as a purposeful, planned process that addresses the medical, psychosocial, and educational, vocational needs of the adolescents with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare system. So it is actually a handoff. So the providers of primary or subspecialty care to young people with special healthcare needs should be able to understand the rationale for transition from child-oriented to adult-oriented healthcare, have knowledge and skills to facilitate that process, know if, how, and when transfer of care is indicated. So I have 3 very prominent nephrologists in the panel, Dr. Priyambada, Dr. Priya Pais, and Dr. Anuradha, to whom I shall be addressing a few questions. I shall address a common question to all 3. So who are all the stakeholders involved in this process? We'll start with Priyambada.
So the stakeholders involved, of course, it starts from the pediatric nephrology services. The pediatric nephrologist should have a license with the adult nephrologist to ensure that the transition of care is quite smooth. And
Yes.
now it's not just a job of the medical professional alone. We need actually a lot of supportive staff in the form of nurses who are attached to the pediatric services who make the transition a smooth process. And at the adult end also, we should have sufficient nurses, psychologists, and counselors who are there to take care of the patient needs.
Right. Dr. Priya, your thoughts on that?
Thank you, sir. So as a pediatric nephrologist, the 3 primary stakeholders are, of course, the patient. In India, we include the family with the patient, as opposed to many Western countries where they actively exclude the parents at the time of transition. So it's the patient and their family, the pediatric nephrologist, and the adult nephrologist, and as I was mentioning, also the importance of social workers and nursing staff who ensure
Right.
that there is continuity of
Right. Dr. Anuradha, your thoughts on this?
And we would also include visiting specialists sometimes, because these children will be requiring care of access, they would be requiring access, they would be requiring dialysis. So we would also involve the transplant surgeons, because they would be working up with life transplant, transplants, and vocational training is also very important. So as already mentioned by Madam, that social support, social workers and support group and educationists, they're also to be a part of this transition process.
Okay, so shall we say that the process of healthcare of the transition involves the patient, the family, the healthcare provider, the healthcare system, and the community. So it's a sort of shared responsibility between all these 3, because if any one of these links fail, then the transition is not going to be smooth. So with this, I go on to the next question. Dr. Priyambada will take this. When do you think the process of transition of care should begin? Dr. Priyambada.
As Susan ma'am told, the transition should not be just on a slip of paper. It has to be a planned process and it has to start sufficiently early. So especially in India, there is a peculiar problem when it comes to transition. So what defines pediatric care and what defines adult care? That is actually a gray zone in India, because in many places, 12 or 14 is the maximum age where the pediatricians are going to take care of the patient. And technically, adult physicians are okay with people more than 18, but where do this 14 to 18 people go? That's a big issue. So, and it is highly unlikely that in the near future we will have some instances. For example, when I started my practice around 12 years back, in my own hospital, 14 was the cutoff. And subsequently, what happened was the administration changed the rules that pediatrics can see up to 18 in OPD, but admission is limited only to 14. So this actually puts up in a little bit of a tricky zone. So ideally, the transition should start sufficiently early, because if we recapitulate our teenage years, that's a time when actually we are struggling with a lot of things. Even if we don't have any disease, we are all happy adolescents. That is a time when actually we are going through a sort of identity crisis. And they have a lot to deal with on their plate, and on top of that, they have this additional burden of the disease. So the transition should happen sometime early, well before actually they are struggling with the adolescence woes. So probably if the hospital system insists that the pediatricians cannot see patients about 12 years of age, I would say it should start at least 1 or 2 years early. And if it is actually a little more smoother, like 18 is the cutoff age, probably you can keep it somewhere around 12 to 14, so that we have ample years ahead. But the pediatric nephrologist and adult nephrologist can work together to ensure a smooth transition. And also, it is not that at the age of 18, the responsibility of the pediatric nephrologist gets over. Even though they are legally an adult, they can cast their vote in election. Studies have shown that the mental development continues into the early second decade also. So probably it could be anywhere from 10 to 12 years, and it can go up to say 23 or 25 years. So whatever it is, the most important thing is it has to be gradual and it has to be planned.
Right. So in a country like ours, where the care is primarily under the personal, what shall I say, the personal care of a physician. So our patients are very specific about seeing Dr. X or Dr. Y or Dr. Z. Though we all work as teams in many hospitals, but still there are patients, especially in the corporate setup, who would come and say that I want to meet this particular doctor. So one fine day, you just say you have reached an adult stage, and then I make you drop you into the next man's clinic. The patient and the family are not going to feel comfortable. So this process has to happen over a period of time, as you rightly mentioned. But we need to have some flexibility also, because nephrotic syndrome transition is different from a transplant patient getting transited. And especially when patients get into the adolescent age group, where they become a little belligerent, they have impulsive behavior, etc. So probably 12 to 14 years would be ideal. And also, when they go to 17 or when they go to college, they get busier with their personal lives. And sometimes transition happens until the age of 24 to 26. We'll move on to the next question. Dr. Priya, what goes through your mind while planning transition? What are your thoughts on this?
When planning transition, I have two questions in my mind. The first is related to the patient and their family. And that question is, are they ready? And there are tools to assess readiness. There are guidelines that were brought out in 2011 to highlight whether a patient is ready. But then simply put, it boils down to whether the adolescent is aware of the disease that they have, the medications that they take, danger signs of an emergency, what to do, how to make an appointment, very practical things like that. The second is whether the family is ready to actually move from one physician to the next, as you were mentioning, sir. Some families are very attached to a particular physician. And if the very thought of changing physician brings a lot of fear. And so if, like ma'am said, if we do this gradually, then the patient is really more prepared. The second question that comes to my mind is whether we as pediatric nephrologists have prepared the patient and family. And in this, as you were mentioning, the difference between transition, which is a very planned gradual process, is different from transfer. And I think unfortunately, what happens sometimes is transfer. The ideal situation would be a patient has gone through months, if not years of transition, where the transition is very smooth and the follow-up and outcomes are good. Sometimes, unfortunately, patients who are poor with follow-up, say for example, a patient who's, last seen at the age of 17, now presents a year and a half later, because of the constraints of hospital rules, etc., shows up, we have no choice but to then send them to the adult specialist. That's a transfer and that's not ideal. So is the patient and family ready? And have I prepared the patient and family for transition?
So the questions that one should probably a checklist: are they ready? Are they going to cope well? Will they be able to fulfill their dreams and life goals? And these are feelings like similar to one encounters when dropping off their child at school or college. So it's very important that as pediatric nephrologists, you make sure that this is the right age. Fine, I have to counsel them regarding this transition and then start the process. I'll move on to the next question. This is to Dr. Priya again. What is the young patient's perception of the transfer and its timing? What goes through the patient's mind?
So I would say that if we had to look at data, we actually have very limited amounts of data and we need to look at this more to actually find out what goes through their mind objectively. If in our experience, many adolescents, we see that change in their development from a child to an actual young adult, where they open the door, they come in first, they sit down, they answer the question, they know their medications. So those children, we can see those adolescents are getting ready. If we ask them, many of them actually are happy at the thought of not sitting among a bunch of screaming toddlers. Those patients are probably again on the path to readiness and would be happier in an adult focused setting. There is definitely a perception, I feel, of concern and fear because among the pediatric nephrology world, there are fewer patients, as you all know. Tends to be a larger team, and there tends to be a lot of looking at the parents for the serious answers instead of the patient adolescent themselves. And so this shift onto the adolescent, when they're ready, we can see that they accept it. When they're not ready, there's a lot of fear on both the family and the patient side. And so the perceptions may vary. It is our job to assess really what the unspoken feelings are about transition. And it takes time for us to assess this as well, which is why transition often takes weeks and it requires continuity. If it's a different person seeing the patient each time, which may happen in a busy group practice, we don't actually get to know that patient's inner workings very well. And so continuity of care helps in developing this perception.
Thank you, Priya. So it is also important that we acknowledge the patient's perception. So here, they looked at a scale survey called the Likert Scale Survey in Lurie's Hospital in Chicago. So many patients learn to transition to adult care earlier because once the child grows up, if they find it very difficult to sit in a pediatric waiting room and care settings. They feel that they are being treated as a child. So they prefer to have isolated adult waiting rooms that are calmer than the pediatric waiting rooms where there's a lot of noise, children playing around, crying, etc. So acknowledging the psychosocial experience of adolescents and young adults in a pediatric environment may lead to consideration of earlier transition. The other point that I just wanted to make here was, do they have a say? I feel that they should have a say in the timing of transfer. So this was again a study published in 2020 in BMC Nephrology, where how many patients had a say in the timing of my transfer. So nearly about 40% said they agreed, and there was about 20% of them who did not really agree at the timing of transfer. So not in the timing. They say they had an option or they had an opinion that okay, this is the time that I can get transferred. So this I think has to be again given importance because once they become adolescents, they would like to take their own decisions at times. So the next question to Dr. Anuradha, where to transfer care? Because not all centers would have, because pediatric nephrology centers are very limited. But then in a city like Hyderabad, for example, where would you be comfortable to transfer care? What parameters would you consider before transferring care?
So as this, what really is happening in a city like Hyderabad, I mean, most of the places in India, as such, transition clinics or transition care is still in its, I can't even say infancy, it is not yet really started, frankly speaking. So way to transfer the care directly to the adult clinic, it is very detrimental to the adolescent, young adolescent. But I think there should be something like an adolescent clinic or young adult clinics where you refer them, and then a team of doctors like pediatricians, trained adult nephrologists who are trained in treating kidney diseases in young children. So, and then at the same time, sisters from two teams as well as, I mean, adult nephrology and pediatric nephrology. They can engage together and continue to deliver the care to the young adolescent and social workers. I mean, there will be at least some adolescent clinic. If at all, if not exactly transition clinic, there should be a clinic where there is at least some few visits. We cannot say that it can continue for months and years, at least 3-4 visits. If there is some kind of a clinic where both stakeholders, pediatricians as well as adult nephrologists are seeing multiple times, and then giving confidence to the patient's family, giving confidence to the young adult, then I think it would be better. But right now, it is not the scenario directly discharging writing medication. We're just looking into the medical part of it. We are not just looking the kid as a, we are not just we are not giving a holistic approach to the young adolescent. We are not looking into his psychological status. We are not looking into his educational condition. We are not training him for the vocational, future vocational things. So right now, I can say that it is still in the nascent stage, but at least we can try a midway where we have an adolescent clinics where both the stakeholders and both the these are there, and these children especially have multiple problems, not just they may have neurological issues, they may have ongoing problems with nutrition. So everyone should be involved in these things, and transition should be made very smoothly, rather than making it adult center directly, where the entire information, comprehensive information is not passed on.
Thank you, Dr. Anuradha. So the young adults and their family should also have a major role, and they should have an opportunity to choose a program that's convenient geographically. So because in large cities like, let's say, Chennai or Hyderabad or Bangalore, we're transiting from one center to another center or going, we always try to choose a center that is convenient for travel. So, and also somebody goes to college. So that's something very practical and logistic. So the center should also, when you're choosing a center, this also should be a major factor. Coming back to Priyamada. So what do you think is the emotional status of a young patient undergoing transition?
In a simple word, many of them are confused. What I have seen is by the time they are 16 or 18, that is a usual age transition happens in our institution. Many of them are happy that actually they are moving away from the pediatric clinic. But at the same time, many of them are not actually receptive enough to deal with how we deal patients in an adult clinic. I always feel the pediatric side is a little more warmer. The pediatrician's approach to patients is a little more warmer, and probably a little bit of parenting nature also might be there, where it is actually very difficult to expect the same thing. We tend to consider this, we as adult nephrologists, we tend to consider this pupil as adults, and probably that is not really what these children expect. And family also is going to be an integral part of the transition of care in India.
And by the time they are 16 or 18, many children want to take decisions for themselves. And so most of the time, the family probably, they feel that the parents are taking a little bit of undue interest. And even that parental conflicts between the parent and the child is also sometimes very obvious in
very
the adult OPD. So they want to move to adult OPD, that is what I feel. But they have not been prepared enough. Probably it's a problem of our system. They have not been prepared enough to expect or to receive what they are going to get in the adult OPD. That is my primary feeling.
So basically, it's a mixed feeling of sadness because you've been used to a particular team, a long-standing relationship, and then the anxiety of getting into a newer setup. So, Dr. Priya, what are the core elements of transition?
So if I were to try and summarize it, the first would be to prepare the patient and family. And so the assessment of whether they are ready or not that I mentioned before must be done. The adherence of the patient has to be reasonably good. Otherwise, it's going to be a disaster when they shift to the adult nephrology world. So it is our responsibility as pediatric nephrologists to work on the adherence part. We also need to work on the awareness of the disease and consequences in the longer term and address unasked questions that the families, especially the parents, may have. This involves a lot of reproductive questions which we pediatricians are not comfortable answering, but actually is there. Because when they move to the adult world, these are questions that the patient themselves should be comfortable to ask. So the patient should be made comfortable to ask questions on their own. From the point of view of the pediatric nephrologists, we have to prepare them, but when the transition time occurs, we have to be first willing to let go. We can't go on seeing them forever. We have to prepare a good enough handover sheet or letter that will give the adult nephrologist enough information about the patient, because these days children with diseases who did not survive into adolescence earlier are surviving more and more. So adult nephrologists may not be familiar with some of the diseases that we see when they come to the adult world. Examples are cystinosis, primary hyperoxaluria. These are not familiar diseases for patients reaching adulthood. The third responsibility of the pediatric nephrologist is to actually ensure that transition takes place. So I think this is where we have to step up, and maybe in an institution like ours, we're fortunate. We have a supportive adult nephrology team, and we just have to take the patient across the hallway and show them where the clinic is. But it may not be so simple in places where the adult services are in a different part of the city. And some creative thinking, I think, is needed to ensure that the patient moves and reaches the other side of the transition spectrum. And lastly, the needs from the adult nephrologists that I believe are really a willingness to accept that patients at the age of 17, 18 are not like other adults. We know now, data has shown that adolescence extends from about 14 to the early 20s. And so the acceptance that this group is different, they may not be as responsible as a 35-year-old, for example, and the willingness to work with younger people as maybe an adolescent clinic may not be feasible, though it's definitely ideal, but maybe somebody who is, likes this group of patients. Maybe somebody who could identify themselves as the transition physician would be an excellent core element to incorporate into the transition world. I don't think much of this exists, but we definitely need to grow this. So elements from the patient side, the pediatrician side, and the adult nephrology side also.
According to some authors, this is how the 6 core elements of transition work. First, you develop a policy, and then you assess the readiness. Then you transfer the care. Then there is transition completion, and then it is also important to track and monitor everything is okay. So I'm sure the patients would also be giving a feedback to the pediatric nephrologist that they are okay, they are getting used to this adult clinic. plus a letter or regular communication from the adult side to the pediatrician that everything seems to be fine. So the next question to Dr. Anuradha, what are the steps that you think is important in this transition?
Pre-planning stage, we can go to pre-transition phase, and that is the phase where we try to explain about the transition process around 12 to 14 years of age for children with the chronic diseases, and we give a written policy to them. We give a written policy stating that you may be requiring transition for a longer period of time. I mean, you in the future you will be referred to an adult care center. So we are going to address few issues. So this is the pre-planning stage, and coming to the transition phase. Here we involve the adult nephrologist, pediatric nephrologist, and finally social workers, support of social workers, and other supporting system. We take this and we assess the child on periodic basis. Both the pediatric nephrology team and adult nephrology team assess the patient regularly, and the involvement of transition champions, though it is not there, but this is ideal. The role of transition champions and the role of transition coordinators, those who do these steps of coordinating transition. So these people's involvement is very much important. And again, every time there should be a checklist. And we should make the young adolescent ready for the transition. So every time we should check the list, and if there is some problem, again we have to address the problem and again tell them come for the next session where these problems can be solved or these problems can be addressed. And later, finally, it is the transfer stage wherein we are transferring the care to the adult centers. So, and there we hand over complete comprehensive information to the adult center where the adult nephrologist is dealing with this young adolescent, and later the pediatric team has to go and again recheck, reconfirm that whether the child has, the adolescent has been incorporated into adult care, and we have to get back the feedback.
Right. So it's important to dispel the fear of the unknown. First step is to smooth transitions to help the young patient understand the disease and medications and have a private communication with the adolescent. Then once the fear of the unknown disappears, it can lead to emergence of more responsible and independent behavior. Dr. Priya, what is the role of a pediatric nephrologist in transition? I know that you have a major role. So what what do you think?
In previous questions, I think it is our responsibility primarily to ensure that transition occurs. And so all the steps have to be, whether it is preparing the patient, preparing the family, assessing formally, preparing the handover, identifying an appropriate adult nephrologist who may be a good fit for this patient, whether it is the center, it may be an issue of distance. All these factors, other than medical, also it is really our job to look into. Finances is another big one, where these patients, we have to make sure that they have the finances to continue receiving treatment at whatever center that they are going to be transitioned to. And then lastly, our role as a transition, the person who is responsible for the transition is to ensure that the transition has happened, and to also inform the adult nephrologists, other than the medical issues, what are the key social demographic issues, and to follow up with the patient, maybe for a few months at least, to ensure that the patient is able to receive the care that they need. So it's really pretty much boils down to a lot of work on our part. But I think as our numbers of few, it is very much worth the effort to ensure good outcomes for our patients.
So a very important thing is to also prepare a proper transfer summary that includes all the relevant medical, psychosocial, nutrition information.
Right.
Train the young individual to self-report and prepare the young adult as a lead person during the medical interview, and encourage the family members also to attend the transfer clinic and get accustomed to the new team. And this is an example of a history and a transition letter that was sent to me by a pediatric nephrologist. Priyamada, what are the challenges and the role of the adult healthcare provider? I think you're the appropriate person to answer this. Hello?
Yeah.
Priyamada? Yeah.
So we encounter quite a lot of challenges as the young adults transition to the adult nephrology service. So the first and foremost, as Dr. Priya and Dr. Anujata told, the adult nephrologist has to realize that we are not dealing with a full-grown adult, even though on paper they are adult, but the mental development probably is actually different from a child, but they are not adult yet. So we need to have a listening ear to this sort of people, and probably they will have to be dealt in a different way. And as these kids are adults, young adults are challenging to the adult nephrologist, transitioning to a service also might be challenging to this adolescents as well. So it's the job of the adult nephrologist to ensure that sufficient support is staff, especially a social worker or some psychologists, some clinical psychologists who can actually offer some help to the patient should be attached to the practice. And the needs of the patients transitioning in a glomerular disease clinic, needs of the patient transitioning in a transplant clinic, and the need of the patient transitioning to CKD clinic, they are going to be totally different. So probably we should have an individualized approach rather than a protocol-based approach for this children. And what I have seen is that drug non-compliance is going to be a major problem. Whatever be the native disease, let it be glomerular disease, CKD, or transplant, non-compliance is going to be a major issue. And sometimes as adult nephrologists, we feel the reason why they tell for non-compliance is quite silly. Like I get pimples on face when I start on steroids. For us, it is silly. But for an adult, young adult, it is going to be a part of their identity. And we have to understand that what goes to their mind is going to be somewhat different. And we should not actually generalize them as older adults. And these are the people who need special attention. And the adult nephrologist who receives this young adult, he or she should be mentally ready to put some more extra effort, some more extra time for this young adolescent's transition.
Okay, one is getting all the relevant records. That is very important. And there are pediatric specific kidney disease, like something like cystinosis, etc., which some of us may not be really oriented in treating. And some of us trained in a predominantly adult center may not have been, we may not have all the expertise in managing these childhood disorders. And adult care provider needs focused training on adolescent health care, develop tolerance toward high-risk behavior and immaturity in the young. And this is another survey, the same thing that I mentioned, the roles of an adult care providers before transition. So nearly 50% of them strongly agreed that they understood the role, while a small percentage disagreed that they could not really understand their role. So Priya, what is the role of the parents in facilitating this smooth transition?
I think this is where we have to adapt our transition protocols to settings where we work in. And the literature on transition is very much from the Western high-income country world, where the role of the parent is to step back and step out of the room. And actually they are excluded from healthcare appointments subsequently, because legally the patient after attaining the age of 18 is not required to have a parent there. In India, definitely, I'm sure you're all aware, even in adult nephrology clinics, patients come with their families. Now, the role of the parents, they have to be ready to accept that they will go from being the primary decision makers, the people who drive all the decisions and who also take all the responsibility, to allowing the adolescent to play a more active, independent role. At the same time, not abandoning the patient to their own devices. And I don't think in my experience, our parents have any intention of abandoning their children when it comes physically. But sometimes they maybe, especially when the children are more educated than the parents. And we see this a lot in our setting, where the children are actually the first in their generation and in their family to achieve a higher education. And so the parents are actually a little bit intimidated because the child can read the medicines. At least they think that they are independent and they put all the responsibility on them a little too early. And we often have to actually take them off, the parents, for saying that you cannot expect an adolescent just because they know the medicines to also be responsible for taking them. And so the role of the parents in India is to very much try and increase their awareness of the disease along with the patient, continue to support them, and also to accompany them to appointments, because I think that would actually improve the outcomes of the adolescent, because having that family support will be an answer.
Thank you, Priya. So parents should be willing to let the patient go and take over their responsibilities. Sometimes parents are very much attached to the children, and once they become adolescents, these children would like to be on their own. Specific training for the parents is also required. Anuradha, what could go wrong during transition? I know many things could go wrong, but what according to you are the areas that we should concentrate?
So adolescence is a period where they have a complex issues going on, environmentally, socially, psychologically, and there is a massive hormonal outburst in this patient, I mean in this young adolescent. So at multiple levels, things can go wrong. At young adolescent level, I can say that at the adolescent level, at parents level, at stakeholders levels, we can classify them like this for our convenience. So at the patient level, the patient may be on drugs and he may have a negative body image. He may have a negative body image. He may not be, adherent to the drugs which he is supposed to take regularly to prevent the progression of the disease. And they are psychologically also more depressed when we have taken multiple studies, I mean, which are done in foreign countries like NHS FSGS study, where they thought that the quality of life depression scores were very very less in these children with diseases, pediatric diseases. So their self-esteem and peer pressure would be there in these patients. So
Why not select for the discussion?
They may not take drugs, and patient level at parents level, the patient is not letting go the adolescent to take the onus and take the responsibility. Their things can go wrong, and finally at the stakeholders levels, yeah, especially adult nephrologists, I would say that they are not trained, or in fact, not the correct that it is better that we have exchange programs between adults and pediatricians, where we can where adult nephrologists can equip more knowledge about the kidney diseases in children, and similarly in adult pediatric nephrologists also, since they are associated for a longer period of time, even they unconsciously would not like to let the patient go from their care sometimes. So these are the places where things can go wrong.
Okay. Thank you, Anuradha. One major problem, non-adherence one. Increased morbidity and medical problems like graft loss post-transplant due to non-adherence and loss to follow. Dr. Priyamada, what are the main barriers to smooth transition?
So I think actually we have covered part of this in the previous question. So one is actually system related. So if the patient is transitioning in the same center, not many centers will have a pediatric and adult nephrology service, and still availability, and not every center will have electronic medical records which is accessible to all. So basically capturing all the events that has developed in the last 10 or 15 years when the patient is under the pediatric care, and actually transferring it to the adult nephrologist, that is going to be a major problem. Then the second issue is actually individual related. The approach of the pediatricians and the approach of the adult nephrologists are going to be totally different. Patients' expectations might be different, the family's expectations might be different. The family might expect the adult nephrologist to incorporate their suggestions and their decisions over and above the patient. Probably that might not be feasible in certain situations. So these are what I believe to be the major barriers which prevents a smooth transition.
Okay, thank you, Priyamada. So mainly it is the hesitancy to change the provider, concern about building new relationships, and lack of financial support for transition. Dr. Priya, what are the challenges of transition in children with CKD and after transplant?
Thank you, sir, for highlighting that this is a special group.
Yeah.
So children with CKD and after kidney transplant are again few in number, but this is a very high stake situation. If the transition goes wrong, the outcomes are graft loss, which has been shown very clearly in the literature that if there is a poor transition process, graft loss is highest shortly after transition. And the second, in patients with CKD or ESRD, if the transition process doesn't go smoothly, the outcome would actually be patient death. And we have actually experienced this, unfortunately. So the challenges of transition in this special group of patients is that patients with CKD, whether they have had a transplant or not yet, is that they have a cognitive delay. And this is not so well known, but in the pediatric literature is well described. So if you have a patient who's 16, 17, 18, mentally really they are much younger. They tend to have that little delay in cognition that definitely improves after transplant, but takes a little bit of time. So not only are they medically complex, taking a lot of medication, perhaps on dialysis with special needs, on transplant immunosuppressants, but they're also not quite ready, perhaps, for that transition when compared to, say, an adolescent with nephrotic syndrome or distal RTA, who basically mentally is the age, same age as their chronological age. I think one of the main challenges is adherence, and it's adherence to immunosuppressants, it's adherence to a complex medication regimen. In children with CKD, they are also on the same type of treatments of all the comorbidities of CKD. It's adherence to dietary restrictions, which children especially find very difficult. Adherence is interfered with because of peer pressure and the immense mental stress and distress that adolescents experience when they look different from their peers. So what is very clearly got up by now that a physical difference in appearance sometimes is viewed as not important or silly in the adult world, whereas for the adolescent, it is all important. And so the reasons for non-adherence are maybe financial, but a lot of it has to do with the fact that adolescents are impulsive, they take risks, and they don't understand future risks. And so I think pediatric nephrologists and adult nephrologists need to accept that this is a special group, overcome our differences in how we work. For this particular group of patients, take extra pains.
I'd like to have a quick word from all three of you on this concept. First, Dr. Anuradha, then Priyambada and Priya. What is the role of the dedicated transition clinic? Do you think it's something practical that we should do? Dr. Anuradha, then Priyambada, and then.
The main purpose of having this dedicated transition clinic is empowering the young adolescent to take care of himself, and he should be able to manage his medical illness along with not just medical illness in entirety, multiple factors like education, vocational training, and mental health. All these things also have to be addressed. So it is a whole, wholesome process, rather than just inflation only towards the medical health care. At the same time, we should make him autonomous. He should not be dependent, finally. He should be able to take his own decision with supervision.
Dedicated transition clinics should be there, and as we know, the transition care in India is at a very primordial stage, but this is the way forward. So the number of nephrologists are increasing, the number of pediatric nephrologist services are increasing. So we are actually going to have more hands in the future, and at some point we have to register in our mind that quantity is not important, but quality is also equally or more important. So to provide quality care, transition clinics are to be there, and it has to be the norm in the future. Ma'am, it's time to wind. We have exceeded the.
Yeah. Transition programs are resource intensive, so one has to keep in mind. This is a visual abstract showing the impact of a pediatric to adult nephrology transition clinics it can be successfully facilitated with collaboration between teams educated on and engaged in the process. So nearly a 71% of successful transition has been seen in this particular study. So there are some guidelines of transition adult care from the IPNA, NICE, as well as the AAP. And there's been a consensus statement by the ISN and the IPNA. So it's a combination of the pediatric unit, the young person, and the adult unit. We need a psychosocial team, the transition coordinator, transfer clinics, specialist nurses, etc. And this would be something like a flow chart that you discuss and then plan, then incorporate the adult provider. Then you have a transition clinic, follow up, and then the transfer of care. So let me sum up and say transition from pediatric to adult renal services is a highly stressful period for young people and their parents. Generally associated with poor medical outcomes, decreased medication adherence, and increased avoidable hospitalization. Those with transplant added risk of acute rejection and graft loss. Structured multidisciplinary transition programs and targeted interventions may lead to improved outcomes. And what is required is a well-planned, timely, structured transition program should be considered both by the pediatric and the adult healthcare services for facilitating the care of young people with CKD for moving on to the adult care system. And all interested parties must make for the best handoff possible and run with the ball. So let's strive to make the handoff smooth. So with this, let me thank all the panelists for their very patient answers. We had a discussion over WhatsApp a few weeks back on the questions that you would take. I thank all of them for the cooperation. I thank the WinCon team for organizing this very important topic. And thank you, Susan, and I hand it over to you for your final comments.
Thank you, Dr. Edwin. It was wonderfully moderated, and thanks to all the speakers. It's a difficult transition always from pediatric nephrology to the adult nephrology. Sometimes the child and the parents may feel lost because they will be very close to the pediatric nephrologist, as mentioned by all the speakers. They will be very close to the team, and they go to a new team, and they should not be felt lost. And as mentioned by Dr. Edwin, it's not a simple letter which is behind over probably the communication directly from the pediatric nephrologist to the adult nephrologist. It makes a lot of difference. I'm a pediatrician and I practice adult nephrology. So most of my pediatric nephrologists, they call me saying what are the problems, because the list can be huge, and most of the pediatric nephrology patients have a lot of other obstructive symptoms, bladder issues. They may need neurology inputs and of course transplant. So it may not be very easy. We should all make sure they're not feeling lost in the shuffle, and some handholding is definitely needed. I'm told there is 5 minutes for discussion and questions. Please go ahead.
Let me, Dr. Priya, do you have a transition clinic at your center?
So that's just now we started a pilot, sir. And it's a day and a space, and it's a concept. So we're trying different things, and I'm actually looking forward to discussing with the adult nephrology team to identify maybe like an adolescent champion among them. Our adult nephrologists are very receptive to our patients coming. I think to assess the readiness and use the tools that we've been talking about so much is really what we're trying to pilot in us.
So very fruitful discussion has been taken place. There's one popular saying, change is always constant in life. For a changing scenario, for anybody to adjust, especially for the patient suffering from a chronic illness like HIV, CKD, high emotional resilience is needed. It's like, a girl moving soon after marriage, moving from her parents' place to the house, in-laws household, where she has to assume a much larger responsible role. Forgetting all, it's in contrast to the role, what should have been like, what should have led in her parents' house. Definitely, in the pediatric, I feel, because as a pediatrician and a pediatric nephrologist, the way we address our patients who are with us for a very long time, like we were addressing them, Gucci, Bagara, Sona, all these things you can't imagine addressing the adults. So they're very close to us. Definitely for this transition to happen in a smooth manner, I think this clinics, transition care clinics definitely play a big role. And I think it's the need of the hour, especially for the institutes where the patient load is high. Thank you.
Questions?
Inviting questions, and let us have a little more discussion.
Just a comment from my side. It was very nice listening to this very important topic on transition. I work in a place where we don't have pediatric nephrologists. So as I was going through all the discussion and all the comments made by the panelists, many thoughts are coming to my mind. Things are that we are talking about transition of the patient, the people who want the transition. But for us, at my place, we the doctors and nephrologists, we have to keep on transitioning ourselves many times as a pediatric nephrologist and also as a geriatric nephrologist. Because we are seeing patients right from the newborn who have renal illness to the geriatric population. So yeah, I think this is very new concept for me. Looking forward to having more pediatric nephrologists so that we can smoothen this transition process in all the places where we look after the nephrologists. So much, dear members, dear panelists, and moderator Dr. Edwin, Dr. Priya Patsana, Dr. Priyanka ma'am, Dr. Vijayanath sir, Dr. Anuradha ma'am. And we have debates in the exhibition area, but the sessions will continue. So you can just have your tea or high tea and coffee and get back. But the sessions will continue. Thank you.
Thank you all. Thank you, Susan. Thank you, Vishwanath. Thank you.
Thank you, everyone. So let's proceed to the next program without delay. So next is the debate. The topic is should women recipients should be given extra points in disease donor transplantation. And to chair the session, I would like to call upon Dr. Ganesh Mogal, Head of Department Nephrology, IMS Hooghly, Dr. Sharmila Thukral, Consultant Nephrologist, Narayana Super Specialty Hospital, Kolkata, Dr. Anil Kumar Beatty, Consultant Nephrologist, Transplant Physician, EGS Hospital, Bangalore, Dr. Lovi Gaur, Consultant Nephrologist, Max Super Specialty Hospital, Vaishali. And I invite the chairpersons to introduce the speakers.
Good morning, everybody. And I would like to invite Dr. Divya Singh, Consultant Nephrologist and Transplant Physician at Rand International Hospital, Nepal. And also Dr. Mayuri Trivedi, Head of Department of Nephrology at Lokmanya Tilak Municipal General Hospital, Mumbai. And in the against panel is Dr. Vidya Bajpai, which is who is the additional prof, JS State Medical College, KEM. So now we'd like to start the debate.
Good morning, everybody. So do I start?
Yeah. All right. Good morning, everybody. And I hope I'm audible and the slides are visible.
Yes, ma'am.
Yes. All right. Thank you. So I'm going to begin by thanking, obviously, the organizers of this beautiful conference for giving me this opportunity. And actually, I'm going to express a little bit of an extra gratitude to them for giving me the pro of this debate, because I have been going mad since the last 2 months since I'm preparing this as to what is Divya actually going to speak against. And believe me, I am really intrigued to know what her argument against this point would be. So best of luck, Divya, and we get on with this debate. So essentially, the outline of my debate is going to be discussing the gender disparity at various levels in kidney disease, in the population, in transplant, and then coming to the actual point as to what we are debating today, that should women recipients be given extra points in the transplant wait list. So I came across this very elegant quote when I was making my debate, which said that there's no such thing as a woman who doesn't work. They are just women who aren't paid for her work. And this was by a very well-known women activist called Caroline Perez, who is known for her recent most book, Invisible Women. And for all the Bibelophiles there, I'm sure you would have come across this book. And this made so much of sense to me when I had to do it vis-a-vis this debate. So when we come to the actual problem of gender disparity, let's just leave aside kidney diseases and transplants and nephrology. Let's just talk about gender disparity to begin with. Whenever we see through the recorded human history, and when we come and try and explore it with the eyes of a woman, you see that the only thing you get is a data gap, because the entire human history is recorded only, it starts and ends with man the hunter, with very little space that's left for a woman in the evolution of humanity. Whether you say biologically, whether you say socially, whether you say culturally, it's always been the man, the hunter, and the data that surrounds the man. And the lives of these men are considered to represent the overall humanity. So essentially, women are left with extrapolated data, extrapolated events, and an extrapolated identity as far as anywhere in science goes. So essentially, we are the other half of humanity, but all we get is silence. Now, the gender data gap is not just about the silence. It's not the silence that gets me aghast. This silence has consequences which are additive over time. This silence impacts a woman's health, and living in a world which is extrapolated with male data is dangerous to a woman's health. And believe me, when I sit here and debate about this topic, I am not a feminist. I am not screaming here about down with men and this is injustice. I do not say that this is deliberate. I don't think our male counterparts actually sit down and think about this being deliberate. It's just not about thinking. It's just about taking us for granted. It's just about taking the entire womanhood for granted. And men get away without offering because they are not thinking about it. And we are left behind because we do not demand. This is essentially what gender disparity is all about today in 2023. If we have to come down to our topic, that is gender disparity in kidney diseases, I know I'm preaching the converted. All of us sitting here as nephrologists know that globally kidney diseases are more common in women, and the gender disparity exists in all aspects of kidney health, whether it comes to diagnosis, whether it comes to epidemiology, whether it comes to access to care, or whether it comes to outcomes. The difference is glaring. And we should not forget that pregnancy is a physiological process that all women go through, and all of us sitting here, including Divya, my opponent, advocates pregnancy and pregnancy-related diseases loudly. This is an additional burden on the kidney health of women, which is not given the due importance that it should. We obviously have a less access to kidney care and dialysis. There is enough data which shares this. And we have to remember that with less access, women have a higher mortality. And as the kidney function declines, mortality increases in women because of various causes.
So we have a greater burden of disease, lesser access to care with a poorer outcome when it comes to kidney disease. Now, if we had to actually, come down to access to care in kidney disease, which is the topic today, donor transplantation, globally, more women with CKD compared to men, we already know that, yet women have only 40% of, compromise 40% of the population who actually receives some form of kidney replacement therapy. We have late referrals and delayed initiation of dialysis, which is more common in women. Even the awareness of CKD is much lower in women, and they have a much lesser chance of being offered transplantation as a therapy, as a renal replacement therapy. One of the glaring reasons that most authors think is, as women, our personality is, we are less likely to take charge of our health issues and more likely to deprioritize it vis-a-vis centrality of family care. Everything is focused on the family or the provider as compared to self. If we had to see where India stands, 70% of patients in India today who undergo dialysis are men. This data is from 2020. Delhi, Maharashtra and Uttarakhand are the three topmost states with maximum number of women on dialysis. Still, the numbers don't cross beyond 50%. Odisha, Madhya Pradesh and Andhra Pradesh have the least number of women on dialysis today. When we come to the outcomes in kidney disease, women who initiate dialysis under the age of 45 have a higher mortality as compared to men of the same age-matched men. Younger women who initiate dialysis are at a higher risk of a cardiovascular event as compared to the age-matched men of the same age. Hemoglobin concentration is significantly lower in women despite requiring higher doses of ESAs and a significantly better KT by V. We still have hemoglobins which are lesser in women. They demonstrate a higher incidence of fractures as compared to men after dialysis. However, strangely, if we had to talk about the positive part of treatment outcomes, women demonstrate a significantly greater odds of being more adherent to treatment, being more compliant to treatment as compared to men. Now, you will understand why I am putting this line in this slide is because we are talking of transplants, and compliance and adherence is something that is of importance to any patient who undergoes a transplant, and women are more positive about transplants with a greater compliance towards therapy, greater gratefulness towards this therapy as compared to men. Now, when we come to organ donation, we are all aware out of every 10 organ donors, 6 are women. In India, women constitute 2/3 of the living donors, wherein they receive a transplant only 1/3 of the time. There is a less likelihood of women, including in our countries, to be registered on the national transplant waiting list. There is a longer time from initiation of dialysis to listing and from the listing to actually getting the organ. However, the long-term graft and patient survival, as seen in this graph on the right side, is either equal or much better in women as time goes. So the outcomes are better or at least are equal to what the male counterpart would actually have. So essentially, we know that organs are gender neutral, but organ donation seems to have an obvious gender here. And this is the global picture. Gender disparity in organ donation obviously seems to be favoring the men here. So this is me discussing the gender disparity that is present. Now let's come to where India stands. So this is data from central institutes like AIMS and from NOTO, where 80% of organ donors across the country were women, with only 20% being organ recipients. Most common donors in our country are wives and mothers, with only 10% of spousal donors being husbands. So this is data up to 2015. I am sure beyond this, the data still continues to remain the same. Now, what are the possible causes of gender disparity in organ donation? First, a woman has a commitment to give care. This is the personality that a woman has, and there's a lot of data which says that they like to coordinate care, they like to take charge, they deprioritize their own health, with centrality of family always playing a very important factor in decision making. So if I had to explain to you with an example, if we have a lady who comes to us with ESRD, most of the times, if you tell them that you need to get a fistula done, they are going to tell you, my daughter is in the 10th, let the exam get over. My son is getting married, let that get over. So they have this whole concept of the family being in the center before making any decision, as compared to a man who would be a little more positive about his health. Coordinating care, taking charge, you would always, I mean, I'm sure all of us you would agree that usually the caretaker is a lady who seems to be knowing everything about the male patient. Very rarely do we see it the other way around. Next, we have this whole, I don't know whether it's a good quality or bad, but women are more self-reliant. They have more of diligence, stoicism. They would rather tolerate their symptoms. They want to cope with things alone. They do not want to become a burden on the family. Stereotyping and stigma, the more I speak about it, the more I realize that it is such an under-addressed topic, and we have it in our country as well as globally. The decisional power and ownership in our society as well as abroad is usually male dominated, with an analytical nature which is always pro the man against the lady. And of course, with all of this, these existing inequities are compounded by obvious social disadvantages, maybe more in the lower socioeconomic society, where finances, transport barriers, literacy, a greater vulnerability of women, and obviously all of this with the entrenched discrimination, which still remains a very large part of our society. And why do you think this disparity actually occurs? If we had to break it down into smaller points, the male, or if I could rightly call them the alpha male, is considered to be the bread earner or the provider of the family. So he is essentially the Amitabh Bachchan of the family, and it is the truth. He is the provider of the family more often than not. The lady is unfortunately being given the role of a nurturer, a sustainer, a giver of life. She is somebody who is supposed to give. So if I had to say, culturally, she is the mother of the family and she's supposed to give. If I need to be more relevant in today's time, she's not the Ma, she's the Anupama of the family who has to give all the time. And the social compulsions where you have to safeguard the provider, who's more often than not the male, the emotional compulsions where the women would always want to give more often than not give, and the male has the nature of clinging to control, the sense of entitlement that most men, I would be fair to my male counterparts and say not all, but most men have this self-regard and sense of entitlement and the power to cling to control, even for the simple reason that they are so-called the providers of the family. Now, coming to the actual debate, should women recipients be given extra points in the transplant waitlist? My opinion here, and I'm sure, I hope that most of you there would say a big yes. Yes, women recipients should be given extra points in the transplant waitlist. The reason being, nobody is being favored here. We're not asking for special treatment. It's just the return of favors which have already been done over centuries, over years, over days. Women have been the major donors, and today is the time where you need to return the favor back. Because one good turn always deserves another. We have already given. We are already in the credit. So now is the time that we are asking for our rights back. And if this argument does not appease to you, there's data, and plenty of data that favors that there is inequitable access to transplant and a gross disparity. So if we give 2 points, it isn't that we're giving them special treatment. We are just helping this disparity set right marginally. Maybe at least they start at the same point, and then the battle beyond that is equal for both the males and the females. Also, it might be a promise to the entire womankind to protect their future kidney health. So if I, as a lady, want to donate to my loved one, at least somewhere at the back of my mind, I might feel that, yes, I'm going to get extra points sometime. And for all that you know, by giving extra points to women, the males are still at the receiving end, because this is going to boost altruistic and emotional donations, which in socialism we call as reciprocal altruism. You know that you're going to be taken care for, you are going to be more confident about giving. So also, it will encourage women as patients and their caretakers to come forward and seek transplantations as a mean for therapy, because these few extra points might boost their confidence in coming and asking for this and for us to offer it to them. This is essentially no special treatment. It is just an attempt to narrow the gap to access to treatment that exists today. Now, understand one thing. Again, I repeat myself. Is it equivalent to asking for reservation? Is this equivalent to asking for reserved seats in the bus or the train? Is it special treatment? No, this is not. Because reservation, by definition, is setting aside something specially. So if I come here on this forum and say that every kidney that comes in needs to go to a woman, or every alternate kidney that comes needs to go to a woman, that is asking for reservation. Reservation is meant for a minority or for an underrepresented or an underprivileged. This is not reservation. This is just returning back the favor. This is our right. This is like going and negotiating for your pay scale with a corporate. This is the amount of work I have done. I have to be paid so much. This is equivalent to that. We have donated all this time. Today, we need to have equitable access to a kidney. So please, 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 it does not discriminate against the male patient. It just calls for equal representation of their women counterparts. And at no point of this debate, please think that this is equivalent to me being a feminist or me being a social activist. And, this is bra-burning feminism with, me being a difficult woman. Because as Jane Goodall said, it actually doesn't take too much to be considered a difficult woman. That's why there are so many of us. This is just an attempt to narrow the gap that exists so that the man and the woman can start at the same point for their battle to access to an organ. Now, if this did not convince you, I'm going to share some unpublished data that I have from one of my very dear friends from IKDRC, Dr. Shubho Banerjee. This is unpublished data. They are in the process of publishing this data where IKDRC started giving 2 extra points to women since 2020. So from the end of 2019 is where they started giving 2 extra points. And here, as we see on the screen, women who were 27.6% of the recipients of organs has boosted their numbers to 58.9% in 2023. And we have still not even gotten over 2023. We are still in 2023. So we can call this a pilot project, but we know that this works. So I'm going to end my debate by giving these few take-home points, which says that gender disparity is seen in all phases of kidney transplantation. Female recipients have comparable patient and kidney graft outcomes as their male counterparts. They comprise a majority of living kidney donors, while males make up a majority of the recipients. And if we say that we want to advance kidney transplantation as a science, we need to stop thinking man and woman, and we need to bridge the gap that is causing the gender disparity. Policies which govern organ procurement, allocation, and transplantation are needed to safeguard an equitable access for men and women. And if that means that women recipients should be given a few extra points in the deceased donor transplantation program, so be it. But let's be equal rather than one above the other. I'm going to end my talk with this quote which says, "Here's to strong women. May we know them, may we be them, and may we raise them." Thank you so much for a patient hearing.
My slides will have how do the slides come? Yeah.
Hello, everyone. A very good morning to all, and a big thank you to the organizers of INICON, Urmila Madam, Manjusha Ma'am, and my dear friend Maitri for letting me take this interesting debate, take part in this interesting debate, and especially get this side of the debate on talking about why women should not get extra points in deceased donor kidney transplant. So when I got
sorry, can I interrupt you, Divya? I can't see your slides.
Oh.
Your screen is I'm not able to see you or the slides.
Oh, can we help?
Somebody help us,
Media
please.
Tech team. Oh, I'll have to share that screen. Yeah. So when I got this mail of the topic and of the debate, my first reaction was fear. I was scared. I was scared of two things. First is that this is WinIcon. This is a women-only conference. And seemingly, at least on the face of it, the topic looks a little bit against women. And also, secondly, because I am against Dr. Mayuri Trivedi. She's a feisty young woman, and we all know her for her strong views, and she is a very good debater. Yeah. So, but then I realized when I looked deep into the topic that when I'll be putting forward my part, all the women present here are rational and sorted enough to understand that what I'm saying is not actually against women, and it's actually for women in the long run. And also, the more I researched into the topic, the more relaxed I became, because I know that the truth is on my side. So I'm going to win. So Dr. Mayuri Trivedi started with doubting for 2 months. She was thinking that what I'll be actually putting forth. So I'll be putting not 1, 2, 3. I'll be giving her and the honorable jury 9 reasons why it will be unfair to give extra points to women in organ allocation. My first argument, which is actually my strongest one, is that 2 wrongs don't make a right. I have a young daughter, and 1 week back, she brought a doll from her friend, only because 1 month back, her friend had snatched her doll and she took it away from her. So my daughter's friend did a wrong thing, and my daughter reciprocated by snatching her doll. So 2 wrongs do not make a right. And this is exactly what we are doing when we are trying to give extra points to women in organ allocation. It is a fact, I am not here to debate this, that there is a definite gender disparity against women, not only in transplant, but in complete kidney care or kidney health. I have not made any slides on this topic because I was very, very confident that Dr. Mayuri Trivedi madam will make thorough, detailed literature review on the topic, and which she has already done. So it is a fact, I am not denying that from cradle to grave, women are actually at a disadvantage. They are at a disparity in getting kidney care at various stages, may be it acute kidney injury, chronic kidney disease, transplant, dialysis, everywhere. But that is a wrong. But giving extra points only in organ donation is a very, very small baby step, which will not correct that wrong. Rather, that will cause a false sense of security in everyone's mind. So actually, if you want to correct that wrong, if my opponent is really, really worried about women's health, then they should start from where the problem actually is. The problem is at every single step, like I discussed, from cradle to grave. So there is a need for an urgent intervention at every step. And the best management of CKD, as we all know, this is a very elite gathering, is prevention, and we should not let these women progress to transplant and then think of giving them a candy or a lollipop with 2 points on organ donation allocation system. That is completely flawed. So we should try our best at every single stage to prevent them from progressing to chronic kidney disease. And once they progress to chronic kidney disease, we should be utilizing all our resources to actually promote live donation, which has definitely proven, scientifically proven, better outcomes as compared to disease donation. So we should be advocating for them getting more of live kidney rather than again giving them a candy of 2 points. Second, as I was coming to this, that this will definitely create a sense of false security, not only amongst us, also amongst us, but specifically and more harmfully among the healthcare policymakers. The policymakers are anyway trying to find an easy path, and they want to take a path which will give them more fame with least amount of efforts. And this is exactly that. Only by giving 2 extra points, they might claim that they have gained complete control over this gender disparity, which has been there since ages in all the process of kidney care, which is completely wrong. Now, I want to really ask everyone present here that this is the comprehensive system in which we give points. Dr. Trivedi showed the data from IKDRC. I had seen that data. We discussed that data in detail on the executive committee of ISOT, where Dr. Shubho Banerjee and Dr. Kutte is also there. So that their system also has 13 points. This system has 7 points. Out of the 13 points, where points are ranging from as high as 5 to 6, adding only 2 points for gender is not going to make much of a difference. If someone is believing that only adding 2 points for gender to an already 13-point system has taken the percentage of transplants from 26 to 58.7%, that percent is completely naive or completely wrong. So it will definitely give a false sense of security. It is not going to make much of a big difference. And what it will give is a good excuse to all the politicians, all the policymakers present there, when they will sit back and not do anything to actually improve the healthcare at the ground level and only write 2 points extra on the piece of paper, which I am sure none of us here wants, including Dr. Trivedi. Also, not only the healthcare professional and policymakers, this might even give an excuse to the family members of women recipients, when they might feel that if women are, if we spread this word, like it was being spread, that Gujarat is now giving it. If we spread this word, all the common public comes to know that women are getting prioritized for transplant. They will not understand how much, how little, or how more. They will just have this feeling that they're getting prioritized, and this might actually make the male members of the family donate even less. They might say, you just register for transplant. You are going to get extra point in transplant. Why you want my kidney? So then they will again, this will actually broaden the disparity which is already existing. And we are definitely not debating here that why living kidney is better than a cadaver kidney. At least in our country, where cadaver kidney handling and even the surgical procedures are still not up to the mark. So this might, there is a chance that this step might even reduce the number of living kidney donations for our women in our country, and it can be more detrimental than it already is. My fourth argument is that this complete idea of giving gender-based allocation points is against the ethical principles of organ allocation. We have evolved in the field of transplant over last 50 to 60 years, and we have come to where we are today after taking into consideration a very fine balance of these 3 ethical principles, which is utility, which tells about maximizing the benefit for every single transplant. Then it is equity, which tells that we should give equal opportunity to everyone who's in the pool, and justice, in which we should prioritize those with the greatest need. And as you will see, these 3 principles do not always go hand in hand. They have sometimes, most of the times, conflicting interest. And with lots of efforts, we have created a sort of a balance between these 3-4 conflicting factors. And if we keep on adding things which are not ethically correct, this complete balance will topple and fall. So just a quick view, we all know what we do. What UNOS do is they have actually made a very big change in last 5 to 6 years from their original CAST system, which is kidney allocation system, to their now EPTS system, where they actually estimate post-transplant survival score, which is the score which tells us how long a candidate is likely to live if he or she gets the kidney. And then it is matched with the kidney score. So EPTS is patient, KDPI is kidney, which tells us how long a kidney can last if it is put into a new body. And then they come to a sweet point where they give kidneys, the better kidney, longer lasting kidney to better candidates, longer lasting candidates, the marginal kidney to those who are not able to, or unfortunately might not survive much longer. So this is the process in which we justify the ethical allocation of kidney. And here there is no role of any gender-based allocation. This is very clear. It is for male, it is for female. You have your EPTS, you have your KDPI, and you get a kidney. Now, Dr. Trivedi showed some slides on increased incidence of chronic kidney disease in women. The data is still conflicting on that. Most of the literature, yes, shows that there is increased kidney disease in women, but I searched many journals from IJN, everyone says that it is more in men, at least in Indian literature. There might be this problem of less detection in women in India, so I am not quoting those slides. But one thing which I'll definitely quote is that even if we, for a second, we accept that it is more in women, which is still not clear, there is conflicting data. The kidney disease progression is definitely, there is no conflict about that, is more in men as compared to women, because women are protected by their estrogen. God probably is a female and she has made protective hormones for, in our body, and harmful hormones in men. And then we are protected from progression. We are protected from cardiovascular complications, at least till we achieve menopause. And also we in general have a healthier lifestyle. No offense to the men present in the jury. So it is proven that kidney function decline is faster in men. Mortality is highest in men in pre-dialysis CKD. This is from a review article in Nature's Review of Nephrology. And as you can see, the blue is male, the red or a pink is female, and there is higher mortality after adjusting for all the factors, including age and other comorbidities. Also, there is this paper suggests that after their extensive review, they found that the incidence in women can be falsely high only because they're living longer. And once they live longer, once they reach some age, after that old age, you start getting false CKD diagnosis only because you're considering a eGFR cutoff. So because of the eGFR based definition cutoff, there might be a chance, this is what this paper says from Nature, that it is actually a chance that incidence can be higher. So even if the incidence is higher, people are more sicker, men are more sicker, and they might be in more need of kidney. That's why I would propose that we should actually think of who's more sicker, who's the most needy, where the kidney will work best, and who is there for the longest time in the waiting line. These are the three things which we should be focusing on while we are trying to allocate such a scarce organ like a kidney, which can change life in so many ways. So if we add gender to it, it will change from justice, utility, and equity to injustice, inequity, and inefficiency. This thing actually I got to know very recently. If there is a theory which says that if you give a male kidney to a female recipient, males have this particular minor histocompatibility antigen known as HY antigen. It is a somatic antigen. Not only, there are various HY antigens. Some comes from Y chromosome, some comes from various other somatic chromosomes like 6, 13, and 12. These things can cause a problem in a female recipient because of a minor histocompatibility reaction. These grafts are at higher risk of loss because of either rejection or chronic allograft nephropathy, which has been proven in some studies. Most of them are retrospective, I agree, but this is something which we should be looking at if we are proposing such a system where we all know most of the cadaver donors are male. If you want more females to get cadaver kidney and not actually go for a live kidney, which is better, but if you want to stick to this, you should be looking at this very, very carefully. There are studies which show that graft loss was more common in kidneys from female donors than those which were coming from male donors to female recipients. More data, same thing. Short-term loss at the time of at 1 year, they had a higher hazard ratio of graft failure going back to dialysis when a female recipient is getting a kidney from a male. Not very proven. I am not saying this is written in stone, but something to be looked at if we are looking forward to putting such things in our guidelines. Again, similar data. This is a larger study where you can see this red bars. They are male to female. The other color bars are everything else, and uniformly you see death, redialysis, rejection. Everything is higher when a female receives a male kidney. And we know, I went back after seeing this, I went back to my data from KEM Hospital. We have done around 120 cadaveric transplant till date, and 78% of my donors were cadavers, were male cadaver donors. And then I checked with data from, thankfully, Dr. Srijit Parmeshwaran gave his JIPMER data. In his data also, 72% of donors from cadaver were male donors. So we have no doubt most of the cadavers are male donors. Actually, the disparity gets settled there only. You have more female donors in the live donor. You have more male donors in the cadaver donor. So that actually answers that question there only, but still we are looking at more important things here. Now, my next argument to support this is that, what about the risk of exploitation? Now tell me, when I was given this question, there was nothing mentioned that women based on what? Women based on gender or women based on biological sex? These are two completely different things. Gender is a social construct, sex is a biological construct. If you are saying that it's only because of sex, then all those women who are actually socially women will be disadvantaged because they are also at a disparity. And if you are calculating everyone, if you're even taking those women who are biologically men but would like to identify themselves as women, then how can you prove or how can you make sure that this will not be exploited? What I would like to ask Dr. Trivedi, that what is the guarantee that tomorrow if men would try to identify themselves as women only to get points, if she's saying that adding 2 points is causing a 26 to 58% increase in the donation, then if I'm a man and I read this tomorrow, I would like to say that now from tomorrow onwards I will be a woman. I will identify myself as woman and now give me points because I'm at disparity. So there is a risk of exploitation and it's not as easy as it sounds. And this needs to be thought through. For how long? Our country is the one who knows that these kind of privileges can go for infinity. I really don't understand Dr. Trivedi's argument that why she feels that this is not a sort of reservation. You are reserving some part of the whole system for women. So for how long you will keep on doing that? Till eternity? She started with saying that we have been done wrong and now it's our turn to get back. So for how many years? For 10 years, 20 years? When will be the time when we all will be equal? So there is no answer to that, and it is never a long-term solution to this kind of a problem. It's a short-term appeasement policy which is created only by policymakers, and we should not fall into that trap. As proponents of women's health, we should keep our eyes, ear, mind open and not fall into the trap of getting this short-term appeasement policy. What about the post-transplant care? I agree with Dr. Trivedi when she said that women are more adherent to medications, but then that is not all. If we are starting from the argument that women has less access to kidney care, and then you give her a kidney, and then she needs a very close, lifelong access to kidney care to make sure that the kidney, which is a very scarce organ, which is a gift of life given to someone for which thousands of people were standing in the queue, she has got it. It is the whole society's responsibility that that kidney lives for long. Are we ready for that? And the day we become ready for that, there'll be no extra point needed for any women because that will solve the problem in itself. So it should not only transplant. We as nephrologists know very well that the transplant is the starting of the story and not the end of the story. We have to be prepared for a long-term post-transplant care. Till the time we are ready for that for each and every woman, we should not be thinking about this. Lastly, I would like to say that look at the bigger picture. She showed Amitabh Bachchan and Anupama. Amitabh Bachchan is almost the sole earning member of his also family. I was happy when actually Amitabh Bachchan came. I was thinking of what example to give. So it is true even till date, unfortunately, that there are stereotypical roles given to women and given to men. Men are the breadwinners, women are the nurturers, like correctly showed by Mayuri madam. So once, if we are saving or if we are giving kidney to a breadwinner, we are also protecting other women's or improving the quality of life of other women in his household. His mother, his daughter, his brother, his sisters, and other women relatives of his. is our society ready in which women are as empowered and financially independent to take care of the whole family, even when the male earning member doesn't get a kidney and remains on dialysis? That is my question. And I feel that it should be like that. I feel maybe 10 years down the line, I would like to remove this slide forever from my slideshow, because this is wrong. This is not what it should be happening. But still, the harsh reality is that men are the breadwinners. If they get transplanted, they get rehabilitated, they start working. Women who are the nurturers can still take care of the family better. It should not be like that. But by giving a transplant to a man, we are also improving the quality of life of other women in his or her household. They might even start thinking of their health better. They have seen all this, the person improves, the burden improves, and then they start thinking of their health better. So these were my 9 points. And as I would not definitely end on a negative note, I am a proponent of women health. So I would like to end with this slide, where these are the things which I am proposing. Instead of giving a lollipop of 2 points on an organ allocation system, these are the things where we should be betting our money. We will be putting our energy. And these are the things which we should be doing. We should prioritize women for prevention and early detection. We know that they are at a higher risk of CKD. All of them should be screened at appropriate age times and early referral to a nephrologist. We should be definitely optimizing peripartum care. This is a very big reason why CKD might be higher in women, because they have more peripartum issues with the kidney. They have more lupus, they have more autoimmune diseases. A healthy mom equates a healthy daughter and a healthy future mom. So the whole generation can be made healthy this way, and not by acting at the last stage when the kidney has already failed. We should be destigmatizing the kidney care. I come from a hospital where my patients are most of them illiterate, the most underprivileged strata of Maharashtra. And most of my women patients come late only because they feel that kidney disease is a stigma. They would not like to discuss their problems, especially when it is not very life-threatening. So there is something which we should be working on. We should be openly discussing sexual and fertility issues. That's a part of our peripartum care. We should be encouraging organ donation by men. That is what we should be doing. We should be giving extra points or something extra. Every man who donates can get extra 10 points in the future organ allocation whenever he needs. We should be doing that kind of a thing rather than doing it the other way around. There is a very inherent physician bias also in this. Even till now, whenever I see a family, I would think, my first thought will come that the women will obviously donate. If child has a CKD, माँ नहीं देगी तो कौन देगा? पिताजी की बात बाद में आती है, पहले माँ के टेस्ट किए जाते हैं. The part of that problem is not only the society, it's also us. We also inherently feel that mother is the one who's supposed to donate, wife is the one who's supposed to donate, and that needs to change. We should definitely advocate for disparity in access to healthcare. I am all with Dr. Trivedi in this. We will advocate for it together. And we should be ensuring the mental well-being of women patients and caregivers, as everything starts from there. So this is the last thing. If it was up to me, I would choose the hard path with easy ending and not the easy path with the hard end. Thank you so much.
The moderator is online.
Divya, I have a question for you.
Yes.
You're telling that 80% of the donors, cadaveric donors, were male. I have a question for you.
Yeah.
You're telling that in the cadaveric kidney program, 80% of the donors were male.
Yes.
What proportion of the recipients were male?
Yeah. So that is I purposefully did not say that.
Yeah.
Yes. Yeah. So actually, I should have actually said that 64% of recipients were male. So if you calculate, it is still more male donors as compared to.
So basically, in a highly patriarchal society like India, where natural justice is not there, you can't speak of equality and equity unless natural justice is there. So as long as we don't have natural justice, even that small +2
See, why we have a lot of women parliamentarians in India? That's because at some point somebody decided that you have to reserve a certain proportion of seats to women. And now, even now, with that 1/3 reservation, in how many states we have 1/3 of the women parliamentarians? Not many.
Is it possible that? Yeah, and because of that reservation, we are actually not giving chance to the able politicians, meritorious, who can actually come and sit on those seats.
Last ceiling, and how many women have the courage to break it? But
We should encourage that. We should propagate that.
But what about our educated patients who are actually just marginalized people and who are taken for granted?
Completely agree, ma'am. But this will not solve that problem. The problem which you're saying will not be solved with this.
But I think so job well done both of you. So I told both of you because it's an excellent part of argument and proof that's what you've done well. But what I feel is I agree with Mayur. Why? Because see, had this 2-point system not been started, would we be debating this topic even? No. So I firmly feel in this day, I mean, at least we should talk about it. This could be there, may not be for eternity. But well done, I think.
Manisha, we should think of 2% and starting from bringing them with the bus from the home to the village to the village.
Absolutely, this is starting point. This is the starting point. Then you want to the preventive care and the post-transplant care.
Maybe
we have made the beginning. That's what I feel.
But maybe we would be debating for something more granular, if not this, but it's still better for kidney.
Yeah, exactly. No, we are
मैम वो 2 चॉकलेट के कारण अपना पूरा केक रह जाएगा मैम.
Can I add a couple of points?
The female is starting at -50 and the male is starting at 0. Who will come early? So exactly the organization situation in India is like that.
Yeah, I mean, I'd like to add a few things. So gender has become a complex now, it's not just male and female.
Exactly.
That's so
Exactly. My point.
But if you look at it, one more, column, don't want to mention your gender.
Yes.
And now it's a transgender which is coming up. My husband is urologist. We get daily few cases who want to change gender. So gender has become, I think,
Absolutely.
more complex and it should not bang on only gender. Two things we have discussed is like, the 3 points which, which like, where the women are being, not they receive not as a donor, but it's reverse. It's they are donor but not in secret. What is literacy, lack of literacy, particularly the health literacy, and they are not being made a part of what we call decision making, whatever it is.
Yes.
In terms of transplantation, recipient or the donor, they just when the decisions are so much happen. And another thing is like. Basically, they need to be, as one of the decision makers. And third point, what you mentioned is that they are all giving, always giving as when by nature's rule, the women are always giving. So these 3 things you should address, not giving up points. So this basically can be combination as in the first we discussed HD versus PD. So it offers synergism. So we should start with a few points to make people aware that there is a disparity.
Yes.
But you should look at long-term goals. How to increase the literacy, particularly the health literacy, and make them as a decision makers in the family, and then of course the financial literacy. These things should be concentrated. And the 4th point, what I want to mention, said, the deceased donor males are, they actually more donors compared to the females. But what I understand is again a bias because males don't they with an accent and they have
Yes.
a
Yes, ma'am.
not like
Yes, ma'am.
they are coming home for donation.
Yes.
It's not. I mean,
It's maybe nature's way for equalizing the
access to the health
disparity.
So it's again a bias. Because males make the accident. It is the females, the wife who are the
Absolutely. Absolutely, ma'am.
So I think we should give operations like to begin with, we can start with the steps, but should not end with that. We cannot repeat those points again. So it's like we have to show that we are equal. We cannot get discriminated. See, if we keep on fighting like this, Dr. Swandaka told about 80 people. We talk about them being equal, but are they equal? Let us talk about facts. At least 80 these can be said. So I think we have to start somewhere. I think Absolutely, okay, I agree with that, but I think, okay, this has generated so much discussion. And there is a disparity among, differences between us as well. Let us see 10 years down the line, we are talking about ideals. Divya has suggested what should be, but it's not what it is today. Day in and day out, we face that. And if not we, who's going to change it? So I think this nervous system, maybe for a few years, would be the way to solve the problem. I fully agree with you. You are talking about long term, but we reach long term if we start short term activities. So that's what I said. It should be combination of both. Don't forget about the
seems a beautiful debate done by Rick. Actually, we know this is a highly relevant topic. The practice as transplanting nephrologists, we see the proportion of the donation in life. It is almost 85% in our center only. The females donate come forward. It is not happening in the same way from the male side. And you also see the proportion of the overall transplantation happening. It is about 90% or even more by the live donation and the cadaver. So just a matching, saying that word, in the cadaver donation may participate more because of the they get into the organ donation. It just will not match. If you compare the volume of the live donation. So at the place, definitely, when so much of injustice is happening at the donation level itself, forget about the other part, the equity of the care and the CKD corporation, all those things may happen more with the males also, but the males and females equally also at certain stage. But the donation happening, the proportion of the live donation happening is very, very huge, and a lot of injustice is there at the society level. And some level of, from my perspective as a nephrologist, I feel for that and say that somewhere, some points if it is given, it is a kind of making the whole society aware that the patient, the female, there is a definite disparity as far as the nephrology is concerned. So that may help us, and ultimately it should drive the whole society and the policymakers to make more equitable access to the females. It should happen. So with these points, I will points. So the disease zone allocation has to be fair as much as possible. Regarding this, the developed countries, the UNOS and the European disease zone allocation, there's a lot of debate was going on in the pre-CARS era and even now to whether there should be some priority should be given to the gender, the poor people and the minority people. But at the end, actually, it is there is no priority given for gender, at least in the UNOS or in the European state. So, having said that, there are the developed and the developing countries. There are a lot of gender disparities. Actually, it is the margin, the gap is big. Actually, there if you see the gender disparity among the health accessibility is not there. What we see in the developing countries. Definitely, we all see living donor transplants, but in disease donor transplants, probably if we make this, I think Sonala agrees. So the point system, I don't think in most of the quotas we have actually. Probably in Ahmedabad, I guess the only Gujarat, the only state in Maharashtra where they are diligently following. But in most of the states, first come, first serve policy only is making this. No points. Even the HLA there we don't do a HLA typing. We don't do a single.
We have points for it. We have points for it.
Yeah, but maybe Gujarat and Maharashtra can give. I don't think rest of the state. Yeah, I don't think in rest of the state it is. I think we should concentrate on that first. Pediatric priority to the pediatrics. That is also not there in many of the states.
We only find the government.
Yeah. So having said this, I think in India is a developing country, there's definitely a lot of bias, gender bias is there. I think we need to consider, especially, probably giving her 1 or 2 points, if it does not make much difference, I think that.
I think we all stand down over here and we are talking about gender equality. So to break away this gender equality, I think all steps should be taken to, get extra points from women so that they come forward, they are aware of all the other situations, so that we can remove this disparity. Extra points should be given to the women.
I think we had a brilliant discussion.
Last comment.
That free education, free treatment can be given, but extra points. One thing I will tell that madam, when Monica Saya madam was reading nephrology and Arpita ma'am was reading nephrology and Siddhi madam was reading nephrology, there was only finger count number of females there in the nephrology. But now, see, this is a huge number of nephrologists and elite nephrologists and a national conference we are conducting. Must be some amount of encouragement they are getting at their time so that we came to the stream. So in the initial stage, we should get encouragement and that 2 points should be given. Sorry to say Vidya madam, but I support Moyuri madam definitely. So initially, we should be the givers, give and throw, give from us and throw us. Nobody is caring for the donor, 92% of in Odisha life donation is females, and only a hand count of 8 to 10 males, and there 2-3 number of husbands. I can count them: 3 husbands, and 2 brothers, and 1 cadaveric male. They have donated. All the cadaveric are female in our state of Odisha. So why the females? They will only give.
Will this problem be solved by giving extra 2 points?
No,
The problem which you are alluding to. Yeah, this should be points from male donors.
The government. So free treatment for women might solve the problem. In Odisha, there is a base age there, and we are getting 10 lakhs free of cost treatment in transplantation for female and male only 5 lakhs.
I think the debate has been very interesting, with both the contestants being very brilliant. I think we will have enough time to bury it. And I thank both of them. And I think there's no harm in giving those different 2 points to this special sector of women, along with the other, general care, improving the literacy and the independence, which I think it has over the years. With all of us sitting here, I think the literacy and independence has improved, and it will improve with that. Thank you so much.
It is an encouragement.
Yeah, I think men are quite encouraging nowadays. Not that bad.
Thank you, speakers and chairpersons. Gentle reminder. All those who have poster presentation, please assemble in hall B by 12:45 p.m. The next talk in this scientific program is update on therapeutic options for anemia in kidney diseases. I would like to invite on stage chairpersons Dr. Suman Lata Nayak, Director Nephrology Fortis, Vasalkunj, Dr. Hiteshi, Consultant Nephrologist, Mansa Kidney Foundation, Tirupati, Dr. Sanjay Srinivas, Chief Nephrologist and Transplant Physician, Center for Diabetes and Kidney Care and Sugunam Hospital, Bengaluru. I request the chairperson to raise the stage.
Hi, good morning, everyone.
Dr. Suman Lata ma'am, Dr. Hiteshi, Dr. Sanjay Srinivas.
Yeah, we have around 10 to 12. No. No.
I request Dr. Urmila ma'am, President Win India, to please moderate, chair the session, and Dr. Arpita ma'am. Arpita ma'am. Professor, Department of Nephrology, Calcutta.
I think that you are going to explain to them. Then should I ask?
Or notes.
Notes, if notes means online people are able to, it's not issue. At least you can change the second screen. Is it okay?
Yeah,
I want to see notes because I want to know whom I'm asking.
I now request Urmila ma'am to introduce the speakers.
Good afternoon.
Mike name. Hi. Madam, please fix no.
The Sanjay sir is here.
So I close this one.
Request the chairperson
This
to
one.
kindly.
So I close and open, reopen.
Speakers of the session.
Where's the file? This folder?
Instant.
Pen drive. Which file?
Manjusha.
This is pen. So you open the name. Change. File name. Which one?
First part. We'll start with our industry sponsored scientific symposium correspondence on anemia, and this will be moderated by Manjusha. So Manjusha is there at the Department of Nephrology at Gandhi Medical College, Hyderabad. There are three very young panelists. Swarnlata, Professor.
Okay, yeah, sorry,
Department of
good.
Nephrology NIMS. Assistant Professor, All India Institute of Medical Sciences, Bhubaneswar, and Sandhya Suresh. She is a Assistant Professor, SRMC, Chennai.
Close all the things. This is like close, no?
Replacing two chairpersons, Swarnlata.
This one only one to ma'am.
She and the Dr. Hideshi. Professor is already there, so. Just even see that the virtual is also.
Good afternoon, everyone. I think after an interesting and very fierce debate about the women allocation points in the renal transplant, let's shift our gaze to another interesting topic. Of course, a lot of sessions have been going on, and this topic is the anemia in chronic kidney disease. We are just going to take you through the case scenario and see what have been the developments, how to be managed, what are the KDIGO guidelines and all. So let me take this opportunity. I think Dr. Urmila has already introduced the panelists of today's session. So without much ado, I will just start the case. Yeah.
Then you can speak here now. The camera. Can see the. Yeah, right. Change one slide.
So these are the moderator myself, and these are the panelists of this session.
So let me take you through the index case. There's a 36-year-old woman diagnosed to have CKD stage 3 who attends the OPT with the following complaints of generalized fatigue and body pains. Her evaluation revealed hemoglobin to be 8.2 gram per deciliter and TLC was around 5,200 and platelets being within normal limits. The peripheral smear shows normocytic normochromic anemia, no abnormal cells, otherwise it's normal. The iron stores evaluation was done by the treating physician, wherein the serum ferritin was about 250 microgram per deciliter and TSAT was a little on the lower side. So here we take you through the questions. This question is to Dr. Swanlata. Dr. Swanlata, can you just explain to us what's the type of anemia that we are discussing and what is the type of iron deficiency anemia? Of course, it's understood that it's IDA. What are the types of IDA and what are the methods of diagnosis and what are the KDIGO guidelines as of today?
So first of all, I'd like to thank the organizer for the wonderful session. It's been going great and we had a lot of active interaction and then the participation. And the anemia is one of the difficult, most common but very difficult topic as an oncologist we deal with. So I think this is as has been mentioned by Dr. Manjusha. The case is very typical case. In particular, Indian scenario where you see the iron deficiency anemia being the most common cause of the anemia, not only in CKD patient, but also in general population. So this is a clear-cut case of iron deficiency anemia. So as per the KDIGO guidelines, we define as iron deficiency anemia when the person's saturation is less than 20 and ferritin is less than 100 in non-dialysis patient and it is less than 200 dialysis patient. But however, the iron therapy is recommended when the saturation is more than 30% and ferritin is more than 500. So here, again, it all depends on a particular CKD patient. We also expect functional iron deficiency where there is enough reserve, but it's not available, and that's why we detect it as the TSAT being less. So in this case, I think because the iron reserve still we can say it is moderate, so 2 to 3, and then person saturation is less than 20, I think it's a functional iron deficiency.
Yeah, so we have absolute and functional iron deficiency as has been defined. So these definitions are given in the KDIGO, nothing very new for us, but then we need to be aware of, because this is definitely prudent for us when we need to say what type of iron deficiency anemia are we dealing with. Is it absolute or is it functional? Because our treatment strategies are going to depend on that. So what's the optimal target and the targets that have been defined are very difficult because, the literature says that there are global differences. The Japanese behave differently from the US. So it all depends on the phenotypes and genotypes. We need to customize our targets, just not taking the KDIGO guidelines in the face value as such. This has also been mentioned in the literature. There is other input wherein it is mentioned that a trial of IV iron for hemodialysis CKD patients or a 1 to 3 month trial of oral iron for ND CKD to be given if we need to increase the hemoglobin, that to be decided when the TSAT is less than or equal to 30% or ferritin is less than or equal to 500 nanogram per ml. And the new data that is coming up is in non-dialysis patient. You all know the FIND CKD trial, and in hemodialysis patient, the pivotal trial, which we are going to speak to you later on. The second question, I take this opportunity to pose this question to another panelist, Dr. Preeti. Can we just move forward? Why should we treat anemia at all? Is it mandatory that we need to treat anemia? If we don't treat anemia, what's going to happen to the patient? How do you approach the treatment of anemia? And are there any agents which can be given intravenous and oral? And do you think oral is better or vice versa? Over to Preeti.
Thank you, Dr. Manisha. Very interesting discussion going on. First of all, the question is why should we treat anemia? Anemia in CKD patient has been found to be associated with both the things, overall cause of mortality and cardiovascular mortality. It has seen that the patient with anemia suffer from more heart failure, non-fatal MI, and ventricular arrhythmias, ventricular dilatation is more common. So to decrease this kind of mortality and specifically prevent cardiovascular mortality, anemia treatment is important in CKD patient, and there have been trials that suggest that even there has been more progression of CKD in anemia patient, although we do not have any sort of data on that.
Yes.
Coming on to the IDA, treatment of IDA has been associated with increase in the quality of life, specifically increasing exercise tolerability, improving quality of life, but increase in the fatigability and improvement in the cognitive function. So there is important need to treat IDA and anemia both.
Yeah, completely agree. Yes, Preeti, please.
Yeah,
how should we treat it? So treatment is in CKD patient, whether they are in dialysis or they are not on dialysis. In dialysis patient, IV therapy is preferred as suggested by KDIGO also. And in non-dialysis patient, first it is suggested that we should give 1 to 3 month trial of oral therapy. Then we can shift to IV iron therapy. And if there will be some problems like patient is intolerable to oral iron, there is consistent GI and there is severe anemia, severe symptomatic anemia, we should go on IV iron therapy in the patient, even if the patient is non-dialysis.
Yeah, basically what you'd like to say is if it's an OP patient, an ND-CKD patient, like it's preferred that we give oral therapy. And if it's a HD-CKD patient, hemodialysis patient, it's always better that we give parenteral therapy. And as you said rightly, I think this slide very well depicts the benefits of treating a patient with anemia. I think Preeti has enlisted all the points, just not the salient things that we look at, like, MI or something like that, but then the quality of life, the cognitive function, everything is of equal importance to us. And it's high time and it's a need of the hour for us to correct anemia and reach the targets of a particular genotype and phenotype when we speak about anemia. So moving on, we move on to the subsequent question. So once we have seen this index patient, so we all agree that this patient needs iron therapy. So let's plan iron therapy. And now the question is, what are the various modalities of iron treatment that are available? This is to my third panelist, Dr. Sandhya. Over to you.
As Preeti already mentioned, we have the KDIGO guidelines which will say that we should give IV iron if we want an increase in the hemoglobin or a decrease in the ESA dose. And this should be given if the TSAT is less than 30% and they have a peritoneal cutoff of 500. But of course, it has to be individualized. The choice between oral and IV has to be individualized, especially in a non-dialysis CKD, depending upon the compliance of the patient, the availability of venous access. Are we going to take all the possible veins in a patient who is having CKD non-dialysis stage? The severity of iron deficiency also is important. The severity of anemia. Any prior oral therapy versus patient having GI intolerance to prior oral therapy. Any side effects of prior oral and iron therapy or IV iron therapy. All of these should be considered when we are considering the choice between an oral and an IV iron. And of course, the various different adverse effects of oral and IV iron, which I will touch upon next. We do know that there are certain benefits and there are certain risks with IV iron. But the benefits that have been proven are that it improves the fatigue, it improves the mortality, especially in patients with congestive heart failure, and it may improve quality.
Sandhya, we will look into the benefits and risks. I think there's a specific question for that. We move on to that a little later. So we can just focus on, the various modalities of IV iron and oral. Over to you. Yeah.
So oral, we have now the older formulations, which was the parasulfate, and now the newer formulations like parasulfate, which are the phosphate binding agents. Again, the cost would be a major factor which would determine our decision and also the GI side effects. IV iron, we have the traditional IV irons like the iron sucrose along with the low molecular weight iron dextran. I think we mainly use iron sucrose here. We have novel agents like the pericarboxymaltose and iron isomaltoside, which are most commonly available here. And all of these are just different because of the carbohydrate shell which is attached to the iron, and this will produce some certain different side effects which are unique to each of these agents. Most of the centers we use iron sucrose because it is cheaper. The
no side effects.
Multiple dosing. Pericarboxymaltose and iron isomaltoside, we can give larger doses as a single dose. And the disadvantage would be the cost. And also for dialysis patients, the exact dosing has not been well specified in many trials. Although we do say that up to 500 mg can be given, even the FDA and the EMA have actually approved 750 and 1000. But on the manufacturer label, it doesn't really give us a 500 milligram dose for the FCM and isomaltoside. They do only specify 100 to 200 milligram at once for a dialysis patient.
Yeah, so all these drugs which have been displayed here right now are traditional versus novel. I'm sure many of us are using the traditional much more than the novel, but nevertheless, what we need to observe is that these are all FDA approved drugs, though the novel drugs are there, they're also FDA approved. and people have started using that. Of course, the cost is a major limiting factor as far as the utility of the novel agents is concerned. In the same breath, can you just enlist, as we were discussing about the benefits and risks of iron therapy? You know, I mean, we cannot take it in a categorical way that iron is always beneficial. Iron is also associated with certain risks. So the benefits outweigh the risks, but then we need to be more prudent in what situations we are supposed to avoid iron. What are the side effects of iron? Over to you, Sandhya.
Yeah, I think all of us during our internship, we would have had a tough time infusing IV iron for all our patients and standing for 5 minutes to just look for any reactions. So the first thing that strikes our mind when we think of IV iron is anaphylactic reaction, hypotension. Patients can have some less GI side effects like nausea, vomiting as well. There are certain specific things that we need to look on for the newer combinations like FCM can actually increase the FGF23, which is very significant in a non-dialysis TKD because it can reduce the phosphate levels. In a patient on dialysis, it may not be that significant. The other question is, does IV iron increase the risk of infections? This is something that has been very debated in a lot of studies and a lot of guidelines. And in the pivotal arm, they did not find any difference in the infection risk between the reactive group and the proactive group. However, we know that theoretically iron does impair the IV iron can impair leukocyte function because of oxidant damage, and iron is required for all the bacteria to proliferate as well. So theoretically, it can increase the risk of infections, and patients with active infections have not been included in any of the IV iron studies. So we would like to avoid IV iron in a patient with an active infection. This was another interesting study I came across was the study which compared bolus and maintenance doses. So in bolus doses, we would give reactively high doses of iron in consecutive dialysis sessions, whereas in maintenance, we would give low doses and maintenance therapy as a weekly or a bi-weekly therapy. And they did find that patients who received higher doses as boluses had higher risk of infections when they are on dialysis through catheters. So this was one study that I did come across. Again, the oxidant damage, does it worsen cardiovascular outcomes? This was found in the RIVER trial, which is actually stopped early because of high cardiovascular mortality in the IV iron arm. But subsequently, we did see the fine secret trial and the pivotal trial, which did show a decrease, especially the pivotal trial, which showed a decrease in mortality as well as non-fatal cardiovascular events. So this is something that we need to really keep in mind. IV iron does show a decrease in the ESA dose that does reduce the blood transfusion, especially important for a patient who might be on a transplant wait list.
Yeah, the obvious benefits are very obvious in the sense that, you know, the necessity for blood transfusions, the necessity of the dose of the ESA and all can be declined. But then coming to certain salient points such as infection, yes, we are still, even today we struggle with the patients having an active infection, whether it's sepsis or whether it's a CRBSI, we are still struggling despite the pivotal rule saying again, so the contrary, we are not in a very comfortable place or zone to give IV iron in patients with active infection that's going on. And of course, the FGF23 is another interesting aspect. That means the FCM has a significant benefit in the CKD MBD, risk in the CKD MBD. So the CV outcome is, of course, either way, we say that the CV benefits are there, but then one trial which has said that the CV outcome are on the contrary side. Thanks to Sandhya. Thank you so much. So we move on. We have learned about the preparations as well. This is a fine CKD, which I think Sandhya was mentioning about, which has looked into is IV carboxymaltose better than the oral iron in treating iron deficiency anemia in patients with CKD. The conclusion of this study is compared to oral iron, IV ferric carboxymaltose targeting a ferritin of 400 to 600 microgram per liter quickly reached and maintained hemoglobin and delayed or reduced the need for other anemia management, including the ESS. This is a pivotal study. I think all of us know about this. This is one in dialysis population. So in this, among the patients undergoing hemodialysis, a high dose intravenous iron regimen administered was proactively done. It was superior to a low dose regimen administered reactively. Proactive versus reactive approach, we all know about it. And this resulted in lower doses of requirement of ESA. This is another study, Fairbairn-Nephro. How does iron as a maltoside compare with the iron sucrose? Of course, the iron sucrose is a common agent that we are using as of now. So this question is to my chairpersons. I want to involve them too. Answer is being displayed there. Can iron be administered via the dialysate? Of course, there is literature about it. If anyone wants to give your opinion, not that take the question, but give the opinion regarding the administration of iron via the dialysate.
Many years back they had done that. Many years back it was done, but there were issues with chelation, bicarbonate and infections.
Yes, yes, ma'am. So,
I agree what I'm saying. There were a few studies which came out, but the problem was the infection. Or whether it was related to the iron which was given through the dialysate was not clear. But now, since we have got formulations which can be given IV.
yes,
and in
it's
a
more
large-
easier.
So it is more easier rather than to put it in a dialysate. And in our situation, when you are putting it in dialysate, all patients cannot require. The
Correct,
dialysate,
absolutely.
what you are using gets used for the
Other patients as well.
So I think practicality is very difficult.
Completely agree with you. Dr. Arpita, madam, you want to share any viewpoint on this?
No more regarding this, but one thing I must want to ask to our panelists and to you as well and other chairpersons, that what targets of TSAT and ferritin do you fix to consider that when I will treat the patient with iron, he or she is still running iron deficient? Because whenever I receive reference from medicine department, still medicine is admitting a lot of CKD patients. I find they often do only serum iron, even though don't care to do the TSAT and ferritin, or serum iron and ferritin. The TSAT portion is overlooked. So which do you give, which we give most importance, and how we accept the ferritin levels, how we analyze ferritin levels, which one we give most importance?
Madam, literature says, KDIGO says importance is for the serum ferritin and serum T transferrin saturation. Transferrin levels are being done in certain labs. TSAT is not being done. But then I think transferrin saturation is the one which we need. Of course, the targets are different for both proactive and reactive approach. Over to panelists. Yes.
One study just come up, pilot study. It has clearly mentioned whether it's going to be iron proactively or reactively. So reactive is just, when you give, iron, only when there is the.
Fall in the,
Less than 500.
400, yes.
500, and then performance iron is less than 20.
A simple
So,
question, will you
yes.
give iron to somebody whose TSAT is 15% and ferritin is 600?
Madam, TSAT is a serum ferritin. Serum ferritin is an acute phase reactant.
Particularly in CKD patients, because there is certain hepcidin will be very high. It will prevent the utilization of this low iron, and that's why the TSAT is very less. So in fact, that has been the newer molecules have been looked at, which can actually bring down. And the advantages of the latest whatever we are trying to discuss and subsequent slide, that will decrease the hepcidin level.
Will you give iron in this patient or not?
Iron should be used cautiously, because iron over will become.
Madam, what I opine is iron should be given.
Actually, why I put this question, in the controversy conferences that are going on regarding fixing TSAT, you will see that constantly the TSAT target is getting
Higher up,
and the
yes.
DRIP study and all, they have minimized the importance of
Ferritin.
And the is 800.
Yeah.
We can give safely iron till 800. It is going
You
beyond
consider
800,
that they have gone
stop.
up to 1200.
1200.
No, that is not in the recommendation. But the recommending people are increasingly elevating the target TSAT. That is from 20%, we have already
30%.
gone up to 30%. And I am listening and reading the controversy meetings outcome that it might be elevated up to TSAT of 45%. So that is an important area. And this caveat that Shanlata was talking about, that relative iron deficiency. So if we can find out that these are the people and these are markers of relative iron deficiency, then is HIF PHI is addressing that issue? Or not?
Yes, ma'am.
Really,
That is the consequence.
molecular level, that HIF PHI is addressing at the molecular level the hepcidin problem in CKD. So is it translating into truth that the relative iron deficiency people are being helped out without iron, but on HIF PHI? from the problem of refractory anemia or hyporefractory or
So the
refractory.
question
Yeah,
she's
we will.
saying, if your if your ferritin is high,
Mm.
should you just start hit PHI and not give iron to them?
That's
Even
what,
if you're-
that's what the latest studies claims mentioned.
But can we do that? Can we finish it? then
Yeah.
we cannot.
See, madam, actually what you have brought out the point, the increasing, the changing, the dynamically changing targets and all. See, KDIGO also mentions that we cannot take it in a categorical way because the Japanese behave differently from the US. So many things are there which add on to the target setting in each and every population. Unfortunately, in Indian scenario, we do not have a target of this particular serum ferritin should be there, this particular TSAT. We're still following KDIGO. KDIGO mentions this actually. So it depends on genotypic, phenotypic differences when we are trying to say that has to be kept in mind. Of course, we do follow KDIGO. I mean, why is there such a dynamic change in our, I've gone through that. Yes.
TSAT level is from KDIGO only.
Yes, madam. 2019. Yes.
This conference is madam, they have fixed TSAT at maximum of 50 and ferritin of 800, madam, as of now.
So we move on. So after 10 doses of iron, her TSAT increased to 35% and serum ferritin to 450. Hemoglobin has increased. So what's the plan of action? Now this is to the audience. The options are continue IV iron therapy, convert to oral iron, start erythropoietin, Paxil transfusions. Anybody? Hemoglobin has improved. So Jyoti feels that we should start EPO. So we agree with you, Jyoti, we start EPO because I have to take the program forward. So EPO, so we have a lot of erythropoietin stimulating agents. So here the question is like looking at the benefits and risks. This in fact has been made by Preeti. So Preeti, can you take this question? What are the benefits and risks of ESS? This visual abstract is made by you. Yeah, please.
So again, the question is now that we have seen that patient has received iron therapy and now it is an iron release state.
Correct.
So we can move on to other therapies, for example, EPO or DPHI, which we'll discuss later.
Correct.
But again, even EPOs are associated with their own benefits and risk. This term, for example, there can be hypertension. In a patient with accelerated hypertension, patient can even through seizures. In active malignancy, we should always rule out active malignancies when we are starting a patient with EPO. It has also been seen in trials that there could be increased risk of vascular thrombosis or even strokes with the increased dose of EPO they have been used, and vasculitis and all posterior mortality where in the trials when the target hemoglobin has kept high, especially more than 13.5 or more than 13, it has been associated with high mortality, that adverse effect. It has seen that it may be because of the higher doses of EPO rather than increasing the HB levels, but yes, also it has been seen that they are associated with better quality of life because improvement in anemia, less transfusions, and with improvement of anemia, there is less hypertension.
Correct. I mean, every drug is not just free. I mean, it's not completely beneficial. Every drug is correct. So there are certain risks, as we all know, certain trials and studies, RCTs, which are available for us, which speak about the negative impact of higher targets or probably the ESS. So moving on, what do the KDIGO guidelines say about the erythropoietin therapy? What are the targets of the erythropoietin therapy? Dr. Swanlata, can you take this question?
Yeah. So when as per the KDIGO guideline, it says it should be started before you start patients on ESS. You should have adequate. You should rule out other causes, and you should have the all iron or whatever deficiency. So once it is done, then you start erythropoietin. You can start at a lower dose. You should start when hemoglobin is less than 10. You should not supposed to start when hemoglobin is more than 10. As we have said in previous, it was quite closely, it was 9.5. In fact, I would rather wait for some more time before I can start with the one because hemoglobin is obviously.
That is little different between non-dialysis and dialysis. Dialysis is a little lower target, and
yes, So you should start when hemoglobin is less than 10. It can be started with a lower dose of 50 units per kg body weight and can be then escalated. And maybe it should not continue the target. When we define anemia in the CKD patients as hemoglobin of 30. In males and hemoglobin of 20 females. But you should not wait till they achieve that target. You can actually, continue till it is hemoglobin is achieved at 11, and subsequently, we can actually start cutting down on the erythropoietin for 25% to maintain that.
And if the patient are maintained, you can gradually cut down. So that's how we can manage the.
Correct.
To avoid depending upon the case.
So when to initiate and how to maintain, what is the target? So we need to be clear about that. We do not want a higher target, which is going to be detrimental to the patient. So let us be having a clean eye or a clear watch on the improvements of the hemoglobin. Once it's improving, as has been suggested, we need to titrate the dose so that the patient doesn't have a higher hemoglobin, which is going to be again detrimental to the patient. Now, we have started our patient on erythropoietin of 50 units per kg 3 times a week initially. And as the hemoglobin did not increase, we further increased to 100 units per kg, but there's no further increase in the hemoglobin. What's your next step? This is again to the audience, any audience who is little more proactive. I can see somebody smiling over there. Increase to 150 units per kg. Stop PSA. Think of an alternative EPO. Evaluate the underlying cause. My voice and tone itself says the answer. Yes. D, evaluate the underlying cause. Let's see about this entity, what is called as EPO hyporesponsiveness. Over to Dr. Preeti. She's going to speak to us on, she's going to clarify to us on 3 C's of the EPO hyporesponsiveness: causes, categorization, and complications. Over to Preeti. What are the causes of EPO hyporesponsiveness?
First, we should define actually what is EPO hyporesponsiveness. Whenever we are using higher dose, especially more than 3 times the dose we are using to achieve or to maintain the target hemoglobin, then the patient could be having EPO hyporesponsiveness. But when we are seeing the patient, we should first see if the patient is getting adequate dialysis. Inadequate dialysis is one of the important cause of anemia and ESA hyporesponsiveness. Then we should see whether the patient is having an infection, even open infection, unused fistulas, catheters, any kind of infection can cause non-responsiveness to EPO therapies. Other things, other conditions like hemoglobinopathies, fetal disorders, even MDS, bone marrow disorders should be looked at. This patient nutritional deficiencies, folate deficiencies, vitamin B12 deficiency should also be looked on. And we should never forget that the patient should be in iron reduced state before we say the patient is having ESA hyporesponsiveness.
Absolutely. Yeah, I think we need to look into the causes before saying that. So how do we categorize? There's certain categorization of the EPO hyporesponsiveness too. How do we categorize that?
First is the initial hyporesponsiveness, then there is secondly, initially when we are giving adequate dose, which we have mentioned, 50
Yeah.
units per kg, and twice a week, then the patient is not getting, we can say that the patient should have increase in hemoglobin by 1 gram per deciliter in 1 month. With adequate dosing, we have to increase the dose to 3 times. Still, the patient is not achieving the target hemoglobin, then the patient is having initial ESA hyporesponsiveness. Again, when the patient has achieved, but again, we have to increase the dose of ESA 2 times the dose. Then we can say that this is the subsequent ESA hyporesponsiveness in the patient from ESA.
So for the benefit of the trainees, what we need to understand is there are 2 entities. As the initial EPO hyporesponsiveness and subsequent EPO hyporesponsiveness is a defined, whatever has been projected in the slide. So we need to look into whether a patient is having, before saying the responsiveness, whether it's initial or subsequent, and also look into the cause as well. What are the complications, Preeti? 3 C's I said causes, categorization, and complications. All to you.
We have discussed the complication. We'll start with them only. From the risk of thrombosis, especially vascular thrombosis, because the patient who are receiving chemotherapy will be having vascular access. Stroke complications could be there. Then they could be increase in the hypertension, seizure, and almost severe mortality. So these should be looked at.
Correct. So all these things have to be kept in mind with regards to the complications of the ESA therapy, as has been mentioned in the figure. Blood viscosity, thromboembolic events, and hypertension. Another entity, PRCA, which we will little come to later on, cancer, and all-cause mortality, cardiovascular morbidity too. So much so about the risk of ECA and an increased risk in the mortality with the higher targets that we're going to have. So now moving on, when we speak about EPO, so we are equally interested in knowing what are the various types of EPO and of course the side effect that I just mentioned, PRCA. So may I request the other panelist, Dr. Sandhya, to take this question. What are the various types of EPO and a little info about the PRCA?
So we usually use the equivalent alpha here, but there are 2 forms of the equivalent alpha and beta. Which then depend upon the companies which are manufacturing it, and there are certain small differences in the molecular weight and the number of cyanidation units in the molecule, and the differences are not very significant. So this is what we commonly use as erythropoietin in our units, a short-term use that is for use around 2,000 to 4,000 twice or thrice a week, subcutaneous or IV. And dabigatran is the other one which is available, which we start off at a dose of the dose which is given by KDIGO is 0.45 milligram per kg per week, which would roughly translate to around 25 microgram weekly, or 40 microgram once in 2 weeks is what we generally use for most of our patients. And we also have the regulated forms of erythropoietin. And these are the ones which are commonly used, and we have to certainly titrate the dose according to the hemoglobin response, and it has to be monitored at least once a month in all dialysis patients, and even more aggressively, maybe even once in a week or once in 2 weeks, to ensure that the hemoglobin doesn't rise too rapidly. Because many of the complications which were seen in the erythropoietin trials were because of the higher hemoglobin targets. So hemoglobin going up to 13 and 14, and these were the most common reasons for the thromboembolic events. We don't know whether it is specifically due to the erythropoietin itself, or it is due to the most likely due to the high hemoglobin target. So monitoring of the hemoglobin is
Very important.
absolutely essential, especially when we are targeting, and especially when we're starting at a higher dose of erythropoietin.
Yeah, we need to be very cautious, and frequent monitoring is crucial. Yes. So, and a word about PRCA.
Yes, PRCA, it was very interesting to me to come across the historical cases of PRCA in the past, when they had the outbreak of PRCA with the use of certain formulations of PFS. And it was thought to be due to the leachate from the rubber syringes, rubber stoppers. Normally the stoppers had a coating, but in this particular formulation, there was no coating for the rubber. Whether this the leachate from this rubber stoppers caused it, or whether the erythropoietin formed micelles, and this caused the development of antibodies in the patient and led to the development of PRCA. All of these are not very clear, or the patients can have certain genetic predispositions to these the formation of these antibodies. So a lot of multiple factors which were probably contributing to the PRCA. And now we do see, but it is very rare in the current scenario, but it's something that we need to keep in mind when the patients are requiring very high doses of erythropoietin, and we ruled out every other cause, and the hemoglobin is just not increasing. It's something that we really need to keep in mind. It's important because we really don't have anything as a treatment. We can't.
Certain immunosuppressive drugs can be used as a part of management of PRCA. But nevertheless, I don't think we see it as very common. It's extremely rare for us to see. So anyway, I think for the
I have a practical experience when I finished my DM, and then we saw one patient was requiring the blood transfusion every week, 1 to 2 blood transfusion. It was never more than 5. So because I have just finished my examination, I had a recent memory in mind, and we thought we were put that we are in one of the different diagnosis. We were wondering how to send these antibodies, because diagnosis is
that's little difficult. Yes.
Then we have sent the antibodies with the help of the Johnson & Johnson company. They sent it to the US, and it was found to be positive. And then after that, we have started him on steroids and cyclophosphamide.
Immunosuppression.
And we have stopped all the erythropoietin agents. So in fact, hemoglobin has improved 8.
So that's fortunate.
That was, I think, 2005.
Yeah, Iprex was more common in that era, the first part of 2000s and all. So I think it's very rare. Yes, madam.
Sorry?
I was offering, yes, at that time, yes.
Whenever we suspected, yes, it's a good friend.
So that's, I mean, the engines right now, the practicing nephrologists right now may not be seeing the PRCA as common, because that was more often quoted with Iprex, now less common, but nevertheless, for the completion's sake, we need to know what's PRCA, what is the management, and how do we diagnose. Let's move on. What are the indications for the blood transfusion? We know that, yes, in certain situations, we are compelled to give blood transfusions, though we do not want, but then there are certain indications for blood transfusions in patients on dialysis. So let's look at what are the indications for blood transfusions. Over to Dr. Preeti.
Iron deficiency, anemia, with IGIL, but we may need the transfusion occasionally in the patient case, especially first when the patient is having severe hemorrhage because of any cause of the GI or salt from anything, we have to transfer the transfusion in the patient is symptomatic or any cardiac illness.
the anginas, for symptomatic people to treat for symptomatic.
Symptomatic,
We have
yes.
give blood transfusions, and when we need rapid collection of hemoglobin.
Pre-surgery. Pre-surgery, yes.
We have to transfuse the patient, and when the patient is not responsive to the therapy, what we have discussed, that IVR and you have to transfuse the patient. Even we are getting out of transfusion, the patient not getting out of transfusion even once, but we have no other choice.
So what we need to understand is with the easy availability of the erythropoietin stimulating agents, especially in the maintenance dialysis units, especially in our state, which is run by the government completely, wherein ESA is again given free of cost, the percentage of blood transfusions has come down tremendously. And of course, the indications for blood transfusions are just 1 or 2, like pre or post-op, and if there is a symptomatic anemia. So apart from that, the blood transfusion usage in patients on dialysis has come down tremendously, but nevertheless, we need to know what are the indications. So what are the newer therapies in the management of anemia? So here comes our most interesting part. Over to Swanlata. Yes. So we are waiting for this.
6 decades before when the ESS were invented and has revolutionized the management of anemia and CKD. I think now I'm seeing another revolution.
Milestone. Yes.
In the management of CKD. I think this is going to be the future molecule. And now most of the even the
Present also, present and future.
That's what I'm telling. Now we have just started
Yes.
taking this
Use it.
molecule of clinical practice. And I think India also, most of us have started with that as well as starting. These are basically, when recently also with the what is called Nobel Prize was for this concept of identifying the tissue at the tissue level.
Hypoxia.
You know, so I think that this molecule has it increases the endogenous erythropoietin.
Your question is, what are the newer therapies? So you are supposed to, HIF, PHI. Yes. So the answer here, we are with HIF, PHIs. I think everybody is well acquainted, well aware of these molecules which are coming up, which are being marketed, which are being used in fact, but in India, it's only Desidustat which has been approved. So we are using only Desidustat. So going into further details, I think Preeti will take the subsequent questions. What are the mechanisms? Swanlata was just mentioning about the mechanism, so I had to stop her. So just you can speak about the mechanisms of action of HIF, PHI, and how do they differ from the regular ESS?
So as we are discussing, hypoxia, this is the factor. These are the constituent factors which are responsible, which are actually responsible for cellular adaptation in the cases of hypoxia, which happens normally in the cell. It has two units, one alpha, and basically alpha and beta. Alpha is mostly oxygen sensitive. In the cases when there is normoxemia, it gets degraded with the help of VHL and PHIs, but when there is hypoxia, there is less limitation, there is non-limitation because of the VHL and this PHI gene gets deregulated. Now we are creating this situation by giving PHI inhibitors so that it does not get degraded and further dimerizes and do the EPO gene transcription. Other than doing the EPO gene transcription and increasing the endogenous levels of EPO, it also increases endogenous hepatic EPO levels. And there are other pleiotropic effects of these drugs. For example, they also affect on genetic level. They increase hepcidin and make iron more available for erythropoiesis. They also are actually acting on various other metabolic
Cholesterol synthesis. Yes.
Hydrogenesis, iron metabolism. So they have a lot of pleiotropic effects, which could be advantageous or could be a matter of concern for us.
Yeah, pleiotropic corollary, we have SGLT2s, which are having a pleiotropic. So we may foresee that these drugs are going to be beneficial in a diverse ways in both CKD and Ds as well as in CKD D patients or HD CKD patients because of the pleiotropic effects. The other question that I had asked you was, what are the differences between these HIFs and the ESS?
So the first difference, which I've already told, that EPO exogenous erythropoietin, whereas HIF stabilizers increases both endogenous renal and hepatic EPOs. And special advantages which we are seeing with PHI inhibitors is that they are oral drugs.
Yeah.
Whereas EPOs are given IV or
Subcutaneous.
but they are not oral. And we have to maintain a cold chain at all the levels, starting from the manufacture, the production, and storage, distribution, which is not there. If we don't maintain,
Especially in rural areas.
if we don't maintain that cold chain, the immunogenicity and the effectiveness of drug is going to change.
This is not the case with HIV.
HIV.
And I already told the pleiotropic effects are also not there with PPO inhibitors. So
especially in Indian scenario, LMICs and all, I think the rural population who are like either ND-CKDs or probably D-CKDs who already are not able to utilize such much, feasibilities of having a refrigerator and all these things. The end user cold chain is one crucial thing as far as the EPO is concerned. I mean, the ESAs are concerned. But then HIV-PHI has such a great advantage. So it definitely can be used or can be prescribed in rural population who are CKD patients, who are non-dialysis as well as dialysis. So moving on, of course, the cost is one little hit. Yeah, not much of a difference. It can be easily affordable benefits.
In the rates given there is not compared. Actually, the cost for
Yes.
pill is less in India compared to the
Correct.
US.
Desidustat is much less. Correct. So agreed that the cost is not much of a difference between the erythropoietin agents and HIV-PHI. So, so not much of a this thing. So definitely there are certain areas, a certain population where we can definitely use HIV-PHIs without any this thing. Oh, really? Then I go on to the other question to Dr. Sandhya. What are the concerns about HIV? Do you think they are safe? Do you think everybody can use it blindly? There are no side effects? Or do you feel that there are certain concerns which have been raised by the scientific community? Over to Sandhya.
So I have played devil's advocate here. So we did talk about all the benefits of the PHS, and I think one more thing I would like to add that it actually doesn't have the peak effect of erythropoietin that we see with the injectable forms of ESA. So that's another advantage of HIV-PHS. There is a more because it's endogenous erythropoietin production. But we have to look at the cons as well. The pros are plenty, but there are certain cons as well. So we need to really dig into the details of all the trials which have gone on. This is a very nice summary table that I found made by Dr. Divya Bajpai.
Divya is here? Okay, good. Yeah, please
and
go.
I think she has actually touched upon all the cardiovascular trials of the HIV-PHS. So what they did find was that all of these were non-inferiority trials. And when we looked into the details, in the placebo control trials, we did find that the HIV-PHIs were non-inferior in terms of cardiovascular safety in the dialysis population. However, in the non-dialysis population, there were certain trials in which they did find that they did not reach the non-inferiority margins. So that would mean that the non-inferiority basically means it's not worse than placebo. So if it didn't reach the non-inferiority margin, then that is something that flagged a safety concern for the FDA. But again, there are certain details which we need to look into in all these analyses. They did take different time points for analysis. Some of the analysis were done while the patient was on drugs. Some of the analysis were done 7 days after the study was completed. There was a disproportionate increase in the dialysis population in the roxadustat arms. There are a lot of heterogeneity in all the trials as well. In terms of the hemoglobin targets that they used, they did use higher targets of hemoglobin. The targets were not very specific, but in many of the studies that the hemoglobins that were achieved were actually higher. So where the cardiovascular outcomes are poor because of higher hemoglobin targets, should we be a little bit more conservative in starting the PHIs instead of going at a higher dose and then downgrading the dose? It might be more prudent to start at lower doses, monitor the hemoglobin, similar to how we do it with erythropoietin at present.
Yeah.
Along with that, there are also several other disadvantages. Actually, we already saw the thromboembolic events. Certain formulations can have other disadvantages in terms of vascular calcifications. There may be hyperkalemia, which, however, in the DREAM and the trials of deciduous
very less
they did
percent.
not show an increased risk of hyperkalemia in both the trials. And the other major concern is it increases the levels of PEGF. So we should be given in patients with active diabetic retinopathy. Again, it's not been well studied. In the controversies conference, they do mention that there was no signal for worsening of retinopathy. But again, more studies are required.
Cyst
formation does definitely increase, so we should avoid this in ADPKD patient. We don't have data for pediatric population. We don't have data in transplant population. So these are certain things that we really need to look into.
So this is the one what I think, yeah, please.
I think that it's heterogeneity, the response, particularly all the studies with the Japanese, they have not been.
Correct. Yeah.
favorable
Genotype, phenotype
results. Yeah,
differences,
yeah.
global are there.
Most of the
Yes.
studies, they have showed a beneficial effect. In fact, what I want to say is that these are short term, maximum. I
Yeah,
think
exactly.
24
Correct.
24 weeks, but all these.
24, 56, 26, 52.
Yeah, and all these malignancies and retinopathy, I think we need to have
Long-term follow-up, yes, absolutely. So any drug, I think we need to have long-term follow-up. By that time only we can understand whether it's completely safe. But as of today, standing here, sitting here, we can say that HIV/PHI is safer. We can use them, in fact, liberally in a good group of patients. Okay, another 5 minutes. Okay, are there any specified indications, Vanlata, for HIV/PHIs?
I was saying, particularly for added advantage of particularly when
Patients with,
inflammation and when
where there is a markedly
so
high,
iron
yes.
help, in improving the iron transport and then mobilizing the iron from the iron stores. So I think these are the added advantages.
So what madam said with high ferritin patient, yes,
Yes,
you can
that
use.
we can
yes.
use that, and most of the CKD patients are in a pro-inflammatory condition.
Correct,
So in
absolutely.
these also,
So in situations of inflammation, you can still use HIV.
most of the studies also have shown that there is a beneficial effect of lowering the lipid, periods, particularly even with Indian studies, Green studies, they have shown that there is a decrease in the LDL cholesterol.
Pleiotropic effects, multiple are there. And of course, this slide is about what is the drug which is available. I think Sandhya has just discussed Desidustat, which is approved in India. The other things, other drugs of HIV/PHIs are not available in India. So if you look at this, this is for engines which we have made. This is something which is of relevance of Roxadustat with all the mountains. The trials all go with the mountains names: Andes, Sierras, Rockies, Himalayas, Optima, Olympus, Dolomites. Dolomites, I came to know all these things when I was studying this. Dolomites is a huge mountain range in Italy, it seems. So, so Himalayas, if we go, there is hypoxia. Agreed. So this is a little, little corollary that the engine can remember about the trials of Roxadustat. In a similar way about Vadadustat, it is O2. In every trial you see innovate, protect, O2 will be there. So this is another blind thing that we can take. And Desidustat, D, Dream D and Dream ND, Depredustat, you ascend with Depredustat, SND or SNND, and Molidustat, MIA-B M. So these are the little informations that we wanted to give to the engine. And a question to you, Swanlata, what do you know about the thrombotic risk of HIV/PHIs? Yes. Correct. Absolutely. They're not completely free of the, yes. But then the targets, hemoglobin target is of more importance. Yes. It's always prudent to have a target of around 11.5 in dialysis, not beyond that, at least in our population.
Not completely safe. There are evidence associated with hypertension, cardiovascular mortality, and problems. So obviously we have to make it. But having said that, all the studies, they have not shown any, increased complication compared to the existing cases.
Correct. All these, whatever have been shown here, are associated with a higher thrombotic risk. What about the effect on hypertension, Sandhya?
Actually, this some of the studies have shown an increase in the blood pressure with
This is animal studies.
Even the Dream Team and the Dream ND trials, when we look at the drop in the systolic blood pressure and the diastolic blood pressure,
Two more.
it was a little,
I'll just wind it up.
That was a
Four
not
slides.
significantly greater decrease in the blood pressure. Residue
Huh?
status. But study dedicated to blood pressure changes with PHIs is still elevated. That is the SNPT. So that once we see that, we will know the effect. It also decreases the lipid
Pleiotropic, yes, absolutely agree. So are there any guidelines? Yes, of course there are. APSN guidelines, the South Asian guidelines draft version is available. It's yet to come. So there are certain indications when to use HIV/PHIs. Madam?
Indian Journal of Nephrology will publish our guidelines.
Yes, draft version is there. Yes. So this is a summary of whatever we have discussed with respect to each agent of anemia, that is therapeutic agent of anemia that's available. This is what KDIGO says about HIV/PHIs, ESAs, and iron compounds. Not that all are not with disadvantages. There are certain advantages, there are certain disadvantages. We should be prudent in choosing when, what, and how far. These are all important for us. when we are treating the anemia. But what is not known is the impact of HI, pH, and iron parameters. What are the targets that need to be there? And of course, in inflammation, we are saying that it can be used, but then a definitive evidence for the same impact on the CV health and mortality, and which CKD groups would benefit max. What is the role in pediatrics? What is the role in transplant scenario? Do they have role in the CKD progression and prevention? In anephric patients, as one of the discussants was mentioning about the hepatic EPO. So is there a role for HI, PHI in this, and drug-drug interactions? These are all to be known for us. So before I wind up, I just want the chairpersons to give their comments, to share their experience too on the latest drugs, that is the HI, PHS. Madam, you have the yeah. Please.
So impact of HIP PHI on iron parameters, and what are the iron targets before HIP PHI? There is no guideline yet how to address this, but it should go with the standard practice that we make that the patient should be iron replete. We should not expect an absolute iron deficiency patient to do well even on HIP PHI.
Okay.
Yes, the relative iron deficiency markers, if we can make out,
yes.
not the indirect surrogate markers, but if we can make out the true markers of relative iron deficiency, then we can sort out few people and look at in our future research that whether this hexadine concept is really working clinically or not. Role of HIP PHI in inflammation is not yet known, but definitely the patients who are having inflammatory reasons to have a relative iron deficiency are likely to do better with PHI. Again, either observational or a true RCT type of things should come out. Even observational will help it with surrogate markers. And impact on CV health and mortality, as King remains yet non-conclusive. We need to look at many more data and generate our data. The world moves on the data itself. So which CKD subgroups would benefit max? We have been talking about that the relative iron deficiency or patients who are long-term on pump care because of the access crisis. We can try particularly on them and can generate an observational data. And we can show those in those patients, CRP and other inflammatory markers would remain relatively higher than the patients on fistula axis. So that way we can make two groups and look at again and generate our data. That's a future research question that needs to be discussed with our trainings, and in future we may mentor those things. Do they have a role in CKD progression prevention?
Again, yeah, these are all open questions. Yes.
CKD prevention progression, the mechanisms we address, HIP PHI is not a player in those mechanisms. So I think it's again still a far-fetched thing. HIP PHI in anephric patients.
Yes, I mean, certain molecules are there, novel compound is there, which enhances only the hepatic EPO production, and apparently, yes, there is a role. Yes. Dr. Sanjay, your viewpoint, not on all the questions, but at least in general. Yeah, in general. Just give me 1 minute. I'm just winding it up.
I was part of the group.
Fantastic. Yes.
Presently also I'm using patient. I have more than around 15 or 58 patients on my. And one thing I found out is they are effective, but you don't see a sustained response in all the patients.
Okay.
There is a variability in the response. So one thing is once you get a response, then it is very easy to maintain the patient. Because again the dosing is just 3 times a week.
Yeah.
And the cost for the patient comes down significantly. And I have not seen any major side effects associated with all the questions that are listed here. We still are in doubt even with EPOs.
Agree.
So we don't have any data on that. Probably we need to generate our own data. But I am more comfortable with the use because my idea is improving the hemoglobin will in general translate to a better quality of life. That is the underlying thing that we need to do.
Absolutely. Completely agree with Dr. Sanjay. I think there's a lot of loads of info that we have given to you. I'm sure everyone has enjoyed this session. So thank you so much. If audience question 1 minute, probably we can take, because already the organizers are behind me because I'm overshooting the time. If any question? Yeah, I'm just projecting that. Any question?
comment that.
A quick comment, Manisha.
Yeah,
Hmm.
fortunate to be a part of KDIGO guidelines and all the questions raised here are particularly addressed in
Pertinent.
that. And also fortunate to be a part of IFN group which Madam mentioned. So India will also have its own guidelines.
Thank you. Any other comment, please? Any other comment from anybody else? Otherwise, I just move on to the last slide. This we have circulated to everybody. This is a survey that we have created, our group has created, so that we have an idea about the practice patterns of anemia in our scenario, in Indian scenario. This is a QR code that is there. You can take a screenshot of it. And the link for this survey has also been circulated in good number of groups. It will also be received on the mail. So post this session also, we want to continue the connectivity with you so that we get a good amount of information so that we understand where we stand as far as the anemia practice patterns are concerned in Indian scenario, which is a diverse scenario. So thank you. Thank you so much. Thank you, the organizers, especially my friend Maitri and Renuka Satish Madam, for giving me ample time, an hour plus 10 minutes to complete this session, and my wonderful panelists who have been struggling over the last few days to work on this whole information, and my chairpersons, Dr. Arpita and Dr. Urmila, who had stepped in instantaneously, and of course, Sanjay, who has been part of many studies. Thank you. Thank you so much. And thank you, audience. Thank you. Thank you, everyone.
Thank you, speakers, panelists, and thank you, Manjusha ma'am.
Madam, thank you. Arpita, madam.
Our next topic is injection therapy in living donor transplantation. And I would like to call the chairperson for the session, Dr. Shruti Tapiawala, nephrologist, renal transplant physician, Global Hospital, Mumbai, Dr. Gayatri Bora, Assistant Professor, Guwahati Medical College, Guwahati, Dr. Jayalakshmi, Professor, Madras Medical College, Chennai, Dr. Rama, Assistant Professor, Osmania Medical College, Hyderabad. And I would like to call the chairpersons and please introduce the speakers.
The next talk is going to be induction therapy in living donor kidney transplantation, and talk will be given by Dr. Garima Agarwal. She is a consultant nephrologist in Manipal Hospital, Bangalore, and I request her to start with that.
Hi, thank you, chairpersons, for that introduction, and thank you, Win Icon, for this opportunity. I'm going to be talking today about induction therapy in living donor kidney transplantation. So the scope of this talk, first, I know this is the pre-lunch session. I won't bore anybody too much. I'm going to just talk about why we use induction agent, what is the classification, the commonly used induction agents, mostly in the Indian scenario, a comparison between some of them. So the primary first question being, why do we use induction agents? This was a large meta-analysis concluded in 2009. They took all kidney transplants across the board and they divided them into ATG versus no ATG, and the maintenance was CNI, ASA, and steroid. And they didn't include any multi-organs or pediatric transplants. Finally, 4 studies were included. And this showed that when you look at the no ATG group, this was early on, induction agents were just starting to be used more commonly, that there were significant rejection rates in the no ATG group at 6 months, at 12 months, and all across the BAMF. So also the chronic rejection rates were more in the no ATG group. However, when we looked at the graft and the patient survival, they were similar. Something to note here was what they did find was in the ATG group, the CMV, the leukopenia, and the thrombocytopenia was significant. We already know that. Other than this, there was a large Cochrane meta-analysis in 2010. This compared IL-2 receptor antagonists with placebo, and they showed that the biopsy-proven acute rejection rates were 30% lower in the IL-2 receptor group versus placebo, and the graft loss was reduced. Now, looking at this data and many other studies of the time, KDIGO, which is why we do what we do, in 2009, issued a guideline saying IL-2 receptor antagonist should be used as the first-line induction therapy in all kidney transplants, except maybe identical twins. And in high-risk transplants, you should use a lymphocyte-depleting agent. What do they mean by high-risk transplant? They say high number of HLA mismatches, maybe a younger recipient, older donor, Black ethnicity, more relevant for the US, panel reactive antigens, any percentage positive, presence of donor-specific antibody, blood group incompatibility, or a large cold ischemia time. So, so finally, like I'm just starting right here with when do we use induction agents? We use them pre-operatively because obviously that's when your risk of getting rejections is highest. So they are initiated pre-operatively and continued for about 3 to 14 days after transplantation. Why do we use them? 3 main aims from all the data I studied: to reduce the incidence and severity of allograft rejection and ultimately improve graft outcomes, here's hoping; to allow reduction of avoidance of calcineurin and steroid maintenance therapy, so to prevent toxicity, so where you want to lower down your maintenance, maybe then; and to deliver immunoregulatory state or so tolerance, so future the reduction of immunosuppression would be better and the graft survival would be better. So this was, we know the when and the why. So what are the common induction agents and how do we classify them? There are 2 classifications. You can classify them as monoclonal or polyclonal. Monoclonal would be anti-CD25. We know basiliximab, dacilizumab has been withdrawn because the manufacturer just didn't think it was making enough money. Anti-CD3, OKT3. We know anti-CD52, Campat, not used anymore. We use alemtuzumab, and anti-CD20, rituximab. Polyclonals, of course, what we are all very familiar with, ATG, that comes as rabbit ATG, ATGF, and ADCAM. You can also divide them as T-cell depleting and non-T-cell depleting induction agents. T-cell depleting are anti-CD3, OKD3, I already told you, ATG, alemtuzumab, and non-T-cell depleting is the IL-2 receptor antagonist. So I just put this slide here to tell you, we all know this in our transplant centers. We know the induction agents are now used very commonly. This was data from India where they showed a single center did about 700 transplants and showed from 2005 to 2010, the use of induction agent almost tripled. And so now we go on to the next part of my talk is what are the most commonly used induction agents? So IL-2 receptor antagonist, I wanted to start with the mechanism of action. We know that it's the antigen presenting cells, it activates the T cell then releases IL-2. This IL-2 is going to proliferate the T cell and starts this vicious cycle, which is going to reject your graft. So the IL-2 receptor has, of course, the alpha subunit, and this is where the IL-2 goes and attaches. Basiliximab is a chimeric IgG1 monoclonal antibody. You can see in the image in green. It goes and attaches here to the alpha receptor, alpha subunit of the IL-2 receptor, and hence doesn't allow IL-2 to attach to it, which is why it's not a T-cell depleting agent, but it decreases the proliferation of the activated T-cell. Now, so coming to the commonly used agent, we have Simulec manufactured by Novartis, probably used in low-risk transplants. There's some centers, if you have a patient already with leukopenia, you wouldn't be comfortable using a depleting agent. Dose is usually 20 milligram, given 2 doses, day 0 and day 4. And the cost, I've given all Indian numbers, and the cost comes to about total cost of therapy of 2 doses, about 1.5 lakh for the patient. Coming to ATG, now the concept is, and this was developed even before IL-2 was developed. The concept is when you inject a lab animal with some human lymphocytes, the animal's immunogenicity is going to work and it's going to have sera, which contains lots of antibodies and bad stuff against the lymphocytes. And that sera was then used and injected in patients to hopefully, decrease rejection. That's where ATG came into being. There are 2 types of rabbit ATG. I just wanted to stress on this slide because I get so confused about Graflon and thymoglobulin. I want all of you to know there are 2 types of rabbit ATG. When the human thymocytes are injected into the New Zealand rabbits, it made thymoglobulin. When the Jurkat T cell line is used into the rabbits, it made ATGF, which is Graflon. And of course, we have ATCAM, which uses horse sera, but that's mostly used in hematopoietic and aplastic conditions. So these are the 3 types of ATG available. Coming to the mechanism of action of ATG, intuitively, we know that obviously it's going to deplete the T cell because it has all this anti-T cell bad stuff. But it's not only the T cell depletion that the ATG does, it also induces B cell apoptosis. It interferes with the dendritic cell functional properties. It, in fact, even interferes with the cell surface molecules, and which is why it has some role in delayed graft function. You know, when you have a cadaveric transplant, long cold ischemia time, we prefer ATG, and we know reperfusion injury responds better to it because of its role in cell surface molecules. Of course, it induces the TREG and the NKT cells. So varied mechanism of actions and how ATG works. So this is the commonly available ATG preparation, thymoglobulin, high risk transplants, protective against reperfusion injury. And to be honest, when, and probably all KTRs, when I ask people, informally, a lot of centers have mostly shifted to ATG or thymoglobulin use, and IL-2 is not being used as much. So the doses are very, very different. Abroad, they're using 3 to 5 milligrams, going up to 6 milligrams per kg body weight. I don't see any centers going beyond 3 milligrams. Here, we are a low dose ATG center. We go to 1 to 1.5 max. So the cost of ATG therapy comes at about 1.6 lakh. But please remember, you'll have to give the patients Valgan cyclovir, which is another 40 to 50,000 to the patient. Coming to Graflon, this is for, I guess, for moderate to high risk kidney transplants. Good drug. And I think the most important indication of late was when thymoglobulin was not available. We had no choice. So we all learned how to use Graflon. So the dose is recommended is about 3 to 9 milligram per kg body weight. Around 6 or above is used everywhere. The general rule we all follow is just double of the dose of ATG you give usually works for Graflon. And for a 60 kg adult, the therapy comes approximately to about 1 to 2.2 lakhs. I wanted to mention alemtuzumab. I think it's being used. I had exposure at Amrita in Kochi. They used it for simultaneous pancreatic kidney transplant, but I believe Apollo Chennai, Dr. Vaidya is using it even for regular transplants, not only multi-organ. So what is alemtuzumab? It's a humanized IgG1 monoclonal antibody directed against anti-CD52. CD52 is present in virtually all B and T cells and macrophages and NK cells. So it depletes lymphocytes like anything, lasts for about a year. I know a lot of my friends practicing in the UK who say that they just need to give 1 dose and they like it because it's cost effective. So this is what it does. This is the mechanism of action of alemtuzumab. Now we come to the other part of the talk, induction versus no induction. So I have some data and I try to concentrate mostly Indian data, but let's look at this. So we go to the Cochrane analysis. Remember, I mentioned that KDIGO formed its guidelines based on that. But when we look deeper into all the studies that were included, these studies were mostly from the 1990s and 2000s. The whole transplant game was different back then. When you go deeper into the data in the studies used in the Cochrane analysis, 87% were on cyclosporin, not on tacrolimus. 50% only 50% were on mycophenolate, 28% were on azathioprine, and 22% were only on dual immunosuppression. Also, back then in the 1990s, the acute rejection rates, they were looking at 50%. We are looking at less than 10 to 15% rejection rates. So the whole gamut has changed now. Is even IL-2 receptor induction relevant anymore? So I wanted to focus only on the studies of IL-2 versus ATG versus no induction, which use TAC, MMF, and steroid. I didn't want to go into the azathioprine and the cyclosporin studies because that's not what we practically do. So this is what I got. And I want you to notice the circles. If you look at the circles marked there, basically this Willoughby study, which used US data, it showed that the induction with IL-2 was 11% rejection rate and no induction was 13%, not statistically significant. Again, induction with IL-2, 11%, 13%. So these results are repeated in all the studies which are using the current maintenance immunosuppression that we use, that the induction rate, the rejection rates, even with no induction, are really, really low. So I wanted to point out this trial. This was a large Osaka trial. You guys, we have read about this. They basically did this trial to compare tacrolimus single dosing with double dosing. And they had 4 arms, but what it ended up being was an induction versus no induction trial, because 3 of the arms were no induction and 1 arm was induction, the one that I marked in yellow. And what they found was again the same thing, that at 6 months, the acute rejection rates in all 3 no induction arms with the current maintenance immunosuppression was barely 10 to 15%. So this comes to what we conclude. I here talked about only live transplants, low risk transplants. I didn't go into the high risk data. So the available data suggests that kidney transplant patient with standard immunological risk treated with tacrolimus, mycophenolate and maintenance steroids, the benefit of IL-2 is very modest or non-existent at best. Do we really need induction in these cases? Center specific, we all need to think about this and get more Indian data. Coming to the real challenge, the ATG versus basiliximab in high-risk transplants. I didn't want to put more studies. I just put up Indian data because none of us are going to use basiliximab in high-risk transplants. So, but I wanted to point out this study where they used low-dose ATG with basiliximab. This was Indian data. This risk was about moderate. And here they showed low-dose ATG at 1.5 milligram per kg, even in low to moderate risk transplants, showed lesser rejection rates than as compared to basiliximab. And the patient and graft survival was similar. This was a large study. This is the largest trial with ATG versus no induction, and it was published in the NEJM, and this is what most of the guidelines are based on. This study, they used 1.5 milligram per daily of ATG, and they gave it every day for 4 days. And they used basiliximab. They compared it with basiliximab. Cyclosporin, mycophenolate, and steroids was the immunosuppression. And you see the significant reduction in biopsy-proven acute rejection. It was only 15% in the ATG group versus basiliximab group. Antibody-treated acute rejections were lesser. Again, no trial has shown any death, censored graft loss, or death benefit, patient survival benefit with ATG versus basiliximab. Coming to this study, I just put this up, again, Indian data. I just wanted to know, okay, what about these patients in the past who have received ATG and basiliximab? Well, those results are good. This trial in this study from India, this was the Transimmune group from Hyderabad, and they wanted to see in the people who had received ATG 5 years ago, and they said that ATG versus basiliximab both did well. Because I know one of the arguments is like right now you're thinking there's no acute rejection, but people who receive ATG are probably going to do worse in the future. But this Indian data from Hyderabad seemed to not think so, and they said both did fairly equal, ATG versus basiliximab. So the conclusion, in high immunological risk transplants, RATG definitely preferred over IL-2 receptor antagonist, and even in low to moderate risk should we prefer low dose ATG over IL-2. Although, please remember, and I was really surprised, I found no data with all this reduction in acute rejection that we do. I found no patient or graft survival benefit data at all. So I don't know, with reduction in acute rejection, is it making us happier or the patient's body? Okay, coming to I'm sorry, this was wrongly mentioned here. This is thymoglobulin versus Graflon. Now, this is the big argument because we have Graflon available here. The centers in the US and the West don't. It's not FDA approved yet for kidney transplant. So we are commonly using it. And when we talk to each other, we talk about, okay, which is better? How do you use it? This was the large trial I found from the Medanta group in Delhi. And they did 570 transplants in a span of about 2 years. And they directly compared those who received ATG with those who received Graflon. They included, it was all living donors, but they did include ABO incompatible transplants. And Graflon group had a little bit more ABO incompatible. But what they found was that the biopsy-proven acute rejection rates were much lower in the ATG group, thymoglobulin group compared to the Graflon group. And the difference was statistically significant. However, when you looked at infection, even though numerically the infections were a little bit more in thymoglobulin as we would expect, but they were not statistically significant. Know that patient survival, graft survival equal in both the groups. This was because all this data is retrospective and single center. I was really looking for some prospective study from India, and the Kolkata group at Rabindranath Tagore satisfied. This is a prospective study. They did this in their center, single center study, 2019 to 2020. They took all of their transplants. All of them received TAC, mycophenolate. They compared those who received thymoglobulin with those who received Graflon. The thymoglobulin dose that they had given was 3 milligram per kg. And the Graflon dose was about 6 milligram per kg. And they studied rejections, patient survival, graft survival, and graft function. So they did find that the biopsy-proven acute rejection rates were less in the ATG group, but they didn't find any statistical significance. And the Kolkata group recommends that we can use Graflon or ATG interchangeably, and the efficacy and the safety is the same. So currently, where do we stand when it comes to induction therapy? We have no consensus. Every country, every center is doing their own thing. The selection of induction therapy obviously has to be based on a comprehensive evaluation of your recipient, its immunological risk, their comorbidities, and of course, the financial burden in this country. Patients at a high risk, I would go more towards the depleting agent. The choice of maintenance immunosuppressive therapy also affects the selection of the induction agent, because there are a lot of studies now where they want to minimize the steroids or minimize the CNI, and they are preferring ATG to be able to do that in the future. I just wanted to point this out. I think I'm much before. Is this okay? I'm good. So, okay. So this is my last slide. I just want to look at, are there specific groups of patients where we should be more careful? So elderly patients, we know elderly patients have lower immunity. They have senescent T cells. And so there is data to say that they suffer from more infections and malignancies and less rejections. Perhaps in an elderly recipient population, a dose of IL-2 versus low dose ATG rather than a full-blown ATG dosage. HIV patients. Obviously, intuitively, we know HIV meaning more opportunistic infections, but paradoxically, HIV patients who undergo transplant are also seen to have higher rejection rates. Most centers abroad, which are doing these transplants frequently, are preferring IL-2 over ATG in this group. HCV patients. We know that HCV patients, positive patients, have a poorer graft survival than HCV negative patients, and there's always this worry in our head of progression of their liver disease. In these patients, there was a large study by this group, which looked at 3,490 HCV transplants, HCV positive recipient transplants, and they found virtually no difference between any induction and maintenance therapy. So for HCV, their conclusion was like, don't worry, like do what you do for a normal patient. That's it from me, and we'll do the discussion.
Thank you. That was a good deliberation. Let me start the ball with the question. ABO incompatible transplant. What would be your take on the induction with the desensitization protocols?
Right. So thank you for the question, ma'am. Yeah, for ABO, we use rituximab as an induction agent, and we prefer a low dose induction agent. I looked at a lot of protocols, Mayo as well as Rabindranath Tagore, all the published protocols also using rituximab as a desensitization, most of them.
So what would be the induction agent?
Yeah. So induction agent with the ABO incompatible, there is some controversy there, because we would prefer, because thinking it's high immunological risk, to use ATG, but there is some sensitization that happens with ATG in these patients, and we see more rejection rates. So centers are preferring basiliximab with rituximab as a desensitization agent in ABO incompatible. And I'm not sure about the science behind it. I'm sorry.
So I'll just give you our experience, because we do a lot of ABO incompatibles, and we did a little bit of a study on this. And we actually found that Ritux with use for desensitization actually protects. And using ATG, whatever low dose, gives you a lot of neutropenia and higher risk of infections when Ritux is merged with ATG as a desensitization and an induction protocol. So that's why I asked you what was your experience, because we are now not using thymoglobulin where you have a pure ABO incompatible transplant. Yes, if it's an HMA incompatible transplant, then we will try to do swaps more than desensitizing them and giving more immune suppression. But I would like to invite comments and questions from the group.
Regarding the dose of ATG, I think you are just following the Western study. What I have found is I use only 100 milligrams of Grafla, which comes to around 1.3 to 1.5 milligrams per kg per year, which is quite adequate to achieve what you are, because as you have shown, use or no use,
right.
And all the studies that you are talking about, you are just talking predominantly about the rejections in the initial phase. Have they looked into what happens to the infections 1 year and survival 2 years down the line? Because I was seeing the presentation done by Premier Institute where they are using these kind of doses, which you have mentioned. And the infection rate was projected at around 48%. And the loss of the patient was projected at around 42%.
Right. Absolutely. So actually, I found the infection data in the Western studies, and our studies all stop at 12 months, and they are not very clear when they're using these dosages from the institutes that you mentioned. So yes, we are also in practice worried about these dosages in our patients. Right.
So we have, so our center does multi-organ transplants. We have organ, we have pancreas, we have PCS. So I have personally gone up to 10 to 13 mg per kg, and it has been relatively safe for that group of patients as well. And what we used for kidneys was 9 milligram per kg, and that seemed to be sufficing. So 6 was on the lower side, which literature and whatever we reviewed was showing a little bit of higher rate of rejection. We do not want to equate Western literature to us, but say for Indian population, what we have noted is that 3 milligram per kg of thymoglobulin, not more than that. Because below this, we do not get a higher risk of infection with appropriately given prophylaxis. And graph plot, around 9 to 10 milligram per kg for high-risk kidneys where we use. And for other organs, of course, it's not the 4-1, but they're 10 to 13 milligram per kg is used.
Yes.
I explained what the glucose atom is 3 times the dose of thymoglobulin dose.
Yeah.
Then you can compare your test with making but we use that dose.
Too much leukopenia also, sir, we see. Yeah.
This suppression, we see more of antibody mediated rejection. Very minimally
T-cell mediated, yeah.
But this injection has any role in preventing AVM.
Your question, madam, there is studies coming in with thymoglobulin induction. The formation of de novo DSAs are actually lesser.
Yeah.
There is lot of literature, many studies in transplantation in the last few years have actually shown
The de novo
thymoglobulin, your formation of de novo DSAs are lesser. So this, as madam said, we are discussing acute rejection. Acute rejection is a no-brainer now.
Yeah.
Less than 5%. We should not even worry about it. We should think of the long-term 50% graft loss, which is a chronic active or a late AMR. Their thymo has shown results, and they are actually just through a Google search, we find out very, very good articles coming out from.
Certainly, ma'am, the de novo DSA, they compared IL-2 with ATG, one study, and they said that ATG is better, but the graft and the patient survival outcome, because these studies are not long, none of them I found in my literature search.
We are actually looking at the elephant from two sides, either the trunk or the tail. There are many things which leads to AMR.
Right.
There is allorecognition, there is missing cell.
Right.
There are many other phenomena which actually leads to an AMR.
Absolutely.
But that is just not a lymphocyte subset which decides an AMR.
Right, absolutely.
I am from Madras Medical College, and we actually do not use induction for brain transplants on a routine basis. Like how you said, we use it for people who are more sensitized. And from our study, it's not a study which is still published, but it is one to observe from our data. From March 21 to March 23, we had total of 79 living donor transplants, out of which we did not give any induction for 43 people, because we go by the HLA haplomatch or more than that. These people we don't give. And we had given Desiliximab for 30 people. The reason was that we had a spouse living related donor. We do take it as a more or less non-related. And grandparents, we had younger people who had grafts with the grandparents.
Right.
And 17 parents we had basically because the donors had little elderly, second transplant basically, or the dialysis time was very long. So these people, 30 people we gave Desiliximab, and living related donor ATG we generally don't use. We use it mainly for the disease on the transplants. Okay. But we had given for 6 people, and we had 5 pediatric transplants. And for one grandparent given to the child. So our observation is that Even though there's a difference between the patient selection between where we gave induction, where we did not give. The survey normal graft function was 77% in the people who did not have induction. And it was around 68% the ones who may get induction. Maybe because of the choice of the sensitivity of the recipient, desensitization of these. And 80 is a very small number to compare with these. They had 50% graft function, 50% had a graft. So, I mean, I think we cannot have a head-on comparison. So probably in the same set of individuals, if you have to head-on comparison, we'll be able to tell you whether the induction is really doing anyway better.
But ma'am, if they are sensitized for some sensitization event and it's unrelated, would you still go with IL-2? Like in your high immunological.
For those people only we gave it.
So the small subset.
Small subset we gave it. I mean, our second transplant rate is not that high. We do it for a very small number. So those people will prefer it.
Yeah, that's good.
Transplant very high sensitive patient and very low risk patients, and most of them were to have seen that on using ATG, the risk of infection is very high. And whatever APMR is saying, we're seeing the long-term follow-up, not on the immediate part. So what is your experience about it? Do you think that in those who are the low risk, rather just like man has said that not to give any induction,
right,
or to give IR 2 inhibitors? So what is
Absolutely, ma'am. That's why I think my data is a bit biased itself, what I presented. I also think if it's low immunological risk, are we doing any justice except maybe spending another 2 lakh rupees of the patient and maybe some more risk of infection? However, IL-2 even didn't show an increase in the infection risk. So yes, low risk patients, good match. I think we can go without induction because our maintenance immunosuppression is so good now that I think we can be quite relieved.
I think everything boils down to for students and for juniors to take away. Everything boils down to how you immune stratify the patient. Because even if it is a related match and you have a haplo match, what if you have an HLA antibody against the mismatch? So a detailed diagnosis and a diagnostic pre-transplant of the sensitizing events, of the HLA antibodies, of the history of the patient is extremely important. This helps you immune stratify. At least in our country, we do not have a chance to go for repeated transplants. We do not want to waste the patient's money. We want to save them against infections. So immune stratify, use induction where required in a judicial manner, and of course, give good prophylaxis. I see that the prophylaxis is half-hearted. Valganciclovir, Septran, clotrimazole, lozenges, try to optimize them, try to teach hygiene to the patients, and I think we should balance things properly, is what I will say.
Absolutely. Thank you.
Thank you,
Chairperson. Thank you.
Short break of half an hour for lunch, and the next section of scientific program will start at 2 p.m. The lunch is arranged at 4 o'clock. Thank you. I'm public, sir.
We have not imparted against the CD. I have it, but I see nobody else. Spelling out words. He wants you to call on partial platforms now. I was in St. John's. She wanted, I was asking. She's in there, and I whenever I say Bob was in, I don't know say his name. I'm
Okay.
No, I saw her about half an hour back. She here then this start. You want to moderate us? More. Hi, Dr. Valerie, how are you?
Good, how are you?
This is Manjusha speaking. How are you?
Good, good, thank you.
Yeah, your, your PowerPoint has been in class and would like to share it live.
Sorry, I hear you quite badly.
You're not able to hear us. Is the voice bad?
I can't really hear what you're saying. I can hear you speaking, but the words are difficult to make out. Can you hear me clearly?
Valerie, are you able to hear us now? Is it better?
Sorry, what? Can you hear me now?
We can hear you, Valerie. I think we can hear you. You're not able to hear us, is it? Okay, I'll come on.
Ma'am, hello, ma'am, can you hear us?
Yes, now I can hear. Can you hear me?
Yeah, the speaker podium is working, the other mics are not working.
Okay, okay.
Hi, Dr. Valerie, you're able to see me now?
Yes, hi Manju, how are you?
How are you?
Good, good, how are you?
Good, great to see you. So your
Yeah.
PPT has been sent or you want to share it live?
I sent it and then I know it's exactly the right minutes. So maybe if you did the recording, that might be better. Is that okay?
Yeah,
Or do you
recording.
prefer
So
live?
we have the recording. Tech team, who is there? Gautam, Vikram? Gautam. Is there? Recording is there? Yes, yes, we have the recording. So we play the recording. And then you will
That
take
might
the
be better
questions
just
live,
to be sure.
Valerie?
I think that would be fine. Is that okay with
That will
you?
be fine? Right, absolutely.
Okay,
absolutely.
perfect.
Yeah,
Good,
yeah.
good. Then we know that it's exactly the 20 minutes.
Sure, sure, Dr. Valley, sure. Video camera, we have to touch every time, sir. Look, the slides on. Valerie, we're just taking some time to check on the PPT. We'll just get back to you, Valerie.
Okay, no problem. Otherwise,
Yeah.
I can always do it live if you prefer.
Sure. Yeah, the chairpersons are also ready. We will just start. We are just checking with the tech details of the PowerPoint.
Okay, thank you.
Yeah, please. She says it's recorded. What did you get recorded? Oh, join, madam.
Actually, there is some problem with.
No. Introduction speaker.
Okay, so the introduce the speaker. Yeah,
Thank you very much for inviting me to give this talk in this wonderful conference, and congratulations on the success of WIN.
I don't have any financial disclosures, but do like.
Yeah.
Now voice voice కింద సింబల్ వస్తుంది.
If you prefer, I can do it live. It's up to you.
Valerie, I can't hear you.
I
Yeah,
don't
please
have
tell
any
Valerie.
financial disclosures, but do like to declare my
If you
privilege.
prefer, I can do it live.
Oh, right. Okay. We'll just project the slides, or you want to share the slides?
Implementation research.
I can share the slides.
You can share the slides and do it. Can we have the
Is that
tech check?
easier for you?
Yeah. Great.
Is that
Excellent.
better for you?
Can we have the tech check, Valerie? You can just share the screen. Yeah. Perfect. Perfect. Slideshow. Perfect. Yeah, absolutely. We are good to go. Dr. Valley.
Okay,
Yeah, we
now
just keep it at this. Yeah. Please
Okay,
be
just
online
one
and we just
second.
keep it at this. And if you
Okay,
can
just
just
one
project the
second.
first slide in the slideshow mode, we'll start the session, Valerie.
Okay, I just need to get rid of the talking on my
All right. Okay.
presentation.
Right.
Just a second.
Right. Waiting.
Just save it, and let me just get rid of then of all the stuff there.
Right.
Okay, so hopefully, can you see that now?
Can you put it in slideshow mode, Valerie? Excellent. Perfect. Perfect. Yeah.
Okay.
So we are good to go. I think the chairpersons are also here. So we start the post-lunch session, Valerie. We just wait. Yeah.
Okay.
Welcome back. So we have the first session post one. So the topic is ethics of implementation research. And for the session, I would like to call the chairpersons Dr. Anuradha Raman, consultant nephrologist, Sunshine Hospital, India. Dr. Suma Raju, consultant nephrology, Narayana Multispecialty Hospital, HSF Layout, Bangalore. Dr. Jyoti Ramachandra, consultant nephrologist, Sagar Hospital, Bangalore. And now I invite the chairpersons to introduce the speaker.
Good afternoon. Good afternoon, everyone, and welcome to this post-lunch session. Welcome to this post-lunch session.
It is my privilege to introduce Dr. Valerie Liu, consultant nephrologist, Brigham Women's Hospital, University of Zurich, University of Cape Town, South Africa. And the topic which she has chosen is ethics of implementation research. I mean, this is the topic which is not very familiar to most of the clinicians as much as it is to the researcher. The concept is to execution or practice of a plan, a method, or any design, idea, or a model, a specification, standard, or policy for doing something. So when you have, how to implement what if there is some, so you have an idea and how to implement it for in clinical usage. And I think this is, we are looking forward because we have very little knowledge about it. Over to you, Dr. Nand.
So thank you very much. Can you see my slides?
We can.
Okay, great. So thank you very much for the invitation and to participate in this landmark second conference of WIN. Really, again, as usual, I have enormous admiration for all of you participating in all of this and all your energy, all your knowledge, etc. So over the next about 20 minutes, I'll be discussing actually more about the ethics of implementation research. Sorry, I'm trying to make my slides go forward. So I don't have any relevant financial disclosures, but I always like to disclose my privileges. And specific for this talk, really, I've been privileged to be a member of the Ethics Committee of the European Renal Association. I'm a member of the Swiss Ethics Committee, but here specifically, I've actually worked on the ethics of implementation research as a consultant at the WHO. And so this has really been a wonderful experience, and I'm happy to be able to share this. So the objectives of what I'd just like to cover today are to understand the key concepts of implementation research. As we just heard from the chair, it's very important to take what we know into from evidence into policy and into action, and then recognize the importance and the value of ethical principles in the conduct of implementation research. And then examples. I'll give a couple of examples throughout the talk. So the first very important piece of information is that, interestingly, and this has been quite reproducible over the last couple of years, we know that it takes about 17 years to get evidence into practice. And we're really now sitting with all this fantastic information about SGLT2 inhibitors, for example, and the question is it going to take 17 years before this is really taken up in practice? So this brings us to this issue of implementation research, and here is a link to this ethics guide that I worked on, because implementation research really is trying to take what we already know, taking evidence-based medicine and bringing it into daily implementation. But the question is, why does it take 17 years? And so implementation research is really trying to understand, how can we narrow that 17-year gap? How can we understand local barriers? And in local specific contexts, what are issues that need to be overcome so that we really do implement good evidence-based medicine everywhere? And basically, implementation research started off being really in neglected tropical diseases and infectious diseases, but now increasingly, and especially since COVID, we've seen how NCDs have been neglected. It's become sort of a hot topic in the last 2 to 3 years that we really urgently need implementation research in non-communicable diseases. And this is a very nice infographic from a great paper on this topic. It's really talking about cardiovascular disease, but to me, this really applies very equally to kidney disease. So if we look at why are so many people dying of cardiovascular disease or kidney disease, we need to think, yes, we know there are a lot of risk factors, and we know that if we reduce risk factors, we could significantly reduce the burden of disease. We also know that a lot of people with risk factors are actually not at goal, even when we're treating them. We know that a lot of people remain undiagnosed, and this in kidney disease is a huge problem. We know that even when people are diagnosed, most people are actually not on medication, and even ACE inhibitors are about 50% of people are getting ACE inhibitors when indicated. This is a lot lower for the SGLT2 inhibitors. We know that when people need specific interventions, they may not be getting it. We also know that patients might get the prescription, but might actually not be swallowing the tablets. And then we know that there's a lot of care that patients don't have access to. And for us, often this is dialysis, transplantation, and even supportive care. So the huge question is, there are all these gaps. We know the solutions. We know that by reducing risk factors, by controlling blood pressure, controlling diabetes, giving the right ACE inhibitor at the right time, SGLT2 inhibitor at the right time, we could actually impact the burden. Question is, why are we not doing this? And implementation research tries to answer these questions and figure out, how can we narrow these gaps? How can we get more people's blood pressure controlled? How can we get more people on an ACE inhibitor and SGLT2, for example? So just coming back to the idea of research per se, research always should have an ethical justification, and then we need to recognize the responsibilities that come with this. And so the ethical justification of any research needs that it should have social value and scientific value. And then in terms of responsibilities, respect for participants' rights and welfare has to be the very first priority, but we need to be careful as well that research is done by trained researchers so that the quality of research is good. We need to be very careful to disseminate research findings. In COVID, we realized there was indiscriminate dissemination and even fraudulent publications, but we really need to disseminate research findings. And I think when we're doing important implementation studies, we need to disseminate also negative findings, where we realize that something didn't work, because we need to share why something didn't work. And then there needs to be public accountability, especially when research topics are impacting public health. So we all know the key ethical considerations from the Beecham and Childress medical ethical principles, and these three principles apply equally to medical research. That whenever we're doing a study, we need to be very careful that we balance the benefits and the risks of potential harm. We need to uphold participant autonomy, especially in clinical research when we're researching on individuals. Individuals need to understand what we're doing, why we're doing, they need to agree. And then in research, one needs to think about justice questions, which are we including the right people, and are we giving the right people opportunities to participate? And also, is the research question something that will address the needs of the community? And so this is really the typical research that we all know about when we're thinking of clinical trials, randomized control trials, observational trials, even case reports. But now we come to this question of implementation research, and implementation research really takes place in the daily running of a clinic or a hospital. It's not happening in an artificial setting like a randomized control trial. So it's really trying to add something new into the flow of work, for example, in a primary care clinic, or to try to figure out why is some public health messaging not really getting across. And so the ethics of implementation research really overlaps a lot with the ethics of public health, which include things of solidarity, transparency, accountability, being careful to engage with communities to explain what's going on. So in this publication, as a preamble to this ethics document of the WHO, together with a colleague, Vijay Gopichandran, we developed the sort of concept that one needs to look at implementation research very, very early through the planning. And one needs to look at the planning phase, the implementation phase, and the post-research phase. And there are a lot of ethical concerns that one needs to consider in each of these phases. And this is what I'll be discussing over the next couple of minutes. So if we think about ethical concerns in the planning phase, it's very important to plan implementation research. And as I said, this is something that's supposed to be answering real questions that are on the ground, very often trying to translate at least what we know in terms of evidence-based medicine into what we do in terms of daily practice. So it's crucial that the implementation research questions are actually responsive to the community's needs. And this comes back to this issue of the importance of community and stakeholder engagement, because very often you have to go to the community and find out, is something important for you? Sometimes even the community might come to the researcher and say, this is a problem for us. So there has to be, the research question must answer problems for the community. Of course, there needs to be a strong scientific rationale, and then the study design and implementation research needs to be very well thought out, because one needs to figure out how can this be implemented in the daily routine. Because of that, one needs to be extremely careful about local contextual factors What are the demographics? What would the population approve? What is even possible? What is doable in the situation? One needs to think, who are the research participants? And sometimes in implementation research, the participants are individuals like general medical research, but sometimes they're actually entire hospitals, entire districts, entire health systems that might be randomized to a certain intervention. So the participants per se can actually be different. And then one needs to again weigh the risks and the benefits, because implementation research is very high stakes. And so one doesn't want to start testing a certain treatment in a certain community if, for example, we're not sure that we can then give this community this treatment later on if it turns out to be worthwhile. So in terms of responsiveness of the implementation research, one actually needs to have data before one can even think about this. And so we need reliable data within the community. So this would mean that the health system has collected this data and have identified a certain problem. One needs to be careful about whose agenda is driving the research. We need to be very careful. A lot of this research happens in low and middle income settings and should not be driven by donors wanting to answer specific questions. It needs to be driven by what's necessary as a research question in the community. So this means there has to be some sort of prioritization of the clinical needs as well as the research needs in the system. As mentioned, whatever the research topic is, the solution should be scalable and sustainable over the long term. Otherwise, this should not be researched. And one needs to be very, very careful when is reaching the hardest to reach and the most vulnerable in the communities, because there are often very big barriers, and these are exactly barriers one wants to address with implementation research. So one shouldn't be looking at the low-hanging fruit and going and testing easy communities. One needs to think, how do we get to the hardest to reach? And then with all research, there's this question of equipoise, and sometimes there is a debate about whether equipoise even exists in implementation research. So this issue of equipoise means that there's true uncertainty about the effectiveness of an intervention. So for example, when one wanted to study the SGLT2s at the beginning, we really didn't know if they worked. And so in that case, it's very justifiable to go ahead. In implementation research, however, we now know that an SGLT2 inhibitor works. So is it justifiable to do the research? But in implementation research, as I've mentioned, the context is very critical to try to understand why are the SGLT2 inhibitors not being prescribed in a certain community, or why are blood pressures not well enough controlled in a certain community. And so here, for example, is an implementation research project that was undertaken in Mumbai to try to understand how can one deliver better hypertension care in private sector clinics in urban slums. So this is a typical group of patients that tend to be kind of forgotten about or neglected. And here they actually use very established mechanisms to manage hypertension. But the question was, how do these mechanisms actually get taken up? How can we make sure they're used well and appropriately in these contexts? So equipoise can be contextual in implementation research, and that's enough to justify the study. Very important in any research is to be careful about equitable distribution of benefits and harms. And in implementation research, as mentioned, one needs to think about potential benefits from the participants, but also possibly from the society. And this means one also needs to think about possible research burdens and research harms for the participants and society. For example, if one's randomizing entire hospitals to certain things and one hospital doesn't perform well, there's a very big risk of stigma and bad reputation for that hospital. When one is doing an intervention, one also needs to think, what is the potential harm for the control group? And then one needs to also think of unanticipated harms. Very often researchers come from outside of the context and they may not know, and they may overlook certain potential unanticipated harms. So these are all important things to consider in the planning stage of implementation research. And when one's thinking about risk, one needs to do a good risk assessment. One needs to think about individual harms, as we said, very obviously, if there's an intervention, what is the actual risk for the person getting the intervention? Is it even acceptable to have a control group? Is that ethical or not? Is the standard of care for a control group acceptable? And what are ancillary care responsibilities? It might come up, and I'll discuss these a little bit more later. Then one needs to think about social harm, stigmatization of groups, for example, entire hospitals or districts, stigmatization of individuals in studies that, for example, are focusing on HIV or some sort of other stigmatizing problem. And then one needs to also think about the excess burden experienced by marginalized groups. And if we think of CKDU, for example, these populations are getting very over-researched. And so this should also be a consideration. We shouldn't only use populations because they are vulnerable. We need to think about financial harm depending on the research question. For example, if we want to get patients to come for follow-up in transplant clinics, we might need to think, okay, we need to give patients incentives or vouchers if they're from a pure community. So these vouchers might help the patient to pay a taxi to get to the clinic, but this could be quite destabilizing to the local taxi economy and would obviously exacerbate inequities between patients attending transplant clinic and general patients attending the CKD clinic. So I need to think of potential consequences of one's research idea. There may be communal harms. Cultural insensitivity is extremely important to think about in the role of women, for example, in certain populations is important. And then one needs to think about harm to the health system. And very, very importantly, as I mentioned, implementation research is happening in the clinic every day. And so here we may not have special research teams, as happened with randomized control trials, for example. So we're using regular public health nurses or clinic nurses, clinic doctors to actually start documenting extra things now in a research study. And so we could overwhelm these frontline healthcare workers, and their time may not be available then for other patients, and we may actually divert resources towards the study because sometimes these people might be getting little extra money, etc. So we need to be very, very careful about all these potential harms when we're planning a research study, especially in a weak health system and in low and middle income settings. As we mentioned, the research topic needs to be very vulnerable, very relevant for the community. So community engagement and stakeholder engagement is very critical. We need to include everybody. Even, for example, in the taxi voucher example, we need to include the taxi people in planning the study. So the question is, when should we do this community and stakeholder engagement? Where? What should we actually discuss? When should this happen? Just at the beginning or throughout the study? It's generally recommended that one engages with the community throughout so that they're kept up to date. And with whom, as we mentioned, we need to make sure we include everybody at the
We
table.
have 5 minutes left for the talk.
The ethical norms underpinning community engagement are also important. So here we have the 3 basic principles of biomedical research: respecting people, being careful only to balance risks and harms, and justice. But accountability, solidarity, and transparency are very, very key because, as we said, this research is happening in the public health or the primary care clinics or the hospitals. And so often patients might think that the research is actually clinical care. We need to be very, very careful that everyone involved understands and that the people running the studies as well are engaged with the Ministry of Health. There's accountability for follow-up. There's solidarity, meaning we're asking the right research questions. And one is very transparent in terms of how the study is actually going. We've mentioned already that there needs to be sustainability. If the study shows something works, it needs to continue. And therefore, there needs to be public justification so the public actually trusts the system. Identification of non-obvious risks of implementation research is a very good reason why we need community engagement. And this is an example of an implementation research study that happened in Canada. It was called the MyTemp trial and used the study design of a pragmatic cluster randomized trial. So here what happened is that entire dialysis units, so not individuals, were randomized to cooler dialysate for the patient in the hope that this cooler dialysate would actually lead to more hemodynamic stability. Interestingly, when one reads the study, it was negative, but what the authors state is we anticipated that a personalized approach to dialysate cooling would be better tolerated. And they basically stated that when they surveyed respondents after the study, the respondents in the personalized cooler dialysate group stated they were more likely to report feeling uncomfortably cold. And this is a big question for me. As a clinician at the bedside, one knows very well that when we drop the temperature of the dialysate, the patients become uncomfortably cold. So my question is, if they had done better pre-trial stakeholder engagement in the trial, they would have probably uncovered that the patients would have said, we are worried that we will become very cold. The question is, how would the researchers have gone about with this information? Would they have said, okay, the patients will get cold, should we increase the dialysis room temperature? Should we provide more blankets? But how will this maybe impact on the patient's actual body temperature? Or they might have had to admit the patients would have said, even if this works, we don't want to sit in a shiver for 4 hours. They may have said the study's not worth doing. So this really, to me, brings up a lot of issues about the idea of involving the stakeholders before a trial. Now we move to the ethical concerns of the research phase. And very important, informed consent, we all know, is critical. But this study really just shows that the quality of informed consent is very, very, it's not as good as we think. So here, for example, in both developed and developing countries, the spectrum of patients who were surveyed after giving consent, who actually understood the purpose of the study, was very broad. Never mind all the details about the study. So we can see that not everybody really understands what they're doing when they sign informed consent, and this is a problem. And especially in implementation research, when we're dealing with vulnerable populations, this is a big problem. We need to recognize all the barriers, which include cultural context, might be stigma, confidentiality. The local perceptions of autonomy are important. For example, in many places, women might not be able to give consent directly. They might need their husbands or their elders to give consent. Illiteracy is a very big problem. Do research participants actually understand words like placebo, randomization? We need to think in certain communities, people are very skeptical about signing a paper. So how do we actually prove the consent? And then we need to think when vulnerable populations are included, like children, pregnant women, etc., how do we get consent from these populations? This is another pragmatic cluster randomized trial done in Canada in dialysis units. In this particular one, they randomized entire units to different magnesium baths. And here, basically, the question is, entire units were randomized to the magnesium bath. So who should really give consent here? So there's this issue of gatekeeper consent, meaning that a dialysis director or a dialysis company might actually give consent that the whole unit can be randomized. But if a patient doesn't want to be in this trial, what can a patient do who's actually dialyzed in that particular dialysis unit? They probably can't opt out because the entire dialysate has a fixed magnesium. So if the patient doesn't want to participate, the patient would actually have to leave. So in these kind of situations where the patient doesn't really have much choice about participating, there's a question, does the patient really need to give consent, or should the patient just be informed that we are changing the dialysate magnesium in this unit? The problem in this particular study is they're looking at cardiovascular outcomes. And so ultimately they will be going to individual patient records. And so when individual patient data is collected, definitely individual patient consent is necessary. But as we mentioned, the way for patients to opt out of the study is very difficult. And this is a problem in cluster randomized trials when entire districts or hospitals might be randomized to a certain thing. Individuals generally just need to be informed, but how can they avoid the study if they don't want to can be a big problem. We need to think about incentives. In many settings, they want to give people a bar of soap or a packet of sugar. We need to be careful that in poor situations, sometimes these incentives can be coercive and impact on the patient's autonomy, and patients might actually agree to give vials of blood or participate just because they want the packet of sugar. So we need to be very, very careful that incentives are not used inappropriately and are generally not thought to be acceptable. However, it's very important that any patient expenses do need to be reimbursed for participation. We need to think also about justice in the conduct of implementation. As we mentioned, justice is extremely important in terms of fairness of participation selection, and we'll discuss a little bit about appropriateness of standard of care. So in terms of justice, this is a very interesting quotation that I like to use, which is from an African-American subject who basically states, why am I in such demand as a research subject, but nobody wants me as a patient? And this to me shows, first of all, that the African American population has less access in general to healthcare, but also that because this particular person represents a vulnerable demographic, he tends to be over-researched and people are constantly coming to him to include him in studies, but nobody seems to be worried about his general care. And then when we think about standard of care, this is a very, very good example that illustrates this dilemma. So in the middle of COVID, we didn't know if various treatments worked, if masks worked, if vaccinations worked. And so a French researcher basically said, if I can be provocative, shouldn't we be doing these studies in Africa where there are no masks, no treatment, no resuscitation? So he was basically thinking as a researcher, Africa is the perfect place. We have control group with no treatment, and we can very easily understand what our treatment would do. But this is completely unethical to take advantage of poor conditions in the control group in order to do your study. So in such a situation, one would have to make sure that one improves the conditions in the control group before a study is justifiable. For us, for example, if we want to study SGLT2 inhibitors on top of ACE inhibitors, we would need to be very sure that in the control group, at least all the patients were getting ACE inhibitors, for example. And then there's an obligation to address participant needs in implementation research. Some health needs come up during the study. If we're studying, for example, processes of care in acute kidney injury in a clinic, we might actually diagnose some patients with acute kidney injury, like the 0 by 25 study. They're then referred patients to higher levels of care. But there's also this issue of ancillary care needs, which come up in implementation research. And this might be that we are screening people for acute kidney injury. We might actually in an ultrasound see that the person has a tumor. This tumor has nothing to do with our research question. What are we going to do about this tumor? And these are ethical questions that researchers need to think about ahead of time. Does the research now pay to transfer this patient to another place for proper management? Does the research team have no obligations to this patient at all? So we need to really think about these needs, especially in places where health systems are weak, because a lot of these people don't have other access to healthcare. And so we might uncover problems that need to be addressed in the study. And then post-research, there are ethical obligations. We all know about data handling, confidentiality, privacy. We need to disseminate research findings, as I mentioned, both positive and negative are very important. The use of implementation research should be for advocacy, because we're trying to get evidence-based medicine into practice. So we need to take this to policymakers. We need to translate it, not only publish in journals, but bring it to people who are going to make decisions. And we need to make sure that the communities that participated in the research actually are those who are going to share in the benefits after the research. So basically, in conclusion, the ethics in implementation research is very complex. We need we need to be sure that we uphold the same ethical standards. We need to make sure that there is good capacity building during the research, especially in low and middle income settings. These are great opportunities where we can build capacity in local researchers. We need to acknowledge the impact of the local researchers. We need to engage communities. We need to think that the research topic is responsive to the health needs. We need to make sure we've engaged appropriately with stakeholders, and we need very, very clearly to make sure that there is post-trial availability and equitable benefits. So as we mentioned, mentorship and capacity building is critical. It's very, very important if studies are done in low and middle income settings that the researchers are acknowledged, that the local researchers are authors, that their intellectual property is respected, and they should actually be senior or first authors ideally. And then we also need to make sure that research funders realize that these questions are important and they need to fund them. So thank you very much for listening. I hope I've tried to convince you that there are ways to try to narrow this gap between research and practice, but we need to think really on a bigger picture, and that is really what implementation research facilitates. So I'd be happy to answer any questions. Thank you.
Thank you very much, Dr. Liu. That was an excellent talk. I thought doing clinical research itself was tough enough. It's a controlled environment. That seems like the tip of the iceberg. Implementation research is like magnanimous talk. There's so many hurdles that you have to clear in implementing. And when it comes to ethics, there's really a fine line there where you can cross that. And oftentimes even in our practice, for simple things like giving ARVs to patients, you wonder whether they really come for follow-up or not. What if I this type of anemia, they don't come back? Whether should I do justice to him by starting it, or because I know he's not going to follow up, should I not give it like a number? This is like just an example where we go through these things in clinical practice. But commendable work that you have done in this regard. Awesome. Thank you. Thank you for giving us an insight into this.
Thank you.
I now open the questions to the audience. Any questions? Can I ask how difficult is it to get through the cultural barriers? How do you find out any personal experience of the implementation research?
Sorry, the question was cultural barriers?
Yeah, if is the cultural barriers really profound? Is it very difficult to cross it during this implementation research?
Yeah, no, I think definitely, and that's exactly why one needs to do community engagement very early to try to identify these. I think one of the classical examples that people give is that, for example, we know that sleeping under a malaria net is very good for malaria prophylaxis and prevention. And so there were big NGOs that distributed a huge amount of nets in big implementation research projects. And then they came back after 5 or 6 months and realized nobody was sleeping under the net. And what one realized when one actually then engaged with the community was that the nets were actually white. And in that particular community, white was a burial color. So people were not using these. They were using them also as wedding veils and tablecloths and things, but definitely not sleeping under them. And so they realized then when they changed the color of the net to blue, suddenly everybody found that was acceptable and they could sleep under the malaria net. So I think this is an example of one cultural issue that is obvious, but hadn't come, nobody had thought about it at the beginning and is extremely important. So I think the cultural issues need to be very openly and honestly discussed. And ideally, it should be also the local researchers. One has to have respect for the local researchers and make sure that they are leading in these types of questions, because they will know what's acceptable. And there's certain communities that don't like, for example, generic tablets in a white box. They want the very shiny box. So then one needs to really think, how are we going to get this medicine, the patient to believe in this medicine if the box is plain white? And so then we have to think we might need to change the box. These types of simple things. But you only realize then by making the mistake, and that's too late, and you've used a lot of money. So again, to me, community engagement is critical.
Great. Thank you. Thank you very much.
Speakers and chairperson. Thank you so much, dear speakers and chairpersons, for sharing your valuable insights with us. All the postgraduate students who have registered for quiz or who are interested in participating in quiz, please go to the lunch area at 4 p.m. The provisional round will be the MCQ round in the lunch area. All the postgraduate students. Moving on to our next topic. The topic is imaging mass cytometry as a tool to evaluate the single cell landscape of renal parenchyma. I would now like to invite our chairpersons, Dr. Nandita Chaudhary, Chief Consultant Nephrologist, Downtown Hospital, Guwahati, Dr. Geetika Singh, Additional Professor, Pathology at AIIMS, New Delhi, Dr. Khushbu Rani, Consultant Nephrologist, Narayan Medical College and Hospital, Bihar, Dr. Shweta Mehta, Consultant Nepropathologist, Manipal Hospitals, Bengaluru. I request all the chairpersons to come on stage. I request the chairpersons to introduce the speaker.
Good afternoon, everybody. So after that last very interesting session, we're now going to go into a little more into basics. Let's look at the tissue in detail. For that, I'd like to invite Dr. Priya Alexander. We all know her. She's a consultant at the Division of Anatomic Pathology at the Department of Lab Medicine and Pathology at the Clinic. And I think she's quite famous for the DNA-JD9 story. As a renal pathologist myself, I'm always fascinated to hear about her work. So, Dr. Priya.
Thank you so much. Can you hear me? Thank you so much, Dr. Geetika and other chairpersons, and thank you, Dr. Urmila Anand and the WinCon committee for inviting me. It's really a privilege to be here, and I really appreciate the opportunity. So today I'm going to speak about imaging mass cytometry as a tool to evaluate the single cell landscape of renal parenchyma. What we'll do is look at it as a technique and then look at how the technique can be applied in disease and specifically in kidney disease. So imaging mass cytometry is simply this, where you can look at different tissues, formalin fixed, paraffin embedded tissues, and stain it simultaneously with a multiple panel of antibodies. And this multiplexed immunohistochemistry allows you in-depth analysis of the tissue. It's a recently developed technique, and it allows the analysis of single cells in a spatially resolved manner. And that is a great thing where you're allowed to do tissue correlation, where the stains correlate with neighboring structures. It allows you to use up to 40 or even 50 markers. And the use of these markers allows you to study pathophysiology of renal disease. So what is the first thing is to create your panel of markers. So you use standard immunohistochemical tools and immunohistochemical markers, but which you validate on normal tissue to ensure that it is staining what you want to study. And then you conjugate it, because this is a proteomic-based technique. You conjugate it with rare earth metals, and the analysis is based on these rare earth metals, which will be quantitated by the proteomic tool. So you have the advantage of standard antibodies that are immunohistochemical, and they're tagged or conjugated with rare earth metals, and it is that metal that gives you the proteomic quantitative analysis. So this is just an example of a study that was done in the kidney, where you see about 15 markers that were used. And just to highlight, what you have is the regular marker. You identify the target. Is it the nucleus? Is it the cytoplasm? Is it the membrane? Then you have to validate the antibody levels and the dilutions, and then you tag it with the metal, which you can see. Now, for example, in this, you are able to study proximal convoluted tubule if your markers stain for beta-catenin, megalin, and aquaporin-1. Or if you wanted to see that you were studying the distal convoluted tubule, you can have calbindin and beta-catenin. Similarly, to study the collecting duct, you look for cytokeratin 7 and beta-catenin. So this is the advantage of multiplex staining. The other advantage of this technique is you can use formalin-fixed paraffin-embedded tissue. So you can use retrospective data, which allows you to go into large archival analysis, and your power of studies and the questions you ask can be very, very significant. The important thing is, unlike RNA transcriptomic studies or the extensive nanostring technologies where you scrape the tissue off and you don't have any tissue correlation, this technique actually allows you to see the antibody interactions in the spatial phase of the tissue. The other advantage is, if you had to do even 3 immunohistochemical antibodies routinely, you keep cutting these sections and you may lose areas that you're interested. For example, if you're interested in a focus of endothelialitis that you want to study, just 2 sections and you may lose the focus of the endothelialitis. So imaging mass cytometry is very helpful for that. So how does it work? What you do is you design your panel of antibodies, then you stain it using the standard immunohistochemistry panels with these metal conjugated antibodies. And then what we use, the Hyperion imaging system from Fluidigm, and that is actually a mass spectrometry machine, which by using UV lasers on regions of interest that you have chosen, the UV laser ablates the tissue, and the metal the plumes atomize the metal tag that is attached, and that atomic weight is what is going to be used as it goes to the mass spectrometry analytical system to get quantitated. And because you're doing only 1 micron ablations at a time, the actual quantitation is actually oriented in space. So you know where that metal conjugated tag is. And the one drawback in these techniques is you need extensive computational analysis and a very talented pool of people who can analyze your tissue. So what are the steps? Once you've done the staining, the analysis, the first step, like any other antibody that you use, is denoising, where you increase the signal and decrease the noise. The advantage of this mass spectrometry technique over immunofluorescent techniques is that the rare earth metals rarely interfere with the normal background wavelengths of normal tissue. Once you have done and standardized and validated your technique, and you've gone through your quality control, you do cell segmentation. What do I mean by that? Every single cell that is in that region of interest has to be identified as a single cell. That's why this is single cell based therapy, single cell based analysis, and that is called cell segmentation. It's very critical that you have a very robust technique which identifies the nucleus, or it may identify a 5 micron cell. And once depends on the different analytical tools, you complete your cell segmentation. Then you have to annotate your cells, where you have to look at your marker and you have to decide and create your ensure that your machine is accurately identifying cytokeratin or accurately identifying endothelial cells. And then each cell gets annotated and you determine levels at which your antibody is positive or negative. And that's what's called annotating your cell. Then using the single cell annotated data, the calculations you can do are immense. You can quantitate the protein. For example, you can per millimeter square say how many of the cells are expressing CD45, or how many of them, because you can multiplex, you can say how many of them are memory T cells, or how many of them are Treg cells. So you understand that you can do quantitative analysis. You can actually also do different qualitative analysis. You are able to do morphometric measures. For example, looking at Vimentin, WT1 and podocyte, at one time you can say, in this glomerulus, I can see so many WT1 cells as compared to the second glomerulus. So you can do a lot of high-level morphometric analysis. You can see how cells interact with one another with analytical tools called neighborhood analysis. For example, is the T helper cell interacting with a plasma cell, or is it interacting with an M1 macrophage, or is it avoiding an M1 macrophage? And this has been exploited in several autoimmune studies, for example, in diabetes. And in cancer, this is extensively used where you're looking at epithelial stromal interactions, immune cells, which immune cells are interacting and which correlates with good prognosis. So the imagination and the potential of this multiplexed analysis is very high. And this is just a quick snapshot of where imaging mass cytometry has already been applied. And I can tell you that many of these studies are Nature and Nature communication level studies, because the depth of analysis is very high. And cancer is extensively now being analyzed with imaging mass spectrometry. Autoimmune diseases, multiple sclerosis, diabetes has been used in, has used this. So for example, in this study of human type 1 diabetes, how was mass spectrometry used? You take your data of islet cells from, in this study, they looked at diabetic progression. And then what they did is, using imaging mass cytometry, they identified islet cells, they identified a whole host of immune markers, and they looked and saw, according to the clinical stage of the patient, how did it correlate with changes in the islet profiles? And by using this technique, they were able to show that in the beginning, the beta cells are intact, but over time, the beta cell marker expression changes as diabetes progresses. And before the beta cell is destroyed, there's an increase in cytotoxic T cells and helper T cells. This degree of analysis at one time is one of the advantages of imaging mass cytometry. Now let's take the single cell pathology landscape of breast carcinoma. What you see in figure A, I don't know how to point. Oh, can you see my pointer? Okay, so here what you're seeing is actual imaging mass cytometry with multiplexed staining. SMA is the color here. So you have the arterioles here, and then you have pan-cytokeratin in blue. DNA serves as the nuclear marker, and the green is fibronectin. So this tells you how at one time you can stain with so many markers. And then they have the ability to analyze these clusters, because all the single cell data is fed into phenograph clustering, and you cluster your data into unique populations, and then you get what is cellular metaclusters or immune clusters. And then you can look, for example, at this big plot here, this heat map is actually a neighborhood interaction where you're seeing which clusters interact, which don't interact. So you get novel insights into diseases that you couldn't have before. Now let's look at what's been done in the kidney. So one of the very interesting studies, and one of probably the first studies looking at imaging mass cytometry, was the development of a kidney atlas. Just using a panel of markers, they were able to identify all the different components of the kidney at one time. So what you are guessing is the distal convoluted tubule or the ascending loop of Henle. Here, based on the staining pattern, you can actually say this is the thick ascending limb, this is the macula densa, this is the collecting duct, based on the multiplexed staining. So let's take a look at this. This is one example where this is the original H&E, this is the trichrome. This is the region of interest that was stained, and the panel of antibodies was used. And this D is actually the multiplexed imaging. Now let's take just this area and study that, which is here. It tells you based on the combination of the stains that this is the glomerulus. Now water staining here is enriched with TAM phosphol protein. So that is the thick ascending limb of Henle. Looking at the purple, this is a combination of megalin and aquaporin 2. That's the proximal convoluted tubule. So you can see that even just from physiology, you can create a normal kidney atlas. This is a closer look at the medulla. Then what you can do is you can take areas and you can do quantitative analysis. So what they've done here is they have these annotated images. Based on the marker and protein expression, you have what is called the Tisney plot. And you can see that these are all unique populations because one of them is the proximal tubule, which is obviously the bulk. Then you have what is the endothelium, the thick ascending limb. In that manner, you see discrete populations and you know that it's fitting in with what you expect. And here you can do quantitative analysis. Then the advantages, you might find populations that you never expected, and so you can study novel insights. And this is just a really nice example of how you have a tubule which stains with megalin, it stains with aquaporin, so that's a proximal tubule, but there were also some of them that stained with vimentin. So this is probably early epithelial mesenchymal transformation, suggesting that even in normal looking kidneys, minute injury is leading to epithelial mesenchymal transformation. Here is an example of arterioles that are expressing WT1 and nestin, which actually goes back to vasoactive niches in the medulla. Okay, yeah, thank you. And so this is how we've used imaging mass cytometry as a kidney atlas to quantify kidney structures, novel cell type identification. Recent study came out looking at lupus nephritis. What did they do using imaging mass cytometry? They were able to look at morphometric areas of the glomerulus. You may say, well, you can just do that with H&E. That's true. But here you're exploiting markers and you can say, oh, I've used WT1, I've used nestin, I've used vimentin, and I'm getting novel data. Or you can say that I want to see podocyte density loss, endothelial change loss. So the biological questions you can ask are so many. So let's come to what we have done. We have looked and used mass cytometry in the definition of analyzing COVID-19 acute kidney injury. And we have been able to do distance analysis of the immune clusters. And we were able to show that based on the distance from HLA-DR expressing cells, we have mostly CD4 reactive T cells in COVID-19. And this is just an example of a distance analysis. We can also use it to ask a hypothesis. In acute kidney with immune checkpoint inhibitors, we think that you're going to have this population of immune cells. And we found that, in fact, those patients who had acute interstitial nephritis, not due to immune checkpoint, versus those who had acute interstitial nephritis, secondary immune checkpoint, had more CD4 memory cells, more T helper cells, and increased dendritic cell populations. Then you can actually devise your targeted therapy. So this has not only the ability to help you understand pathology, it helps you plan therapy in a precision medicine manner. And our last big study now that we're doing is looking at kidney transplant rejection. Knowing that there are significant limitations with the Banff classification, molecular studies have come to play a big role. But the problem with understanding alloimmune injury with the current molecular techniques is that you don't have spatial correlation. With all of the nanostring, the BHOT panel, we don't have spatial localization. So we actually used imaging mass cytometry to study transplant pathology. And this is random images of 40 regions of interest. You can see the multiplex nature. And we developed a tissue classifier training using machine learning models with T-cell mediated, antibody mediated BK nephropathy. We worked with the imaging mass cytometry profiling to devise a classifier. So we did cell segmentation, as I mentioned. We did cell classification. So we were able to identify this cell is a CD4, this cell is a CD5, and then we did multiplexed labeling. So we can say, oh, this is a CD40, this is a CD4 memory T cell. So we are able to go at a higher level of analysis. And then we validate that we are in normalized manner of analysis. And then using the different techniques that we had, we developed a classifier. We have a higher accuracy than I'm showing here. We've got about 85% accuracy, and we are able to distinguish most of the types of rejection. One may say, well, that's very easy anyway, but the advantage is once you develop a classifier like this, the next level is in cases of chronic IFTA, where you don't know what the underlying pathology is. This is when classifiers become valuable. We've also been able to predict outcomes with a small subset of data, and we've identified cell clusters that predict poorer outcome. So the analysis and the techniques that we have the potential is huge. It's only beginning to be used. And so we look forward to using this technique in a more interactive fashion and in doing a more in-depth analysis. So we are truly fearfully and wonderfully made. And I see my teacher, Dr. Chako Korla, and this is one, Dr. Paul Brand is from our institution where Urmila also, Dr. Urmila Anand also was trained. And I just think the human body is incredible. We're just waiting for more ways to analyze and look at our data. And truly the final thing is the patient. How can we move towards making a more precise way of treating our patients? So that's, in summary, all that I have to say. This is a novel analytical tool. It allows insights into pathways and biological processes. It's constantly evolving. We need really good, sophisticated analytical methods. It uses fundamental properties of metal conjugated antibodies and proteomic analysis, and it allows a great in-depth analysis, which allows improved diagnosis, improved therapeutic targeting, and even prognostic outcomes. So this is the team I work with, and a lot of this was funded by a transplant grant I got and the Department of Medicines and Lab Medicine and Pathology support. And I'm happy to take any questions. Thank you.
Wonderful presentation, and it's definitely a very novel technique, which is the barrier to make a mark in that. I just have one question. You said retrospectively we can go back to the parameter sections and see.
Yes.
So how much retrospectively do you need? Like, is it probably a 1 month old log or like?
That's a great question. I can only speak for the studies we've done. I've gone to more than 10 years of tissues. Each tissue may be a little different. There may be some variations, but you have an analytical step before you analyze to make sure it's worked. But I don't see a problem with that. So yeah. Only thing is I will say certain fixations don't work. We have used tissue. So when we get kidney biopsies at Mayo, we often get them from multiple other sites. So some people have already put the tissue into glutaraldehyde, and we find that we don't have enough tissue for light microscopy. So we reallocate tissue, right? That's for the actual diagnosis of the patient. So we've noticed when we use any tissue that's been in glutaraldehyde, this technique doesn't work. So that's something that we're just learning now. So I'm sure we're going to learn more that where things fail and don't fail, but this is something I learned because one batch was not working. One slide will work, one section works and one doesn't. And then I realized those were the glutaraldehyde fixed sections. So.
Ma'am, I would like to ask you, Since this is a single cell based study.
Yeah.
And in kidney bank, sometimes some diseases require that we study 20 or 30 globuli like FSGS. In those cases, when how we have to do a number of studies to get a diagnosis of this, since one cell may not show the final name.
That's a great question. I think what it comes down to is designing your study and then asking the right question. For example, if you are trying to say in primary FSGS, there is a increased number of nestin or there's less, then what you need to do is have enough controls of the primary FSGS glomeruli. And then you need to plan a control that doesn't have it. But you can also use regions of interest, like lots of tumors are studied with the microarrays. I'd like to do it in the kidney yet, but we haven't come to that. But that's what I foresee. You can do lots more with microarrays where you pre-select. I don't have the answer, but that's what I would envision as a way we could do that. So, yeah.
Do we have any more questions?
Yeah, Dr. Priya, it was an excellent talk. It's an excellent talk. A couple of questions to you. How do you foresee the possibly the futuristic implications when we should use information mass cytometry that it is applicable for the clinical application? Like let's say EM wasn't a patient about 20-30 years back, but now EM is routine even in Indian perspective.
Yeah.
So imaging mass, how do you foresee that is going to come? And what could be the possible challenges like an Indian scenario face in setting up a lab of which does the imaging mass?
Okay. Okay, great question. Let's take question 1. I think a lot of discussion was there today about, what is the targeted treatment? Is belatacept good? Is alemtuzumab good? All of these are the questions that are being asked, right? And we know that some people do better, especially with chronic antibody-mediated rejection. So these are areas where our current canonical categorization of disease has not really helped us improve patient outcome. So we are possibly missing important signals that the cell is telling us. And this is an area where we are failing with current methods of treatment is an area we can look at. Every patient with breast carcinoma, there's so many different microenvironments, right? Similarly, in the kidney, we are putting them into broad categories, but under each of these, there are going to be. So I think it is identifying unique places where patients are not responding or we haven't got a good enough understanding to exploit. One of our hopes is that we will be able to get a better idea of IFTA. A patient with an allograft can show IFTA, and it could be T-cell mediated, it could be BK, it could be reflux nephropathy. But right now you're depending on information with the clinician, the DSAs. Maybe these are the techniques that are going to give us signals that we don't have. That's my opinion. How feasible is it? It's already very hard even in the United States. But like anything, we need to be diligent. We need to push through. And one day it's going to be very cost effective. And one day I think we can actually do 40 markers at one time. And it will be cheaper than this. It's archived. You can get endothelial density. You can get podocyte density. Imagine that. It will be amazing.
ML is integral part of assessment of machine learning.
Yeah, you need a very qualified team that is used to using image mass cytometry and used to all of the data is available. These are all GitHub online data, but you need the analyst who's able to use it. So that is a current bottleneck. Sorry, that's my own timer telling me to stop. Dr. Chaku had a question.
Yeah, I think most of the people here would be clinicians. So bench to bedside. Suppose I send you a sample today, when can you give me a report?
In today's world, it's still a research tool.
Sorry?
It is still a research tool.
So
it is not yet. Yes, not yet. But we do want to work towards this being available as a clinically applicable tool. I don't foresee it in the next 5 to 10 years, but I believe it could be because there's so much machine learning and analysis.
get a sample.
Yeah.
How many days does it take?
Okay, so in an ideal scenario, if I get it today, I have a validated panel, which I know I'm going to use. I would stain it the same day. We would probably batch it, I'm imagining, and within a week, we would be able to give you preliminary data.
Yeah, but that's no good for a graph.
Correct. No. So I agree with you on that, in that at least today, I think in a week, we can give you. Maybe down the line, it'll be much faster.
You need something to turn around in less than 24 hours.
Yes. Yeah, I agree. But then even a biopsy where we're trying to say there's macrophages in the endothelium, is this transplant arteriopathy? We have the same limitations. I think it will come, maybe 3 days. Let's hope. But yeah, it would be good if it's that fast. I completely agree.
Dr. Priya had an excellent job. So just wanted to know, how does this correlate with the non-invasive biomarkers? You are doing it as part of your research.
Right. So I think your question is relevant in the sense that we have to go to the next level. At this current time, the the research that's done is very only minimal studies. But I do think that if we combine it with single cell RNA sequencing, we will get more biomarkers. The limitation of this is we have to predict the panel. So we're already biasing our data with the panel that we have in our mind. My thought is that what you're asking is that we first do single cell RNA-seq, identify a whole potential of markers, use that with this and see the spatial relationship, and then identify the true biomarkers. I think that's the way it's going to go. So combining some single cell technologies, we will get there to develop markers that can be used in the blood and the urine. Yeah, but we're a long way from that. Okay. Yeah, thank you. That's a great question. Right now, it's like Dr. Korla is asking the question. It's currently very expensive. It's, but everything is like EM was very expensive. It's now not. Everything is expensive, but the more you use it, the more the machines and the outside companies realize their product is useful, it becomes available. So it's all a matter of time. That's what I think.
What's the thickness of the section?
Actually, that's an excellent question. It's 4 microns. That is such a great advantage of this technique. I don't know who's asking the question. Yeah, 4 microns. That's the beauty. Whereas proteomics is 10 microns. Single cell RNA sequencing is 30 microns. So this is great. Yeah, it's great.
Thank you, Dr. Priya. Thank you for this wonderful discussion. The next topic of the scientific program is renal transplantation in HIV positive recipients. I would like to invite on stage the chairpersons, Dr. Natarajan Gopalakrishnan, Chief Nephrologist at LMC Chennai, Dr. Srilata, Professor and Head of Department, Calicut Medical College, Kerala, Dr. Manish Balwani, Consultant Nephrologist and Renal Transplant Physician, Saraswati Kidney Care Center, Nagpur, Dr. G.K. Prakash, Consultant Nephrologist, Manipal Hospitals, Bengaluru. Our speaker, Dr. L.D. Mueller, will be joining us virtually. I request our chairpersons to introduce the speaker.
Good evening, everybody. At the outset, I congratulate the Nikon team for conducting such an excellent venture and thank you for inviting us for this segment. The next session is on kidney transplant in HIV positive recipient. We know that HIV positive patients now have a normal lifespan, thanks to the very potent antiviral drugs that we have. Since they live longer, they develop more of kidney disease because of HIV itself, because of the drugs, the antiviral drugs that we use, because of the opportunistic infections that they develop, and also they live longer, so they develop acid to general population, they develop diabetes, hypertension, etc. All of this can produce kidney disease. So more of HIV positive patients are referred to nephrology for with G5, CKD G5. So we have to do something like dialysis or transplant. I believe most of us are not that experienced in transplanting an HIV positive recipient. So here we have Professor Emily to discuss with us about HIV positive transplant. I hand over my mic to co-chair to introduce the speaker.
We all know Professor Elmi Muller. She is currently the president of ATS, Chief Transplant Surgeon, Dean of the Faculty of Medicine and Health Sciences at Stellenbosch University, South Africa. So, without wasting much time, I would request Professor Elmi to deliver the lecture.
Good morning. I'm Elmi Muller, and it's an honor to talk to you virtually today. I'm a transplant surgeon. I work in Cape Town in South Africa. I'm also the Dean of the Faculty of Medicine and Health Sciences at Stellenbosch University and the President of the Transplantation Society. It gives me great honor this morning to talk to you about one of my projects that has expanded donor pools in South Africa and outside of South Africa, namely the project using HIV positive donors for HIV positive recipients. So let me start off with a map that gives you an idea of the incidence of HIV in South Africa. It is a huge problem in South Africa, as it is in India, and we know that our incidence is 10 times higher than anywhere else in the world. We also, if we look at our 50.5 million people, know that there are about 5.38 million of these people who have HIV. In people between 15 and 25 years of age, the incidence is even greater, 21% of our population. These statistics are based on antenatal clinic data. Important to note is that a large part of our population, 84% to be exact, have no medical insurance and depend on the state for their health care. It is this group of patients that's severely affected by the policies around renal and renal replacement therapy in South Africa. In weekly meetings, a group of physicians, nursing staff, social workers, and coordinators listen to the stories of the patients who are presented with end-stage renal failure in South Africa. And then they select, according to strict selection criteria, which patients will receive dialysis. Category 1 patients are those who have almost nothing wrong with them except renal failure, and generally they will receive dialysis. But as soon as there's any comorbid disease or confounding social or medical factor, the patient will become category 2, which will mean the patient can only get dialysis if there is a space. If you are classified as category 3, in other words, a severe confounding medical problem, like for instance, cardiac failure or severe previous illnesses, you will be deemed category 3 and you will not be considered for dialysis. Category 3 patients generally are sent home with palliative care. In 2008, when I started my transplant program, all HIV positive patients were classified as category 3. Since the first HIV positive to positive kidney transplant was done at Groote Schuur in 2008, a total of 57 transplants took place from 31 deceased donors. Due to a lack of sometimes suitable recipients, we only used one donor kidney in some cases. When I show you results today, I will report on the 24 donors who had adequate histological biopsies when I discuss the pre-transplant biopsy samples, and I will be excluding the 7 donors who did not have adequate biopsies. You can also see here on this table that the amount of patients where we only used one kidney is 11. I will also report on patient and graft outcomes in the recipient. And in terms of histology outcomes, I will show you the 50 surviving patients' histological follow-up in our study. HIV infection is generally confirmed by means of a fourth-generation enzyme-linked immunoabsorbent assay, or a Western blot method, which is standard in South Africa in all our donors. I would like to share with you some of the demographics of the deceased donor population that I used in my transplant study. The median age of these donors was 31, and 70% of them, 75% of them were male. The majority of our donors are Black African race, and only 3 were on antiretroviral therapy before the donation. All the donors were screened to have adequate kidney function, and only 1 donor had hepatitis B co-infection. When we think about whether a donor is suitable, we usually think about it in these 3 big headings. What is the quality of the kidney? And in this regard, we're mostly worried about HIV-associated nephropathy in the kidney. What is the risk for an opportunistic infection? And in this case, we think about other opportunistic infections, for instance, resistant infections like TB. And what is the chance that we will be transmitting a resistant virus into the recipient? In other words, what is the risk of resistance in this deceased donor? So let me say something about HIVAN, HIV-associated nephropathy, in our donors and how we screen for it. We know that HIVAN is a very aggressive form of FSGS and that it occurs quite commonly in patients who've been untreated. And unfortunately, a lot of the donors in this study have been untreated. So we usually screen for this by means of proteinuria, protein creatinine ratio in donors. And I also do implantation biopsies on all the kidneys. However, I do not do an implant screening biopsy where I await the biopsy result before I decide whether to use the kidney. I only use clinical criteria to make this decision. But I will show you some of the histological findings in our donors in the next slide. And you will see that most of them have no specific histological findings. Some of them have got some ATM. We had 4 donors who had features of hypertension on their kidney biopsy. And in 1 donor, there were suspicious features of HIV-associated nephropathy pre-transplant. Tuberculosis is a very big problem in South Africa. We have very high rates of resistant TB. And generally, the patients who have multi-drug resistant TB or extensive drug resistant TB is also often HIV positive. So we know that patients with a combination of TB and HIV have a very high risk of death. And in this specific article, it was shown that 27.8% of patients who had this combination died. So I am always very cautious when I hear that a donor has got active tuberculosis, because I'm very worried that I will transplant a resistant TB strain into a recipient, which can be very problematic to handle. Now, in terms of antiretroviral therapy resistance, I think this is the one that's easiest for us, because in South Africa, we have got very low resistance rates. This is a slightly older study, but it just shows you that in the beginning, patients who were treated with antiretroviral drugs in the Mankweng and Bela Bela communities are still not showing major resistant patterns in their follow-up drug screening. So in South Africa, we are very lucky and we are very privileged that our antiretroviral therapy resistant rates are fairly low, and for that reason, it is not a major consideration when we consider our deceased donors. Now I'm going to move on to the recipients now and show you some baseline demographics of our recipients. You can see on this slide that the median age is 40, so it's a fairly young group of patients with almost 50-50 male-female ratio. It depends, often when we do another transplant, then that percentage will shift. And the majority, 92% of the patients in this study are Black African origin. We require all patients on the study to be on antiretroviral therapy at the time of transplantation. And you can see that the majority of them are on an NRTI-based antiretroviral therapy regime, and a small percentage on protease-based ART. There's a pre-op CD4 count before we start any immune suppression. The median there is 408. So generally that is a requirement that patients should have a very well controlled HIV and a reasonable CD4 count before transplantation. And you can see that most people are lower than detectable, with 1 or 2 patients who had a viral blip at the time of the transplant. Now, for the recipients, we have looked at their causes of renal failure. Not everybody had biopsies, so it is sometimes presumed, but in some of them we do have biopsies. And you can see that quite a few of them actually have HIV-associated nephropathy as a driving force for their own renal failure, hypertension in combination with HIVAN, and then all the other type of things that drives renal failure in a less common occurrence. You know that the recipient group is quite young. The average age is 40, or the median age is 40. So we don't have many comorbidities. Hypertension is probably the most common. Diabetes actually quite low in this patient group. Obesity in 20% of the patients. And interestingly, in South Africa, we don't have a lot of hepatitis C like many other parts of the world. We do have quite a bit of hepatitis B, but in this group, we only had 1 patient, no, I'm lying, 3 patients who had hepatitis B antigen positive tests before the transplant. Interestingly, a lot of patients have a history of tuberculosis. So that is very common, and 30% of all the patients in the study had at least 1 infection with TB in the past. And we have 1 patient who've been transplanted for the 2nd time with the HIV-positive kidney. Now, patient and graft survival in the study group, we had 8 patients who died post-transplant. So currently the patient survival is 86% at 1 year, 86% at 3 years, and 82% at 5 years. And 7 patients who lost their graft post-transplantation. So the graft survival currently is 95% at 1 year, 92% at 3 years, and 77% at 5 years. In terms of rejection rates, we have 2 patients who experienced graft failure due to acute rejection less than 1 year after the transplant, whereas 3 patients who lost their graft had histological features of chronic rejection between 2 and 6 years after their transplant. So despite using very aggressive immune suppression and thymoglobulin induction, we still see high rejection rates immediately after the transplant. Now, the rejection rates here is broken down in terms of the first year post-transplant and then over the rest of the time. And you can see here that we, in the first few weeks, still see acute antibody and T-cell rejection rates. And then over time, we also see chronic rejection and a sort of lower rejection rate as time goes by. The probability of a rejection in the first year is 26.1%. So that is quite a high probability if you think about how severely these patients are immune suppressed. Now, other biopsy findings that we've seen in this study group is including pyelonephritis, CNA toxicity, and IFTA. But what I do want to talk about a little bit is the HIVAN and the recurrence of HIVAN. You can see here that we don't see HIVAN recurrence in the early years, but we did report it after 2 years. And in that period of time, we had 3 recipients who had some features of HIV-associated nephropathy at 2 years. And then we had some patients who had features of HIV-associated nephropathy in 8 biopsies from 6 recipients over the next 8 years. So you can see 10 years of biopsies did not show a major problem with HIV-associated nephropathy. So that is quite reassuring. Now, I would like to show you a little bit about the virology. When we started this study, people were very concerned that we are going to transplant patients who will get either resistance from the donor or will have uncontrolled virological events. And I want to show you some of the results we did in this regard. So we have done ultra-deep sequencing of HIV, and with ultra-deep sequencing, you can find populations of the virus based on their unique signature or their unique variant. So we can look for haplotyping to identify the virus, and we can also identify through this process some viral resistance patterns. So my colleagues in virology have done this work, and I'm just going to show you their findings. So for the donor, we had 3 available sample types. We had plasma, PBMC, we had biopsies on most of the donors. We initially collected urine, but we've stopped doing that because we're not really using that much. But what we did do in the study was to measure the viral load in the plasma and deep sequence the RT gene in the plasma to tell us something about drug resistance, because the RT gene in the virus tells us mostly about drug resistance. For the recipients, we used the PBMC, the plasma, and the biopsies, and we deep sequenced the ENF gene in the PBMC. And by doing that, we could see whether the donor virus is present at all in the infected recipient. So the idea was to look for super infection from the donor into the recipient. Now, here you can get a sense of what the donor viral loads were. In the South African group, most of our donors are naive to antiretroviral therapy, and of course they are deceased. So it happens that the family does not know about the HIV or know about the drugs. So we had one patient where the family reported the antiretroviral therapy and the status of the patient. So we knew about that one, but we found through doing mass spectrometry in all our donors, another 2 donors who actually were on treatment at the time of donation. Then we also looked for proviral load in the recipients. As you probably are aware, viral load is a major risk factor associated with HIV transmission. And if you have a very high viral load in the donor, the transplanted kidney could potentially, theoretically, become a source for HIV transmission. So we wanted to evaluate whether the donor virus super infected the recipient. So we used a deep sequencing approach on the donor and the recipient's PBMC DNA to look for this pattern. And I will show you some of the results now. But you can see a wide range of proviral load in our donors and in our recipients, and most of them fairly high. Now, if you look at the RT gene, the reverse transcriptase gene, and you amplify that, you can get a sense of whether the patient has got drug resistance. So although our donors were almost exclusively naive to antiretroviral therapy, we were worried that they still could carry a resistant drug strain. So we investigated all the donors with this sequencing method, and in the process, we looked at 1,745 sequences per patient. And we then amplified this RT area. So we amplified this whole ENF area to look for drug resistance. And I will show you now some of these results, but it is quite reassuring to say that we did not find major issues in this regard. So an average of 205,000 V3 or RT sequences were done per recipient sample. And we compared this to the sequences that we obtained in the linked donor. So if you look at this figure, it shows you the highest percentage of identity of each recipient virus to any of the donor viruses for all the pairs over a time point, and this was done in the V3 region. So most recipients are dissimilar to the donor sequences and had a sequence distribution overlapping the average pairwise genetic distance between viral sequences from the two unrelated individuals, and that is the 84% black line that you can see in the middle of the graph. But for KID 139, at 12 weeks post-transplant, we detected V3 sequences that were up to 98% similar to the donor, indicating possible superinfection, but at very low levels. We then sequenced the RT region for the same person and found a similar result. So you can also visualize this evolutionary relationship between recipient and donor viruses by looking at a tree like this. And you can plot then the recipient sequences in the figure, which is the circles and the squares in the figure, and then link the donor with the same color. So apart from KID 139, which I showed you in the previous sample, none of the 46 investigated recipient samples contained sequences that clustered with the respective donor virus, suggesting superinfection by the donor did not occur at this given sampling depth. In recipient KID 139, the one that has the overlap between donor and recipient, at 12 weeks post-transplant, we detected V3 sequences that were up to 98% similar to the donor. So this indicated a possible superinfection, but the levels were very low. And then when we looked at the other time points, so earlier time points like 6 weeks post-transplant and later time points, we did not see this again. So this was a period in which the donor virus were present in this person's plasma, but it was obviously then suppressed by antiretroviral therapy, and the recipient did not have any long-term complications. In fact, the recipient remains well and off transplant and had no major biopsy changes. So looking at these results, there are some key take-home messages that we can remember. In terms of antiretroviral therapy resistance, I think for us in South Africa, resistance is not currently a problem. It has got something to do with the fact that we have very low resistance rates in the country, and that a lot of our patients are naive when we use them as donors. So that might be different in a different geographical setting. Superinfection is rare. Superinfection has not been associated with any disease progression and did not pose a risk to transplant recipients who remain on ARVs. So we only saw this in this one patient, KID 139, but we also know that it was only at one time point and the patient remained well. So it seems like superinfection is not a problem. We also know that superinfection with the virus does not emerge even with temporary suspension of ARVs. So we did not see any superinfection even in patients who had a temporary suspension for other reasons. And this is an important finding, that none of our patients had this despite this situation. And then lastly, high
recipients who remain on ARVs. So we only saw this in this one patient, KID 139,
But we also know that it was only at one time point and the patient remained well. So it seems like superinfection is not a problem. We also know that superinfection with the virus does not emerge even with temporary suspension of ARVs. So we did not see any superinfection even in patients who had a temporary suspension for other reasons. And this is an important finding that none of our patients had this despite this situation. And then lastly, HIVAN recurrence has a very low risk. If you think about it, we have seen some HIVAN in our patients, but only one patient lost a graft because of HIVAN. So we do not think that HIVAN is posing a major risk in the long run for these patients. So I just want to acknowledge some of my team. I have a quite large team who's working with me on the clinical side, as well as on the histology and immunology and HIV side. Thank you very much for your hard work and also sharing my UO1 grant that is paying for this work with the group at Johns Hopkins, Andy Reid and Tom Quinn. So thank you very much. Thank you for the invitation to talk to you today. I'm leaving my email address and my Twitter handle if you want to connect with me. It would be lovely to hear your questions and your comments. Thank you for inviting me to do this talk.
Thank you, Dr. Elmi, for that wonderful experience of your transplant. So that is like one.
So the chairpersons can take any questions or discussion. Dr. Natarajan Gopalakrishnan sir is online.
If you have any questions, let him.
Chairpersons can take.
So I'm sure, I don't think so we have any enough data with regards to transplantation in retropositive patients. And what she really presented was a small series. And what we could observe is that the incidence of acute rejections are quite a lot. Probably what I feel is related to the drugs what you were using earlier in an RTI and NRTI, which behind protease inhibitors. The in thing now, the last couple of almost a decade or more, I think we have been using integrase based regimen. So maybe that is one of the reasons. I don't know if she didn't tell us about the higher incidence of rejection in some individuals. Is it because of the genetic polymorphism of apolipoprotein L1 or not? We don't know about that. What we could figure out from other representation is that the viral antigen load was not totally nil, or the CD4 counts were I mean, more than what we do in, and should be more than 200 cells, but I don't know what it was. So some things were not very clear. Maybe it's the old presentation with the numbers being done some years ago. So I don't know whether we have enough experience in the crowd here who have done the good number of transplants in HIV positive patients. So Dr. Gopalakrishnan should be able to share his experience, and then we will open the.
Yeah, thank you. Actually, we don't have great experience. We have just only a handful of HIV positive patients who have undergone kidney transplantation in our institution. But actually, we have read about, surprisingly, HIV patients stand at a high risk for acute rejection. Can you just highlight on that? I mean, is it true that as high as 30% acute rejection has been reported in the literature? What's your current experience? Sorry, I could join only late because of the technical issues. I was not able to log in. I'm sure you might have discussed on that issue in your talk before.
I believe she's not online. I don't think so. We will be able to get the answer from her. Anyone can take this question of Dr. Gopalakrishnan?
So she's not online, sir.
Oh, she's not online. Okay, fine. So the paradox in kidney transplant in HIV recipients is that initially we all thought like being an immunosuppressed and immunocompromised state, actually the need for immunosuppressives may be less in HIV patients and rejection may not happen. But actually the contrary is the experience of the people, the centers which do transplants in HIV patients is, in fact, HIV is classified as one of the non-immunological recipient characteristics, enhancing the risk of acute rejection. There are very interesting immunological explanations for this phenomenon. That is number one. And number two, and also we were worried about incidence of higher incidence of infections among HIV recipients. But again, the centers which do regularly perform kidney transplants, they have come up with a statement that there is no statistically increased incidence of infections in HIV patients. So that's it. And the greatest challenge will be the protease inhibitor, the drug interaction between Hello, am I audible?
Yeah.
Am I audible?
Yes, sir.
Yeah. So the drug interaction between the protease inhibitors and the CNIs, that is another challenge. Actually, in one of our patients, recently we did the HIV positive patient and received kidney transplant. He's doing very well. But he developed a very severe parvovirus infection. We do get parvovirus infection not infrequently, but this patient suffered with very severe parvovirus infection, warranting repeated courses of IVIG and repeated transfusions and so on. And what we did is that, but it is in no way it is related to HIV status of him, because he was in complete remission and then only we took him up. So this is our observation. And finally, what we did is that we have switched over to everolimus instead of CNI. And the literature showed that everolimus has some antiviral property and it can act on parvovirus, and now patient is stabilized. So this is very interesting observation which we have had. But one thing I'm sure that in the future, almost every center will have, particularly the states where HIV prevalence has been high, like Tamil Nadu, Maharashtra, Andhra, and Kerala. We will come across many HIV patients warranting organ transplantation, because, you know, the very efficient and very effective antiretroviral therapy and easily accessible in all the government centers. And they live long enough to suffer the organ damage, both due to the HIV related and non-HIV related diabetes and hypertension and lifestyle diseases as well. Actually, we are seeing a kind of a complete transformation of HIV nephrology over the past 15 years. About 15 years ago, we used to have so many HIV-related kidney diseases, including HIVAN and HIVIC. But now we are not coming across that. The HIV has been almost contained, you know, like it is a success story of the NACO, National AIDS Control Organization, and the prevalence rate has been stabilized or it has come down. And the initial HIV-related kidney problems we don't come across. We used to have a lot of immune complex diseases, IRG and membranous nephropathy and lupus-like glomerulonephritis and so on. But all this we are not seeing now. Now what we are seeing is, one is tenofovir nephrotoxicity, still we do see. Then non-HIV related diabetes and hypertension related issues in the kidney. So that is a kind of a trend change in the profile of kidney diseases among HIV patients as far as Madras Medical College experience is concerned.
Thank you, Dr. Gopal. Due to the possibility of time, probably we will close. Thank you.
Thank you. Thank you, Chairpersons. Our next session is symptomatic and supportive care in chronic kidney disease. To chair the session, I would like to call upon Dr. Vivekanand Jha, Executive Director, the George Institute of Global Health, India, Dr. Chapo K. John Jacob, Senior Consultant Nephrologist, Baptist Hospital, Bengaluru, Dr. Gurudev K.C., President, Consultant Nephrologist, MS Ramaiah Medical College, Hospital, Bangalore. Dr. Ruju Gala, Assistant Professor, Tokiwala National Medical College, Mumbai. And I invite the chairperson to introduce the speaker.
Thank you very much. Dr. Gurudev, do you mind if I go ahead?
Good afternoon, Dr. John.
Yeah, hi, good afternoon. Do you mind if I go ahead and
Yeah, please
introduce
go
Professor
ahead.
Naikar?
Please go ahead.
Thank you. So on behalf of my co-chair, Dr. Gurudev, and other co-chairs who were just named, it's really my proud pleasure to introduce Professor Sarala Devi Naikar. In fact, she doesn't need any introduction. She is an old friend of India, having made repeated visits to India over the last 30 plus years. Professor Naikar is an emeritus professor of medicine and nephrology at the University of Witwatersrand in South Africa, Johannesburg. Her long research career is well known, and for those of you who are interested, I would encourage you to go and look up a YouTube video that she did for the African Health Research Network, in which she talks about her journey of nephrology in over the last so many decades. Professor Naikar's work in global nephrology is well known. She has worked on almost all aspects of kidney diseases, chronic kidney disease, in particular about factors that are relevant to low and lower middle income country settings. The challenges faced by providers in HIV-associated kidney diseases and other types of kidney diseases that are uniquely seen in African continent. She has also participated in global nephrology through her role in many international organizations, most notably the International Society of Nephrology. She has been a mentor to an extremely large number of students in Africa and outside of Africa. And it's rare that her name would not be recognizable in any country where nephrology is practiced. It's really my proud privilege to welcome you, Professor Naikar, to this meeting and request to give your talk on symptomatic care in patients with chronic kidney disease.
Good afternoon. Thank you very much, Vivek, for this wonderful introduction. And my thanks to the organizers for inviting me to give this talk in honor of Dr. Vidya Acharya. I think it's very appropriate that this conference is held in Women's Month, and this talk is in honor of the first woman nephrologist in India and known throughout the world as the mother of nephrology in India. I will try and share my screen, so bear with me for a few minutes. As Vivek knows very well, I'm a little bit technologically challenged. Can everyone see my screen now?
We can see the screen.
Yeah, we can see you.
Okay, great. Thank you very much.
We can see the screen, Sarala, but it is in the form of your file manager. So we don't see this PowerPoint presentation directly. If you can open the file in PowerPoint, that would perhaps do the job.
Is that any better?
No, still the same.
Let's see what we can do.
Yeah, no.
Madam, if you can go to your desktop, I think your slide will be in your desktop because you're opening it up in your documents. So
okay,
let
me save this on my desktop then, because it's in my documents at the moment.
Or you can just click it and take it to the desktop. Will I can't take it to desktop straight and drag it from the will icon to the desktop?
PDF will be showing the
Okay.
Got lots of things open on this, fortunately.
We can play from here, she can speak this calling.
Okay, it's not. Madam, it's come. You can have to share screen. Madam, you can just share screen down below.
Can you see it now?
No, it's not. Ma'am, you can share.
You have to share your screen, ma'am.
Okay.
Ma'am, should we play the recording?
No, wait, I'm just getting there.
Okay.
Let's go. Can't seem to see the icon for sharing screen suddenly. Let me see.
Should be at the bottom, a green icon.
It's usually in the bottom, but let me get to the share screen first.
Ma'am, click on the share screen on the.
If you open the Zoom window, it should be at the bottom.
Okay, got it now. Let's see.
Yes, that's great. If you can just put it in the. Yes, absolutely.
Is that all right now?
Yep. Wonderful.
Okay, thank you very much. My apologies. As I said, this is sort of happens every now and then. So thank you for your patience. Talking about supportive and symptomatic care in chronic kidney disease, I think this is a very important topic for all conditions, and particularly so for kidney disease. And when we look at this, this figure from Kidney International talking about the various kidney disease pathways that our patients undergo on the diagnosis of kidney disease with its risk factors, the progression to chronic kidney disease and end stage. And during the course of kidney disease and its treatment, during pre-end stage and after end stage kidney disease or kidney failure, and during the various renal or kidney replacement therapies, supportive care plays an important role throughout the disease pathway. And this recent publication in KI shows the role of supportive care throughout the spectrum of kidney disease, as well as its therapies, including conservative care. This KDIGO Controversies Conference on Supportive Care took place more than 10 years ago, and this consolidated my interest in the topic. And you can see that it was a very global group of participants, including Vivek Jha, And subsequently, ISN had a meeting where this topic was discussed, and this resulted in this publication on the topic in Kidney International. And I can refer you to both these publications as being very important background literature on the subject. Now, looking at the conceptual framework that Sarah Davidson put throughout the trajectory of illness, where one looks at preventing and curing chronic kidney disease, supportive care, or sometimes palliative care is used as a synonym for supportive care. So it has a role starting at the onset of illness and increasing as kidney failure progresses. And it also takes an important role at the end of life, where patients might need hospice care, and also support should be offered to family and caregivers. So therefore, supportive care is important for those with advanced disease, and these are services that are aimed at improving the health-related quality of life for patients with established chronic kidney disease at any age. And it helps patients to cope with living as well as dying, regardless of life expectancy. And as mentioned, hospice care also shares the same philosophy. So when we look at supportive care, importantly, and I shall talk largely and mainly on symptom assessment and management, but one needs to also look at prognosis, shared decision-making with the patient and caregivers, and important to have advanced care planning at the outset. And when patients go for dialysis, one needs to upfront discuss the situation where it may be advisable to withdraw dialysis. And then in those people who have a severe comorbid illness, that quality of life is very poor, one needs to talk about the need for non-dialysis care. So therefore, for instance, in a patient with diabetes, there are various stages with disease progression, where one talks about education, diet, medication, aimed at trying to prevent or kidney disease or to retard its progression, and various measures on treatment are undertaken. And when kidney failure ensues, one needs to prepare for transplantation or dialysis, either peritoneal dialysis, hemodialysis, and one needs to support patients' decisions. And as I mentioned, at this stage, advanced care planning. And important is a social, emotional, and spiritual component. And it's important to support the patient and caregivers with information throughout the disease progression. And very important is symptom control to try and improve quality of life. Important to note this old slide, just as preventive treatments, kidney replacement therapies are in very low, provision is very low in low and middle income countries. Similarly, supportive care also is provided in fairly low amounts. And this is something that we need to look at addressing. And then talking about conservative care populations, I think that a lot of our patients in low and middle income countries belong to this category of choice-restricted conservative care, where resource constraints prevent or limit access to kidney replacement therapy. And comprehensive conservative care, as I mentioned, is where it's chosen or is medically advised. And then, of course, in those areas where healthcare is very restricted, a large number of people have unrecognized or undiagnosed kidney failure. And this slide talks about the various ways that one can implement comprehensive conservative care. looking at interventions to delay progression of CKD and minimize adverse events and complications. And again, all the elements of supportive care need to be offered, like shared decision-making, active symptom management, advanced care planning, psychological family support, and also important to address the cultural and spiritual domains of care. And in this modality, dialysis is not provided. Now, supportive care can be offered at primary care level or as a specialty kidney supportive care. And these are complementary, where the primary care provider manages basic symptoms, diagnoses and starts depression and anxiety treatment, and talks about serious illness, and it addresses prognosis, and at this stage might also advise patients that conservative care may be the option, and discusses basic goals of care. And this is addressed at a higher level in specialty care, where refractory symptoms are looked at and managed, depression, anxiety, grief, distress is managed, and one looks at serious complex illness and manages conflict resolution regarding goals of care, because occasionally family may have different goals compared to what the patient may wish. Now, looking at symptoms with kidney failure, as we're all aware of, chronic kidney disease has a large number of symptoms, and kidney failure, and with the onset of kidney failure, the symptoms increase, and the median number of symptoms in hemodialysis patients is reported by Cohen et al. As being 9, and that pain is a major component of this, occurring in over 50%. And this is associated with impaired quality of life, associated with depression. Cohen further reported that fatigue is the most important and troublesome symptom reported, along with insomnia, pruritus, neuropathic symptoms, low spirits, and then nausea, vomiting. Davidson reported that symptoms accounted for just under 30% of impairment in the physical health-related quality of life and 39% in the mental components. And therefore, symptom assessment and management is an integral part of management of advanced care CKD patients. It's important to rule out reversible factors and try and treat these. And screening for symptoms should be part should be a regular part of clinical practice. Symptom management requires a stepwise approach, where first-line treatment includes non-pharmacological interventions. Second line, where pharmacological therapy is utilized using low-dose agents, which have efficacy across several symptoms. And therefore, clinical guidelines for the stepwise management of uremic symptomatology is important and essential. The South African Nephrology Society had a working group with a large number of nephrologists from throughout South Africa, with our resource person being Dr. Frank Brennan from Australia, who's a renowned palliative and supportive care specialist, and Dr. Rennie Kraus headed the palliative care group. So these guidelines were drawn up and adopted by the South African Renal Society. And guidelines were provided for management of common symptoms, such as gastrointestinal symptoms, which are very common, and looking at the causes for nausea, vomiting, taste disturbances, anorexia, occurring in up to 90% of patients in some series, with a myriad of causes. And therefore, it's important to exclude drugs. And patients in this situation may lose weight because of anorexia, and therefore small frequent meals should be encouraged. Try and avoid spicy foods, alcohol, and try and maintain upright position after meals. Complementary therapies are reported to be quite important here, such as ginger, relaxation, and acupuncture. And pharmacological therapy can then follow if non-pharmacological is not effective, and metoclopramide in low doses to start with. Haloperidol may then follow on, and ondansetron, which is not available to us on the essential drug list in South Africa, has been also recommended. Constipation, another important symptoms. And we all know that phosphate binders can be an important component here, including other drugs. And mild exercise should be encouraged. And one of the problems is trying to encourage fluid intake when patients are anuric. And therefore, one could then proceed with simple agents such as lactulose, paraffin, Senokot, and other more potent treatments for constipation. Pruritus can be a very disturbing symptom, affecting sleep, contributing to fatigue, depression, and one has a myriad of causes. Important to try and exclude the dermatological causes and to treat these. And non-pharmacological care, such as appropriate skin care, using fragrance-free soap, not using very hot water, and moisturizing with emollients. Treatment can be very challenging, and various agents as listed there, such as antihistamine, pregabalin, UV light therapy. So these can be offered in different stages, but can be quite, patients can be quite refractory. And one needs to look at providing enough dialysis and maintaining calcium phosphate balance. Capsaicin cream is also recommended, as well as gabapentin. Pain, as I mentioned, can be a very disturbing symptom. Literature prevalence reported as 58%. Important to exclude rheumatological causes and address these, and Steele syndrome. So non-pharmacological, one tries to use different measures like exercise, massage, heat therapy, behavioral therapy, and then tries to use various pharmacological agents thereafter. Rheumatological treatment and neuropathic treatment have their own specific measures. One can use topical anti-inflammatories for joint pain, paracetamol, tramadol, and morphine is generally not recommended because this is retained in renal failure. And then transcutaneous patches such as fentanyl or non-steroidal anti-inflammatories could be utilized. Neuropathic pain, various agents such as pregabalin. Amitriptyline may be important because it can also assist with sleep disturbances as well as pain. And other agents, again, could be added, such as opioids and gabapentin. Sleep disturbances are very important, occurring up to 83%, and this impairs quality of life. Patients can be chronically fatigued because they're not sleeping, and one needs to exclude the various causes listed here, looking at the various endocrine and metabolic causes, medication. Again, non-pharmacological measures should be instituted first. Exercise can help, psychosocial and spiritual support, as well as cognitive and psychological therapies such as relaxation therapy, meditation. And sleep hygiene is very important for everybody who's not sleeping well. So no stimulants such as tea and coffee in the late afternoon or evening, no television or cell phones at night when one goes to bed, and complementary activities. And One needs to take a detailed sleep history and treat if this is possible. Manage restless leg syndrome, pruritus, pain, obstructive sleep apnea, which all impact on sleep and quality of sleep. And if pain is present, one needs to deal with this. Amitriptyline as an adjunct with other drugs can be very important, and various other agents, including melatonin, has been recommended. Fatigue, again, one needs to look at the cause, likely causes, and address non-pharmacologically with psychosocial, spiritual care, regular physical activity, and cognitive and psychological therapies. And the cause of it can be addressed pharmacologically. Restless leg syndrome can occur in up to 20%, and one needs to treat the causes initially, ensure that there's sufficient iron, correct hyperphosphatemia, avoid caffeine, especially after midday, and complementary therapy. And then one could use various neurotropic agents such as pregabalin or gabapentin if these are available. Breathing difficulties, again, one needs to look at the cause, whether there's severe anemia, infection, pulmonary edema, anxiety, and these can be addressed. And as further on, one could give diuretics, loop diuretics, up to a maximum dose of 250 milligrams daily if the patient is not anuric, and one could add hydrochlorothiazide to optimize diuresis. And if it's not due to fluid overload, one could add morphine or lorazepam. Depression and anxiety, very important symptoms that affect psychological well-being, and therefore these symptoms need to be managed with psychosocial and spiritual support, with family and patient education. Support groups are very important, with peer support, family support, support from religious leaders and friends. And in the case of children, it's important to get the child to school, even if for short periods during the week. Exercise helps to improve mood and anxiety. And it's important to involve other therapists, such as occupational therapists, social worker, psychologist, and psychiatrist. And various drugs could be offered to try and treat depression. Looking at the typical supportive palliative care trajectory, as mentioned, one needs to assess palliative care needs and address the emotional component. One needs to have person-centered decision-making where goals of care are addressed. One needs to address symptoms, and this is very important. And then subsequently, as symptoms progress, complications ensue, one needs to address goals of care. And as the patient deteriorates further, one needs to discuss hospice-type treatment and end-of-life preparation. And then finally provides care for the family in the form of grief support. So one looks at the various components of supportive care, where one coordinates supportive care with communication, symptom control, continued learning, and care in the dying phase, and carer support at all stages. Finally, looking at the recommendations from this KDIGO conference on supportive care. Supportive care should be available to all patients with advanced CKD and their family throughout the course of their illness, and it should be provided on the basis of need rather than solely on estimation of survival. And therefore, it's important to identify those patients who are most likely to benefit from supportive care interventions and to assess and manage symptoms effectively. Important to estimate and communicate prognosis, especially with regards to survival and future illness trajectory, and to develop appropriate goals of care that address patient preferences, goals, and values. And it's important to have knowledge of local supportive care services and be aware of when and how to refer, and to assist with care coordination. As far as education goes, supportive care should be a core competency, and therefore education for this should extend beyond nephrologists and palliative care specialists. It should be part of the nephrology curriculum for trainees at both undergraduate and postgraduate level. And therefore, supportive care should be offered at all levels of chronic disease management. And finally, one needs to look at research priorities and to have further research on supportive care. And therefore, to conclude, it's important that patients' quality of life is enhanced with both curative and supportive care measures. So to conclude, thank you very much for your attention and for the invitation to speak at this meeting.
Thank you very much, Dr. Naicker. By convention, we do not permit questions for an invited oration, and we thank you very much for highlighting the very important aspect of conservative care of patients with chronic kidney disease. This is particularly relevant in a situation like ours, where majority of patients really are not able to access renal replacement therapy as required. So thank you very much on behalf of the organizers and myself for giving us this very important message.
Thank you.
Thank you, Dr. Riker. It was a wonderful lecture. The calm way you went on explaining how to manage, especially to how to delay the progression of the disease, and mainly manage the give the symptomatic care. And you talked about the psychological support, management of pain, management of depression. We nephrologists, whenever a patient comes with symptoms, we jump to write some medication. You fantastically explained how we should adopt non-pharmacological methods before we write some medicines. As such, we know that most of our patients are burdened with so many pills. And I'm really impressed the way you went on explaining what are all the non-pharmacological methods that we can adopt. It was great learning for me. And it was wonderful listening to you. And I congratulate for having received the Vidya Acharya oration. She was our teacher and she was my examiner too when I took my nephrology board exams. It was really great listening to you. Congratulations. And again, as Dr. Chacko said, I would like to congratulate you on behalf of the organizers for having given this wonderful talk. Thank you.
Thank you very much for your comments. I appreciate that and appreciate the honor of being invited to give this talk. And I think a very important component that I also need to emphasize is communication, because I think communication at all periods of the patient's care from the time of diagnosis during treatment is half or a big part of the battle in treating patients with chronic disease, especially chronic kidney disease. Thank you.
I wish we all had similar calmness in talking to the patients.
Thank you so much, Dr. Sarla Devi Naicker, ma'am. You've always been very supportive towards women in nephrology in India, and Women in Nephrology Africa has just come in, and you're the mother of Women in Nephrology Africa. And we both are like sister organizations. It's really nice to have you do the Vidya Acharya oration for us. Thank you so much, madam. The official citation will be mailed to your address. Since this is an online program, we're not able to share it with you, but we will officially mail the citation to you. Thank you so much, Dr. Sarla Devi Naicker, for sharing your valuable insights and your valuable time with us. Thank you.
Thank you very much. And I must also thank WIN India for stimulating and supporting the formation of WIN Africa. I think without the support of your president, Dr. Urmila Anand, we probably would not have proceeded with WIN Africa. So we are very much in the infant stages, and I'm sure we'll depend on you for support to make Win Africa a success. Thank you.
Thank you, Sarna ma'am. Thank you, Chapel sir.
Sorry, I missed that.
Thank you, ma'am. Thank you.
Thank you.
We close the oration.
Thank you very much.
Moving on to our next scientific program, it's a panel discussion, and I would like to invite on stage our chairpersons, Dr. Sundar Shankaran, consultant nephrologist and program director at Aster Institute, Bengaluru. Dr. Ram Mohan Bhatt, consultant nephrologist, Institute of Nephrology, Kaveri Hospitals, Bengaluru. Dr. Sushma Rani Raju, senior consultant nephrology, Sapna Hospital, Bengaluru. Dr. Subhashri Mohan, assistant professor nephrology, GTKMCH, Tuticorin.
Request all the PGs to go for the quiz in the lunch area. Also, the tea will be served in another 5 to 10 minutes in the exhibition area. The sessions will continue.
No tea for us, huh?
Sessions will continue.
I think Ram Mohan Bhatt is my other fellow. Good afternoon, colleagues. Very honored for me to be one of the chairpersons for this important scientific Chacha. I have my eminent colleague Balal there, so I'm sure we can take his input also on this. The topic today is approach to failing allograft. I think very important topic from a transplant perspective. In fact, the fifth commonest cause of patient going on dialysis, in my own experience, and even in the US, is failed graft. So we have a brilliant panel, the women in nephrology of India, brilliant women, I would say. Starting, we have Rajini. Rajini is a consultant nephrologist in Apollo Chennai, but incidentally, I call her Namma Bangalore Udigi, because she was in Bangalore for a time. So I call Rajini first to do the order. Rajini, she's here. She couldn't join. She's not going to join. Okay, then we have Rajiv Ronson from Madras Medical Mission Hospital. Rajiv.
Hello, the other two members are, one is the Priya John and Smriti Sinha. Thank you, Judge.
Yes. Good evening to one and all. It's an honor to be a part of this very important panel discussion on a failing kidney allograft. And I welcome both my panelists and our esteemed chairpersons to this. Screen is not moving. So Ranjini unfortunately could not be with us. So we'll be leading you through a real life case discussion on the various aspects of a chronically failing kidney allograft. Not moving. Yeah. Slides are on. Slides are on. Thank you. So our first case revolves around this 40-year-old male, Mr. Z. He had a kidney transplant from his mother in 2014. The native kidney disease was chronic crescentic IgA nephropathy. There is no immunology details available. He has a good graft function with an added creatinine of 1.1 milligram per deciliter, and he had a good normal urine analysis. He was on triple immunosuppression with tacrolimus, MMF, and prednisolone. In 2017, his urine protein was 3+, and he had microhematuria. His creatinine had risen to 1.6 milligram per deciliter, and his spot PCR was 1.4 grams. At this point, an allograft biopsy was done, which showed IgA nephropathy with an Oxford MES scoring of M1, S1, and T1. So almost a chronic IgA nephropathy. So here we are dealing with a patient with a chronic allograft dysfunction, probably due to a recurrent disease. So coming to this particular patient, how do we define a failing allograft? And is there an EGFR cutoff used when counseling patients? So a comprehensive consensus regarding the definition is actually not there, because if a patient like this, for example, at 1.6 milligram per deciliter falls under a CKD stage 3 to 4, and there are other and consensus definitions which say that only when they are initiated on dialysis can we actually say that they are it's a chronically failing allograft. But recently there has been a study where they have shown the different GFR trajectories, which is nicely shown in this picture here. So here we have the first two where they have an excellent kidney function, remain stable over time with a gradually decreasing GFR. Then we have the third trajectory. It starts off a little low and it then rapidly declines. And you have the last trajectory where it starts low and really rapidly declines. So these patients probably we need to kind of, I've star marked them, but basically star mark them as patients who are actually belonging to the chronically failing allografts. You also see those trajectory 7, class 7 there, where they have a low GFR, but they're stable right there. So do we actually classify them into this chronically failing allograft? We'll see in the next few slides. So recently in American Journal of Transplantation, they had a basic definition which says, include patients who are stable but with a low allograft function, probably less than 20 ml per minute. A declining function when there is irreversible and progressive decline in kidney function with anticipated allograft survival of less than 1 year. And if they have already returned to renal replacement therapy or had a retransplantation. So all these patients fall under a category of failed allografts. So what are the causes of a failing allograft? I invite Dr. Smriti to take this question.
So failing allograft can broadly be classified into immunological and non-immunological causes. Failing allograft most common is your immunological causes, which includes your acute rejection, basically an ABMR which never recovered, or a chronic rejection, which it can be a chronic ABMR, or sometimes you have repetitive ARs which happen to the patient, which can also lead to a chronic allograft dysfunction. And there are some risk factors which we commonly come across in these set of patients, like they can be HLA mismatched to begin with. They were sensitized, especially your second transplants or recommended blood transfusions. So anyone who has history of sensitization has a 9-fold increased chance of ABMR. And there are studies which show that if we do C1q binding capacity of these antibodies, then they, if they have the capacity to bind C1q, then these antibodies have worse prognosis and higher chances of graft failure. Non-adherence is a very important factor, especially when we are considering for retransplantation in these set of patients and in younger set of pediatric patients where non-adherence frequently leads to rejection, and even certain episodes of infections can precipitate an infection. Your non-immunological causes, inadequate kidney mass is one of the major causes. There is a new ratio which has been proposed, which is your kidney weight is to recipient weight. If this is less than 2.3 gram per kg, then there is an increased risk of glomerulosclerosis. So, an inadequately sized kidney being transplanted can lead to a more faster failing of that kidney. Then disease donor transplant, especially if they've had a prolonged chronic ischemia time because of the immune reaction that occurs after cardiac or brain death, there is diffuse injury that happens in the graft. So that can also lead to kind of increase the propensity towards chronic allograft dysfunction. Post-transplant, metabolic factors need to be controlled. So your hypertension, dyslipidemia, diabetes, if they all are uncontrolled, they can again lead to recurrent disease and chronic allograft dysfunction. Recurrent or de novo GNs, primary diseases coming back, but diseases like oxalosis and HUS generally come more with acute failing of graft than chronic. Then you have BKV nephropathy, CNI toxicity, and renal artery stenosis. These are the most common causes which are associated with your graft dysfunction. Just move on. The top 3 causes that we have in biopsy series is your rejection, mostly antibody mediated, death with the functioning graft. So actually cardiovascular mortality in transplant subsets is also another factor which is very important. And third is recurrence of glomerulonephritis.
Thank you, Smriti. So death with a functioning graft. So does this have any implication in our interpretation of the definition of allograft dysfunction itself? So what do you mean by death with a functioning graft? So death with a functioning graft is that the patient has died with no renal replacement therapy done. And that is the definition. But here they have failed to include patients who have a chronically low stable graft function, or patients who actually require kidney replacement therapy were probably palliated, or they refused the renal replacement therapy. So these are not considered in the definition of chronic allograft dysfunction. Probably we may say this, okay, this is just a terminology change, but I think a certain amount of the nuanced definition is required for us to have better data on chronically functioning, non-functioning allografts from an Indian setting. So coming back to our India index case, there was no change made in the immunosuppression. He was started on angiotensin receptor blocker. In 2018, that was 2 years after he was diagnosed, his creatinine was gradually rising. And by 2019, he was counseled and a left vascular access was created. So, Dr. Priya, what are the options available for patients with a failing allograft?
Yeah, here we have a patient whose allograft is likely to be failing. So somebody who is of this candidature, the discussion starts with a directed conversation with the patient and the caregiver, that is the family. So, because the options available for a failing allograft patient depends upon his candidature or willingness to go back to dialysis or transplantation. So we should start a conversation with them, have a discussion, patient-directed discussion with them, and sort out all the options, whether he is willing to go back to dialysis or transplant. It again depends upon his age and his native kidney disease and other things. So somebody who is, and it also depends upon the level of allograft dysfunction. So as the previously pointed out by Dr. Ranjini, that somebody whose allograft is failing but stable graft function, that is GFR more than 20 ml per minute, it depends upon whether the patient is an allograft candidate or not. So if such patient is a candidate for transplant, probably maintain immunosuppression at an optimal level with continuous monitoring of the therapeutic drug levels, along with the measures to preserve the residual renal function by various measures. At the same time, manage the chronic kidney disease. The chronic kidney disease is going to land into, that is by regular monitoring of his hemoglobin and his metabolic acidosis, or his calcium, phosphorus, vitamin D, whether he's lining up in secondary hyperparathyroidism, and many other things. And suppose if his allograft is failing or declining very rapidly, then if he is a candidate for candidature for a transplant, then we should establish a baseline panel reactive antibodies and then monitor them regularly and optimize the immunosuppression. And these patients are also to be assessed if they need graft nephrectomy. So that is altogether a different discussion. So basically, the conceptual management of failing allograft depends upon taking a proper history, whether he has
uremic symptoms, whether he needs dialysis right now, and the baseline cardiovascular risk assessment to be done, and the risk of infections and malignancy in that particular patient. And physical examination is more important to assess this volume, and more importantly to see whether he has a patent vascular access, if at all he needs dialysis in the future, and blood pressure, optimal blood pressure control, as well as more importantly his nutritional status. And it's always important to know what medications he's on, and because it's important to adjust the dosage of these medications depending upon the eGFR, his landing. And there is a caveat of utility of this eGFR in some patients, because it is said that eGFR is estimated using serum creatinine, and much of our allograft patients probably have lower muscle mass, and GFR is always overestimated. So probably cystatin C based eGFR measurements are better in our patients, in our allograft patients, renal transplant recipient patients. And regular lab monitoring of your hemoglobin and for CKD MPT panel, as well as albumin levels, to see where it is lying up. And more importantly, the plan is to be like whether it is a dialysis candidature or a transplant candidature, and always important to have a communication with the primary nephrologist if it is going to be transitioned to a dialysis center. And above all this, psychosocial assessment of these patients play a very important role, because many of these patients may not be willing to go back to dialysis, and they might land up in anxiety and depression, which would definitely lead to non-adherence to their medication, which would again have an impact on them. Yeah.
So, considering all this, and suppose the patient does not have uremic symptoms, in a failing allograft, is initiation of renal replacement therapy better? Earlier is better?
Yeah, so we don't have much of the randomized controlled trials of initiation of RRT in renal allograft transplant recipients, but something we have two of the largest observational studies in initiation of RRT in failing allograft recipients. So we have one study by Gill et al., who looked at around 4,000 odd failed renal allograft patients, and he found out that the patients who were initiated dialysis on a higher GFR didn't survive when compared to the patients who were initiated dialysis with lower GFR. So and he found out also that 1 ml increased GFR, and initiating dialysis with 1 ml increase in the GFR puts the patient at risk for 4% risk of death. And one more study by Molnar et al., who looked at around 700 renal transplant allograft patients who landed in allograft receiving renal replacement therapy, observed similar results, that the patients who were initiated with higher eGFR, they were non-survivors, and the patients who were survivors had a lower eGFR. But again, this is confounded by many bias, probably because the patients who were symptomatic would have required dialysis, and they would have had a higher GFR. Symptomatic in the sense of fluid overload, infection risk, and also that they must have that probably the confounding bias is not taken in these observation studies, is not properly removed. So, and hence there is a bias. And this study also found that there is a 6% increased risk of death in patients who were initiated dialysis with 1 ml increase per GFR. So probably it depends upon the symptoms of the patient. Symptomatic symptomatic management of the patient is better in terms of initiation of RRT, subset of patients.
So what I understand from your detailed analysis is that it's not very different from a non-transplant scenario. I think it has to be individualized. We need to see the symptoms, and there's nothing like you come to this GFR, you start dialysis. It's more like see the symptoms, see the labs, discuss with the patient, and then decide the modality.
So the only difference is, I think we can project the declining renal function in a chronic kidney disease patient who's transplanted. But in allograft, the patient, the results are more rejections, more infection risk, and all that will put them at a rapid decline of renal function. So,
yeah, so the number of AKIs, if I can say it, is much more in these group of patients. So this guy is now on dialysis since 2021 and now has come for a retransplant with the older sister as a potential donor. He's been continued by his local nephrologist on MMF and prednisolone. Now, he is actually behind my life saying transplant immediately, but he's been febrile for a month, and now we have diagnosed him with TB lymphadenitis. His PRA class 1 is 50% and class 2 is 99%. We were awaiting the SAB results. With this in place, how do we manage immunosuppression and immunosuppression waning on diagnosis? So there are many factors which determine immunosuppression management in a failing allograft. And there are no randomized controlled trials which tell us that this is how we exactly do it. So it is dependent on many factors. One is the physician experience, that them being a transplant physician versus a general nephrologist. A retransplant candidacy, that's very, very important. And how much they have to wait for the retransplant. And so basically the waitlist times and whether they have the availability of a suitable donor. Now this again should be personalized to various things. Now if it be transplant candidate, we need to know whether how sensitized they are and how do we avoid that sensitization. And we need to facilitate a preemptive transplant if the patient is fit, and try to avoid a transplant nephrectomy as much as possible. Now, the residual renal function plays quite an important role in deciding whether to continue immunosuppression to a large extent. So there are small studies which have shown that a failing allograft with a small residual renal function actually did better when they were continued on immunosuppression. And of course, it also improves us to transition the patient to dialysis in a better fashion. And of course, we have to look at the complications of immunosuppression, one of it being infections, which is very, very high, especially when the patient has been instituted on dialysis. The infection risk is much, much more. The malignancy risk. Now, this is a bit of a controversy. So there, one of the largest studies have been done in an Australian setting, where they studied 8,000 patients, and they found that once a chronic allograft patient has been initiated on dialysis, they found that it was the infection-related malignancies reduced, whereas the chronic kidney disease-related malignancies actually increased. And in their setting, they actually stopped immunosuppression in patients who had skin cancers, though we don't see much of it. And of course, the cardiovascular risk is something that we need to look at a high level, especially since this patient has been immunosuppressed as well as being a chronic kidney disease patient for such a long time. So this is a consensus guideline, which gives us a sort of a summary on what to do with patients who have a chronically failing allograft. So there are two questions we want to answer. Do you want to retransplant this patient or not? That's an important question you want to answer. Second is this patient having a stable graft function which you are managing? Is this patient a failing transplant and rapidly declining, or he has already returned to dialysis? So considering this, if it's a stable transplant function, you would manage it like any other CKD and transplant patient together. So essentially monitor the immunosuppression, optimize the CKD management, routine malignancy surveillance. Now, not a candidate for retransplant, then I think this is the time. So in the morning, we discussed transition from pediatric to adult care. This is almost like that, where we re-transition them back to their general nephrologist and continue close monitoring at the transplant center. So this is where low clearance clinics are very, very important. So when I was doing my fellowship, it was one of the things, and it was actually done by the nurses, and they were closely monitoring these patients who had a low stable graft function. So optimize CKD management and again, kind of manage the immunosuppression as much as possible. Now, if it is a failing transplant with a declining function, then and the patient is a candidate for retransplant, then relisting and getting a PRA and seeing how sensitized they are is very important. Living donor champion, not taken off that much in India yet, but yes, and optimize the waitlist management, start counseling for a preemptive transplantation and get a vascular access in and prepare them for dialysis. Now, at this point, it is better to continue the CNIs because it helps to prevent formation of de novo DSAs. Now, if it is not a candidate for retransplant, establish a vascular access, maintain CNI reduce the antimetabolite by more than 50%, keep them on a low dose prednisolone, and slowly watch if they are getting any graft intolerance syndrome. Now, if a patient is a failed allograft who has already returned to dialysis, then we monitor their PRA every 3 to 6 months and taper the immunosuppression in a more gradual fashion. So first, reduce the antimetabolite by 50%, maintain CNIs and the low dose prednisolone. 3 months after that, stop the antimetabolite, maintain the CNI and the low dose prednisolone. And as time goes by, if 1 year everything is stable, then you can actually stop the immunosuppression and wait. So I think Sir can.
Transplant. I think you've brought the entire narrative of feeling graft. The two things come to my mind by practical experience. When you tell a person who's having a failed graft, if also depends on who is the donor. If it's a cadaver donor or an unrelated. 30 years ago, I was doing a lot of unrelated donors. Very easy to tell them your kidney is gone, pay some more money, you'll get a kidney. It's easy to convince them to go for second transplant. Or in the cadaver donor, the emotional attachment is not there. But the close related donor, it becomes very difficult. They don't want to stop immunosuppression. So that's where we have problem in India. Even though I have a patient who just moved from another hospital, transplanted last month only, cadaver transplant, but a lot of problems, with fungal infection, that, so we have to stop the immunosuppression. But because of the cadaver transplant, the families agree. So now to put him back on dialysis, it's easy. So again, that is not what you rightly said is the physician experience. Local center is the thing. Coming to the immunosuppression, I think I don't actually follow the protocol which you said 50% all that. My simple thumb rule is anybody going for second transplant, first thing I do is I reduce immunosuppression. But moment they go on dialysis, I stop the microphone or that azothactin. I keep them on steroids. I keep them on steroids small dose, 5 milligram or so, till they go for second. I don't stop it at all, even after one. So some of my patients are on dialysis 2-3 years on small dose of steroid going for second transplant. So that is my feeling. Because I've tried stopping and they've had some problem. Then I have to give, in one patient, I have to give Solimedrol to make it better. So this is, I think, what you rightly said is a physician's experience. The other thing about starting that, I think very rightly you said, I think it should be like a non-transplant only. If somebody's had transplant, the potassium is 7, you are not going to say, I will not dilate. I think you have to use our clinical judgment and go about it. But the problem is, a person who's had a transplant, most of them I see by experience, the transplant physician is scared to tell the patient that you need dialysis. And I've seen in Bangalore, I don't want to name, because of this, we have lost patients. Patient has been transplanted, they don't want to dialyze. They feel, how do I tell the patient you need dialysis, your kidney is gone? So they go on delaying, giving diuretics, do all that, and the patient is dying. So I think we should not do that. We should follow the clinical protocol, your own judgment, and go ahead with the dialysis. That's my feeling. Suma, you have comment, and we'll ask Balal to.
I want to ask you, sir, that considering this antimetabolite as well as the CNI, which one do you prefer to withdraw first?
First one, a good question. I personally feel that azothioprine antimetabolic, to me, it's only adjuvant. I have many patients only on 2 drugs, to be honest. If they are on a CNI, especially tacrolimus, steroid, I've got quite a few like that. They have this GI intolerance, many of them. First thing I do is stop the microfilm. I'm thinking that if you change it to a sodium, it becomes better. Not in my experience. Whether they are Celcept or Myfortic, they got a GI problem, they'll have it. I stop. The first thing to go will be adjuvant, either MMF or that. Then I slowly start tapering the CNI, TAC or cyclosporine. But once they go on dialysis, invariably they will be only on steroid. That is my problem. I'll ask you, after this, you can ask Balal.
Yes, sir. Your opinion, please, about antimetabolites or CNI.
I am not prepared for this, but since my good friend Dr. Sundar is asking this question, I think in addition to what Dr. Sundar said, that a graft is very sad thing, especially in our country. In addition to the reasons he mentioned, I think the financial burden of another transplant or long-term dialysis is something that most of you cannot bear to do, very sensitive to it. And I do agree that we should not stop the immunosuppression immediately after the kidney fails. I have seen a lot of graft that could be done, because of intolerance, because people some TPS based. So I think she gave a very good protocol for withdrawal. Obviously, Sundar and I meet I do continue the steroids in low doses of the I am not so aggressive with PNI because I also feel when the kidney is failing and there's not much here or left, probably PNI may have some fibrosis. So I am only withdrawing the CNI and then that's not me. And then of course, I could then later with the plasma and you can also. But steroids I can get to my.
Also, I would like to ask in this scenario, once we get to know that there is a chronic allograft nephropathy which is setting in, so we would like to actually work towards preserving the residual renal function. How do we go about it?
I think that's Suma, I think it's a very good point. I think that is similar to any non-transplant, but of late, I mean, I become a sort of fan of DAPA, whether you like it or not. So even in transplants, when I can't do anything. It's become like Sarva Roga Nivarani, Sarva Kidney Nivarani. DAPA has become part of my armamentarium. I'm using it. Maybe I'm overusing it, but I think it's my experience and sort of brand, I can afford to do it. I'm not trying to both, but I'm using that quite often.
Yes, if you have any comments. There is also one consensus that late conversion of CNIs to belatacept also preserves residual renal function.
But it's very expensive. Not available in India. Theoretically, okay.
Also, I think it also depends on the reason why the allograft is failing. So if it's a chronic AMR, it's going to fail a little faster. If it's something which is like an IgA in this particular patient, 2018, he's got diagnosed in just 23, he requires a transplant. So obviously adding the ARB at that point was a smart move. So that helped him to some extent, though he was proteinuric. And in the next part of the discussion, we'll also come to the modes of dialysis, which can actually preserve the renal, residual renal function. And so this is, my apologies, but actually speaking in our dialysis unit, all those people who have got retransplants have all actually only been on low dose prednisolone. I think years of experience, and those patients obviously have been managed like that, and they've actually done fairly okay. They've not had any major issues. So, so essentially see whether the patient needs a retransplant, whether the patient has a residual renal function, and of course monitor the sensitization, because if you're going to do a retransplant, you need to plan accordingly. And there's something called as graft intolerance syndrome. That's just what we call as graft necrosis, can actually present in various ways. Patients become slightly sicker on dialysis. We may have fever, which is unexplained, gross hematuria, allograft pain, allograft tenderness, malaise, weight loss, and other systemic symptoms like resistant anemia, etc. So we need to keep a close watch on patients, especially if we have stopped the immunosuppression and on dialysis they are developing these symptoms. Then it's very important to manage these patients accordingly. So so now that we have transitioned to dialysis, let's say, what are the advantages and disadvantages of hemodialysis and peritoneal dialysis in a failing allograft? I think Dr. Priya will take this question.
So we see in the literature about comparison of different dialysis modalities in renal transplant recipients with allograft as failed. So there are a few studies which compare head-on comparison between HD and PD. So one study by Davis set up in 2001, for it up to 10 years, they found that PD and HD groups had similar outcomes. And the largest study in the recent times was of Pearl et al., who did again head-on comparison between HD and PD with the median follow-up of 3 years. He did not find any survival outcome difference between PD and HD, but patients who had preemptive transplant had better outcome. And then if you compare the patients who are transplant naive PD versus or transplant naive HD versus those whose allograft is failed and back to dialysis, their mortality is definitely higher, and the technique survival, if we offer peritoneal dialysis, also it is little difficult in patients whose allograft has failed. Next slide. So if you come to the challenges with hemodialysis post allograft loss, If the patient has a native fistula, then that is the best thing we could offer to the patient, which has lowest morbidity and mortality, because he doesn't or she doesn't necessarily need tunnel or non-tunnel dialysis catheter, which prevents the infections. But the native fistula is lower in patients with late allograft loss, and definitely the increase in the tunnel and non-tunnel catheters increase, which will put them at risk of infection, as well as, and the patients on hemodialysis, they have increased cardiovascular risk. Coming to the peritoneal dialysis, if you see this studies by various studies in the literature, most of them did not find any difference between PD transplant male patients different from the PD from the renal transplant patients who are put on PD, except that one study reported that there is an earlier time to first peritonitis episode and probably increased technique failure. So, but this is the recent article which has come in CKJ, which is a retrospective observation study from the Catalan Renal Registry, Sweden. This is observed around 2,000 odd patients whose allograft has failed, out of which 89 patients were put on hemodialysis, and 8% of the patients are on PD, and 2% of them had received a preemptive renal transplant. So they results are that after the first renal transplant or after the allograft failure, PD is superior to history in reducing the mortality, and definitely the outcomes are better in patients who underwent transplant PD transplant group versus transplant HT transplant group. Definitely the outcomes are better with transplant group. So this study, which has come up recently, shows that PD is probably better than HT in preserving the residual renal function also. So, to conclude, we have like the differences is that, like, when if you want to preserve a better preservation of residual renal function is facilitated by peritoneal dialysis, and it is most often the preferred modality for pediatric patients and those who have pre-existing cardiac dysfunction. And it is said with the patients who are transplant, they also that there is a phase survival benefit. Similarly, we have phase survival benefit within first year of initiation of dialysis. But then again, if this benefit lasts beyond that, it's not known. And it is also seen in the previous study that transplant PD transplant transition is better, and they have a better patient survival when compared to patients on hemodialysis.
I just wanted to add to that last study. So basically, even in BDS guideline, what it shows is that PD is better for the first 1 year post failure, and after that, the mortality is either equivalent or maybe even slightly better with hemodialysis. This could also be a bias because of the kind of patients we choose. PD will generally have good residual renal function, and HD patients might have to be started on dialysis immediately, easier to give, especially if you have cardiovascular dysfunction. So maybe the last part that we get that transplant, HD transplant, second transplant is preceded by HD versus PD. This could be because we also have that 1 year time period where a shorter duration of PD after transplant has better outcome.
Also, I think generally also hemodialysis, when we start anytime, the first 3-month mortality is high, whether it is post-transplant or in a normal naive patient, when we start hemodialysis, it's higher. So PD probably has that mild added cardiovascular benefit, which increases their survival. So we'll just go quickly in the next 10 minutes.
Before you finish on the PD thing, I remember 91, I have no experience in CAPD. One patient came from abroad, had transplant, and Balal had just come in. So then I asked him, when do you remove the CAPD catheter? So he told me, wait for a month till you are sure the kidney is working and then remove. So what is the protocol? I mean, like somebody's got a fistula, no problem. Graft failure, you do that. But with CAPD catheter, is there any protocol to say when you will remove? I follow Balal's technique of waiting for a month. Sure the kidney is working, then remove. But what is
in our center, actually, we wait for at least 3 weeks till there is a stable graft function, no rejection before we remove. But I have seen many centers which remove the PD catheter and transition the patient to hemodialysis before transplanting. And I think that is not required. PD is a very good bridge to transplant, and I think that should be continued.
I think that is done. Even I used to do it before. I had experience CAPD, but I agree with you. I don't think somebody else CAPD just to do for sake of transplant week or two. Some people do that. No, but that is.
I think it's more fear of peritonitis.
I also.
I think it's more of a fear of peritonitis, especially from the smaller places where they don't have trained staff who can actually take care very carefully. So in this patient who has IgA nephropathy, and this guy had a crescentic IgA nephropathy before, now 4 years later has a recurrence. Now he wants a retransplant. So how do we deal with outcomes of retransplantation with recurrent disease, Smriti?
So as a victim, recurrence ranges in glomerulonephritis between 9 to 15% in most. Every disease has a different kind of activity. Two glomerulonephritis between two transplantations will not be same, two IgA nephropathies will not be same. But if we've had a glomerulonephritis which caused the first two kidneys to fail and then we do a transplant and there's a recurrence within the first year of retransplant, then the victim says that the disease activity is very strong and there is a high chance of recurrence with the second transplant, so maybe retransplantation is not the best idea. This is what the BKS guidelines suggest. And certain diseases like FSGS, HUS, and C3GN, which are known to cause very high recurrence, especially FSGS, if the first graft is lost to recurrence, chances of second graft loss is 80%. And if the second graft is also lost, then the third graft will be lost 100%. So we should avoid in such subset of patients, so it's patient selection. In HUS, in countries where eculizumab has become available, giving prophylactic eculizumab, especially if you're difficult to treat mutations like CFH, CFI mutations, you can give prophylactic eculizumab, and this has decreased the recurrence to almost less than 20% in some of the cases that they have used this. In C3GN, again, if the first kidney failed very rapidly, then risk of recurrence is very high. So again, the risk needs to be explained to the family. Like Sir said, there's an emotional connect with living donor transplant. So you have to explain this risk before taking them on the journey. There's almost all diseases of GM record with a particular time frame. In this case, IgA record after 4 years. So I don't think it's an absolute indication to not offer him a retransplantation.
Yeah, but I think it can recur quite quickly in the second transplant, considering the fact that his first earlier disease was crescentic IgA. And the other considerations for retransplantation is, I think we have discussed, essentially it is identifying the donor, waitlist them if required, low clearance clinics, immunosuppression management, and preemptive retransplantation. I just want to make a mention of low clearance clinics again, because as Sundar sir rightly said, we're very frightened to tell the patient, okay, this is not working well, you need to go on dialysis. And we do explain to them pre the first transplant, saying, okay, your graft may not function that long, or it may, I mean, it's only a treatment, it's not a cure. But when it actually happens, it's a very difficult discussion to have, and it's important to have other people involved in talking to these patients. We have 5 more minutes to discuss one case. So Mr. R was a 43-year-old. He came, he had a first transplant in 2013 with us. He had a gradually failing allograft due to BK nephropathy. And now he is BK virus negative. He has a functioning fistula. And now he presented with uremic symptom and wanted a retransplantation. So what are the considerations for patients with failing allograft due to BK nephropathy? Actually, it's quite a difficult scenario because it's a second transplant. We are dealing with the fact that they are highly sensitized and we need to give them immunosuppression. So, and BK virus, so there are not actually much data even worldwide where the maximum number of patients is probably in hundreds where they have been retransplanted. And so the first thing is, it is not a contraindication for retransplantation. The outcomes are fairly comparable to retransplantation due to other causes. BK virus clearance prior to retransplantation is mandatory before you proceed. So I think the role of graft nephrectomy or even native kidney nephrectomy is completely controversial in a BK virus setting. Induction therapy is not contraindicated, but we need to be very careful with the maintenance immunosuppression. And a very close monitoring of BK viremia post-transplant is absolutely essential to kind of detect whether BK viremia is going on. And
I have 2-3 cases like this where I used to be cyclosporin and they're doing well. Even though they were on track in the first time, second transplant with being cyclosporin as a good old which Balal and me love, they are doing actually well.
So any role for allograft? So I think I took that question, but when do you generally consider allograft nephrectomy in a chronically failing allograft, Priya?
Yeah, so the broad indication of graft nephrectomy are, in acute setup, we have unsalvageable acute arterial and venous graft thrombosis, which is an absolute indication for graft nephrectomy. And the chronic indications being graft intolerance syndrome and graft malignancy, which is not amenable to conventional surgeries. And recurrent and refractory graft pyelonephritis is one indication. Refractory PTLD, refractory BK viral nephropathy are one of the two of the indications, and sometimes very rarely we do this graft nephrectomy to provide space for retransplantation. Ideally, there are no company data and guidelines for us to proceed with graft nephrectomy, and it is usually individualized and institutionalized procedures are being followed. So the problem with the graft nephrectomy is that it is not a normal surgery; it's a major surgery, and there's a lot of morbidity and mortality to the patients. So the pros and cons of graft nephrectomy are as follows. Though graft nephrectomy decreases allosensitization, it decreases subsequent graft failure, it decreases the incidence of graft intolerance syndrome, it also decreases chronic inflammation, and hence the prevalence of anemia and hyperkalemia and malnutrition is less in patients who undergo graft nephrectomy. Versus cons, the disadvantages of graft nephrectomy are that loss of sponge effect, that is, the patient will lose the ability to absorb the donor-specific antibodies or the antibodies, putting them at high risk for sensitization if the patient had to undergo transplantation in the future. It comes with a high risk of vascular complication, and there is always a risk of remnant allograft being remained in situ, and any other surgery is associated with a high risk of surgical complication and risk of sepsis. The other theory of graft nephrectomy is that embolization of the renal allograft artery can be done using embolization of the renal allograft artery can be done using elastic coils and the instillation of ethanol into the renal artery. But again, though it is a lesser major surgery when compared to the open graft nephrectomy, but it comes with the complication of post-embolization syndrome, which might be seen in certain subset of patients. And the various techniques we have are intraperitoneal approach and extraperitoneal approach, and we prefer usually extraperitoneal approach and intracapsular because most of these are chronic cases.
It's an extremely morbid surgery, and I think what are the advantages or the chance of retransplantation post allograft nephrectomy?
I think the major advantage is that, I mean, there is no clear-cut advantage to defend. Like said, most of the indications are on basis of whether the patient has developed some complication. The only advantage is if you have some space issue primarily, like where the other side artery is not good or the surgeon feels that most places require, so that we can provide.
So the last patient is a 60-year-old, had a transplant, had ABMR, now has a very bad heart, urosepsis, recurrent infections, and we've rebiopsied her. It's a very chronic allograft, and she's actually not a candidate for a retransplantation. So how aggressively do we treat? Yeah, just two more questions. How aggressively do you want to treat chronic rejection? I think it's just that do not treat unnecessarily and aggressively in a chronic allograft. And if any of you have heard this famous song, Gambler, got to know when to hold them, got to know when to fold them, know when to walk away and know when to run. And this is exactly that scenario. It's exactly, basically, please manage it, according to the patient, and do not aggressively go on rituximab and plasmapheresis and IVIG. There is not much of evidence. And one last slide, and just wanted to think, because this is a recent paper which has come in seminars of nephrology, and conservative kidney management, as Sarala Devi ma'am just previously spoke, in a failing allograft scenario.
The conservative kidney management is often spoken in patients who are CKD, but less often spoken in patients who have failed allograft. So it depends upon the patient's goals and preferences. Probably the ideal candidates for conservative kidney management would be older adults with poorly functioning and declining allografts, and somebody who has poor functional status and with high comorbidity burden, like with underlying cardiovascular risk or high risk of infections and malignancy. So it basically revolves around this process that we need to discuss with the family, discuss about the care and the plan, what the patient and the family wants, and the serious business conversations whenever the patient, how aggressively they want to be with the allograft, that needs to be discussed. And if they want just palliative care, then basically management of chronic kidney disease and surveillance of the infection, surveillance of the malignancy, and appropriate and optimal management of immunosuppression should be done.
Pratik?
Basically, it is quality of time over quantity of time for older individuals, typically more than 70, 80 years old, with the high risk for retransplant and who do not want to go back to the life of dialysis. They've already lived that life before they have come for this, before the first transplant happened. So you can put them on palliative therapy, end of care, try and subside their symptoms as much as possible with medication and intervention, and give them the best short life that they have left versus prolonging a more morbid life.
So I hand over the thing to the chairpersons and thanks and sorry for the please stand.
I think vast topic and as Balal said, it's an important topic. You all done a great job. I give it to Sushma to conclude.
Thanks for that all. It was a very informative knowledge. Thank you. Thank you, panelists and chairperson for this wonderful discussion. We are now heading towards the most beautiful segment of this scientific program, that is the inaugural function. So I request everyone to join the inaugural function.
Hello, everyone. Hello, everyone. I'm Dr. Garima Agarwal on behalf of Women in Nephrology India and WIN Karnataka chapter. We welcome all of you to Bangalore, Karnataka. Nam kadeinda nimma ellarigu suswagata. So one of the founding principles of WIN has been mentorship of early and mid-career nephrologists and to provide a platform for its members to collaborate, to talk, to gain mentors and to advance in their careers, along with, of course, academic advancement. And this beautiful baby WIN icon is the result of that. So we begin now our inaugural program. To start with, I'd like to request our chief guest to please join us on the stage. We already have Dr. Pratima Murthy, ma'am. Thank you, ma'am, for joining us. Ma'am is the director of NIMHANS Institute in Bangalore. I'd like to request Dr. Sudarshan Balal, sir, Chairman, Manipal Hospitals, to please join us on the dais, sir. I'd also like to request Dr. Urmila Anand, our president of Women in Nephrology India, to please join us on the dais, ma'am. I'd also like to request Dr. Renuka S. Ma'am, President WIN Karnataka chapter, to join us on the dais. All auspicious things must start with an ode to the Lord, and hence we begin with a beautiful prayer rendition by Dr. Pooja Prabhu. After this, I'd like all the dignitaries on the dais to join us for lighting the lamp.
गजाननयुतं गणेश्वरम् गजाननयुतं गणेश्वरं श्रीगजाननयुतं गणेश्वरं भजामि सततं सुरेश्वरं श्री भजामि सततं सुरेश्वरं श्रीगजाननयुतं गणेश्वरम् अजेन्द्र पूजिता विघ्नेश्वरम् अजेन्द्र पूजिता विघ्नेश्वरम् गणाधिसन्नुत पदपद्मकरम् गणाधिसन्नुत पदपद्मकरम् पद्मकरं कुञ्जरभञ्जन चतुरतरकरं गुरुगुहात्मजं परमाकारं कुञ्जरभञ्जन चतुरतरकरं गुरुगुहात्मजं प्रणवाकारं गजाननायुतं गणेश्वरम् भजामि सततं सुरेश्वरं श्री भजामि सततं सुरेश्वरं श्री गजाननयुतं गणेश्वरम्.
Thank you to Dr. Pooja. With that auspicious start, I'd like to request our chief guests and our dignitaries to please move on to the lighting of the lamp. All good things should begin with getting away with the darkness and starting light. I'd also like to request Dr. Akka Mahadevi Madam to please join us on the stage and be a part of the dais, please.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च पतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं.
Thank you, the dignitaries again. We now would like to request our visionary and dynamic leader of Women in Nephrology India. She's the founder and president of WIN India, Dr. Urmila Anand, to address WIN Icon.
Chief guest, Dr. Pratima Murthy. My husband knows you very well, ma'am. We started our career, he started his career in NIMHANS only. And Professor Balan, I don't have to say because I got my feet wet as he used to stay in nephrology with him only. He taught me a lot. My colleagues here, Nenuka, Garima, Akama Madam, my three ladies and gentlemen, I welcome you all to this second meeting of ours, the Women in Nephrology India Conference in Bangalore, very ably organized by the Karnataka chapter. We started Women in Nephrology about 2 years back, but the concept of this was being incubated many years back by our first lady nephrologist, Professor Vidya Acharya. Whenever I used to meet her, she is actually from Karnataka. She always used to tell us, when are you going to get the woman on board? And we never, unfortunately, could do that. And the dream did not materialize during our lifetime. Then in 2011, again in Bangalore, we had a meeting with Women in Nephrology with the support of Madam Kiran Majumdar. And then onwards, we just have been talking about it, but we did not go ahead as much as 2 years back when we got some support from our seniors, Dr. Muthu Jairam and Dr. Bimla Acharya and Dr. Anuradha Madam, 3 senior nephrologists who wanted us to go ahead. And we started this with a very focused idea of giving an expanding platform to these young women nephrologists that we have in our country. I, fortunately or unfortunately, was the first qualified nephrologist in Karnataka. And that happened 20 years back, ma'am. And we were about as Manisha will say, 10 or 12 in a society. Now we are more than 300. And every year, I think all DM, DNB courses, 60% of the graduates now are women nephrologists, and they are all coming forward and they are very talented. They have extreme clinical ethics and work, and we wanted to give them an expanding platform to express themselves. And this has really worked in the last 2 years. We have publications in Lancet, Nature Reviews, Nephrology, everywhere with this young woman group of nephrologists. We have mentored many students abroad. We have had 2 meetings. We have started our registry. We have a journal. Anupama is sitting here, and the journal is now actually rejecting articles, so which we thought may not happen. So we are in the process of getting our indexing. So we have done a lot amount of work, but our focus in the future is to take the ideas from these young girls, and I use this platform to get back to us and tell us how to go forward and take this organization forward. I thank you, Madam, for giving your time, and sir, to be with us. And I think I end this with all my gratitude, all these girls, Manisha, Manjusha, Swarnalata, they were all the wind beneath my wings when we started it. And I'm glad that we are what we are now. Thank you very much.
Thank you, ma'am, for your ever-inspiring words. I'd now like to call upon Dr. Renuka S., President of the WIN India Karnataka chapter, under whose dependable and responsible leadership this entire event has been possible. Every time all of us were getting panic attacks, ma'am would calmly calm us down. So, ma'am, please address the audience.
Good evening, one and all. Respected dignitaries on stage, my dear colleagues and friends. As the founder president of WIN India Karnataka chapter and as the organizing chairman of WIN Icon 2023, it's my privilege to welcome you all to Bengaluru. And as a senior faculty of Department of Nephrology in St. John's for last 28 years, it's my privilege to welcome you all to St. John's National Academy of Health Science and its beautiful campus. WIN India Karnataka chapter was formed on 10th of September 2022, and that was our inaugural function on that day. After that, we registered ourselves and we became a registered body on 2nd February 2023. On 3rd of February, we had our first national academic program with DM students of St. John's presenting cases in the national platform of WIN India. After that, we have our second academic program on July 20th, 2023, where the DM students from JSS Medical College, Mysuru, presented their cases. At the inception only, we were given the responsibility of organizing the WIN Icon 2023 at Bengaluru. So from that time onwards, the WIN Karnataka team, I should congratulate them. They are working hard to make this function today a grand success. And with the guidance of senior faculties of WIN India and the support from St. John's team, it is possible now today me to stand before you and say this program first day went off very successfully. So we hope tomorrow's program will also go well. And I welcome you all again to this St. John's National Academy of Health Sciences. Thank you.
Thank you, madam. This conference today is a culmination of year-round activities performed by women in nephrology, in academic CMEs, by state chapters, and hence I'd like to call upon our dynamic General Secretary of Women in Nephrology India, Dr. Manjusha Adla, madam, to give a report on the activities of WIN.
Dignitaries on the dais, a very warm welcome and to this WIN Icon 2023. So continuing the points that have been raised by our Honorable President of Win India, Dr. Urmila Anand, I would just like to apprise of the audience out here that what we have been doing over the last 2 years. Though certain attempts have been made for establishment of Win India way back in 2011 in Bangalore itself, but we had emerged ourselves in July 2021 in Hyderabad. So we are privileged that we had grown. In fact, it's a very steep rise for us that we recognized as not locally, but globally too. So we are pleased to say that over the last 2 years, we have conducted about 20 academic activities, just leaving around 2 months aside with regards to the conference and other issues. Otherwise, we had monthly activities with the support of the state chapters. We have also, we are also proud to say that we have a very vibrant website which showcases the dynamic activities that are going on by the Win India. And we also have the newsletter, which is released quarterly, all the efforts done by Dr. Swanlata behind the website as well as the newsletter. We're also proud to say that there are about 150 plus members who have registered officially, and of course 300 plus members in the mailing list for us. And the number is increasing. As you all know that the women postgraduates are increasing tremendously. We are also expecting the Win India to grow much stronger. In addition, we have also made our presence in the World Congress of Nephrology 2022. Virtually, we had participated in the Global Kidney Village, as well as physically in person. The whole team was there in Thailand recently in WCN 2023. Apart from that, the other international activities like World Kidney Day 2022, we had conducted about a week-long activities. All these things wouldn't have been possible with the support of the Win India group, Win State Chapters group. And in 2023, World Kidney Day was in the form of a Penta Day activity, wherein we had 5 days activities. The importance of WKD 2023 was one whole Sunday, that is the 5th March 2023, was dedicated to the all state chapters. At this point, I would like to apprise that there are about 9 state chapters which have been established, which include 2 zonal chapters. I truly appreciate the forwardness, the proactivity of every state which has come forward, whether it be Win Andhra Pradesh, Win Telangana, Win Kerala, Win Karnataka, Win Tamil Nadu, Win Central Zone, Win East Zone, Win Delhi, Win Maharashtra. So we are here, coming from diverse backgrounds and diverse linguistic backgrounds. We are here on a unified and unique platform where we are presenting ourselves to the international platform in a very unique, respectable, and prosperous way. So on 5th March, we had a whole day activity. In fact, it was very much appreciated by everybody that from 9 a.m. to 9 p.m., we had all the state chapters showcasing their work, research activities, a special mention about Win Tamil Nadu, which has done a role skit and play and all this. So this is how we have carried on our activities. And we also have been going ahead with many other activities that we have in our mind. Recently, I'm proud to say that recently we have become officially the member of IFKF, International Federation for Kidney Foundation. That's again a feather in cap for us. So with all these things, we move forward, and I'm sure the lot of efforts that have been put in by the scientific committee led by Dr. Manisha Sahai has attracted good number of people across India. The attendance in today and virtual attendance too. The registrations are huge in number, which is about 280 plus, which is double the number compared to WinICon 2022. And we also have a good number of presentations from the trainees. It's about 71 abstracts submission. That's a humongous number that we can say for a toddler organization like ours. So that's how we are going. We are there recognized locally and globally too. And I also take this opportunity to thank everyone who has supported us directly, indirectly, the state chapters, the state presidents, secretaries, everyone who has been here, and special mention to the Win Karnataka team. Though it was formed recently, they had come forward to conduct this WinICon 2023, and it's, as you see now, it's a big success. Kudos to the whole team. We heartfelt congratulations to the whole team. So I conclude saying that the subsequent year WinICon 2024 will be held in the month of October along with the ISOT in the Ahmedabad place. So we welcome everyone. Please enjoy this conference and join us for our online in-person activities, and let us keep learning and sharing. Thank you. Thank you so much.
Ma'am, I'd like you to please join the dais. Dr. Manjusha, madam, please join the dais. Thank you, ma'am, for that report. As Dr. Urmila was just mentioning, we are also endorsed by the International Society of Nephrology and WIN TTS. So truly for a toddler organization, WIN's performing excellently. The road we take is easier for us now because inspiring and bold leaders took the path less traveled or the road less traveled, as Robert Frost would say. So today, as a gesture, thanking and honoring one such leader, we have our special guest of honor, Dr. Akka Mahadevi, madam. We would like to honor her. We are honoring her today with the Lifetime Achievement Award. And to speak a few words about her, I'd like to invite Dr. Anupama YJ, Senior Consultant Nephrologist. Madam is also the editor of our journal, IJKD. Ma'am, please say a few words about her.
Good evening, dignitaries on the dais and off the dais. It gives me great pleasure and it's a proud privilege for me to be speaking a few words about Dr. Akka Mahadevi. Dr. Akka Mahadevi, as she is popularly known as Akkama Madam to all of us, her students, she is well known to the physicians of Karnataka. She was born in 1939 at Haveri in a large joint family, and she did her initial schooling at Haveri and later moved on to Mangalore and Manipal, where she completed her MBBS from 1965 to 72. And thereafterwards, she joined KMC Hubli, that is Karnataka Institute of Medical Sciences Hubli. She joined initially as a postgraduate student in the Department of Pediatrics, where she got her DCH degree. And later on, she moved on to Department of Medicine, and she obtained her MD Medicine degree also from the same institute. She joined as a faculty also in the same institute in 1972. She moved upwards in the academic career as a lecturer, assistant professor, associate professor, and so on. She became professor and HOD in I think in the early 1990s, and there onwards she continued as the HOD of medicine till 2005 when she retired. So you may wonder why Dr. Akka Mahadevi is being felicitated in a nephrology forum like this. It must be remembered, and it gives me very great pleasure to inform that she was instrumental in setting up the first nephrology unit in the whole of North Karnataka way back in 1991. At that time, the only government set up to provide dialysis was in Victoria Hospital, where Dr. K. Sidraju was working. There was no other nephrology unit in the government sector. And the patients of North Karnataka were finding it very difficult to obtain nephrology treatment, dialysis and other treatments. They had to go either to Bangalore or to go to Miraj in Maharashtra. Seeing the difficulties, she thought that it's good to have a nephrology unit in Hubli, and she approached the government of Karnataka with a proposal to set up a dialysis unit there. And she had 2 units sanctioned to the Department of Medicine in KMC, but getting the machines is only half a challenge, as we all very well know. It requires somebody to get the necessary training and the technical know-how to do the dialysis. So among many of the colleagues were, I was in the Department of Medicine at that time, so I know that very many of our colleagues were a little skeptical about getting not know-how about dialysis. So she took it upon herself and she went on to get the necessary training in Victoria Hospital under Dr. Sidraju's guidance. For 4 months she stayed there, learned how to do dialysis. She went further to CMC Vellore also and get some more advanced training. She sent her technicians, or sent the staff, nursing staff also to get the training, and she opened the unit in 1991. And it was initially a 2-machine unit, as I already told, but we all had the first nephrology experience, exposure to femoral catheterizations, kidney biopsies under Madam's guidance. And later on, it is now a well-established nephrology department in the KMC Hubli, which also gives which has also done renal transplantations and is also a DM nephro, has a DM nephro program. And she retired in 2005, and many of us would have stopped there. But she was a very, she's a very tenacious lady, very determined lady, and she joined SDM Dharwad as a professor of medicine. There, the dialysis unit which had been set up was not functioning very well, and she was asked to take over and put it on the gears. And Madam again worked hard to bring the dialysis unit to the present state. Initially, it was having only 3 dialysis machines, and now it has grown up to 30 dialysis machines. She still continues to go there to the department as an administrative head. She still heads the department, and she is also looking after many of the requirements of the dialysis unit and the nephrology department as well. So it's only right on our part to honor this senior professor who has put North Karnataka right completely on the nephrology map of Karnataka. Madam is patron of Win Karnataka as well, and it's a proud privilege to be honoring her in this forum of Winicon 23. I request the dignitaries on the dais to be honoring her.
Maybe ma'am, you can come to this side, yeah, so that you can.
Such inspiring story. I'd like to request Akka Mahadevi Madam to please say a few words to all of us.
Good evening to everybody. The great people on the dais, or Dr. Sudarshan Ballard, whom I know very well previously, always he has helped us. And Madam, Renuka Madam, and though she was my student, Dr. Anupama, she has become a staff now and she is my colleague now. And all others who are on the dais, people who are off the dais, it is my great pleasure to come to St. John and get felicitation. Before this, I have come many times to St. John for workshop of peritoneal dialysis and seminars and so many I used to attend. Dr. Gopal, he was there and we used to attend. And to setting up a CRRT and everything in, it is Dr. Sudarshan Ballard who has helped. We have sent all the time training the doctors, training all the staff members, and any help is required, always we used to operate Dr. Sudarshan Ballard. Our director, or the Vice Chancellor, Dr. Niranjan is very well known to Dr. Sudarshan Ballard. Always he helps. Recently, only 2 days back, we had a meeting. Then there was a question, who has to do the CRRT? Is the nephrologist or is it the critical care unit or home? That is still, it is a only question. Then I asked, sir, why don't you ask for a friend who is Dr. Sudarshan Ballard? Take your opinion from him. And Dr. Sundar also, I know, I have attended many times, everybody, most of the people.
And one more, my student was there, Nagabedi. And many of my students said, anyway, I am thankful very much to Wincon people. Second anniversary, they have felicitated me. It is really great pleasure to everybody. I thank you, everybody.
Thank you, ma'am. I'd now like to request all the dignitaries on the dais to come forward for the release of the Win Icon souvenir. The Win Icon souvenir is an interesting collaboration between all the different nephrologists and members of Win with academic and interesting content. Also, the sweat, tears, and multiple WhatsApp messages of our dear editor, Dr. Kritika Murli. So let's request the dignitaries to release the souvenir. Dr. Kritika, she's here. Please join us. Please join us on the dais for the release of the souvenir. Thank you, dignitaries. We also have more releases coming up. I'd also like to request you to release the Win Icon newsletter. This is a quarterly newsletter we've been releasing since the last 2 years. This is the 9th edition of the Win newsletter. And the editor is Dr. Swarnalata Madam. In every state chapter, it's because of her efforts and encouragement that this really interesting collaboration comes out. I request Madam to please join us on the stage for the release of the newsletter.
I'll give it to you.
As you know, the newsletter of Women in Nephrology is called Wings, Women in Nephrology and Gupshup. We'd now like to request Swarnalata ma'am to say 2 words about the newsletter.
Dignitaries on the dais and off the dais. I think it's been going very great. And this is one of the endeavor to keep everyone updated about what are the events happening in Women in India Nephrology. And at the same time, I'd like to thank all my editorial team members who have been contributing for this Wings newsletter. And I request all of you to please, keep contributing so that we can, it's just a platform for everyone to, bring up their work, whether it's a clinical work or any other work. If they want to share any of the achievements also, we are welcome to, incorporate that and share it, put it across to the entire Women in Nephrology and entire India, like entire world also in the Nephrology Forum. So I request all of you to please contribute so that we can keep this going. Thank you. Thank you very much.
We have another exciting release. We are releasing a Win song. About this, I'd like Madhusha ma'am to please say a few words.
So I think we are very fortunate in Win Icon 2023. We are having releases by releases. So I think this is the time that we release Win Icon song, which behind which efforts have been done by our joint organizing secretary, Dr. Shruti Tapiawala, in association with the audiovisual team. May I request the technical team to just release a song? This is about a 3-minute song, sir, madam. So this is in the background of music, which starts with Mile Sur Mera Tumhara, and then it goes on different languages, all the South Indian languages as well as the North Indian languages. But the content of the lyrics of the song is all related to the kidney disease, diabetes, hypertension, CKD. So yeah, so I think tremendous efforts have been gone into with regards to the lyrics of this song. So may I request the tech team to just play the song for 1 minute? So this song, we are planning to have it as a national song for the, the brand song of Win India, so that we can use it in all the activities that we are planning to do. Tech team, are you ready to go?
सुर बने मिले सुर मेरा तुम्हारा तो सुर बने हमारा मिले सुर मेरा तुम्हारा तो सुर बने हमारा अवेयरनेस किडनी डिजीज की हर दिशा से बहके लोगों तक पहुँचे डायबिटीज बीपी स्मोकिंग कंट्रोल से सीकेडी रुके हल्के हल्के मिले सुर मेरा तुम्हारा तो सुर बने हमारा मिले सुर मेरा तुम्हारा तो सुर बने हमारा संदेश अंगदान का मरने के बाद हमसे लोगों में फैले ट्रांसप्लांट का रूप लेकर सीकेडी से ठीक हो बढ़ते बढ़ते मिले सुर मेरा तुम्हारा तो सुर बने हमारा माझा तुमच्या जुळता तारा मधुर सुरांच्या बरसती धारा तोमार शूर मोदेर शूर सृष्टि कोरूर कोई को शूर मळे सूर जो तारो मारो बने आपणो सूर निराळो तेरा सुर मिले मेरे सुर दे नाल मिल के बने एक नवा सूर तार मिले सुर मेरा तुम्हारा तो सुर बने हमारा तो सुर बने हमारा
Thank you so much. I'm sure everybody has enjoyed this song, and we appreciate the efforts by Dr. Shruti behind all this coming out. Thank you so much.
Thank you for that wonderful song and and having all of us listen to it. So it's a great honor and privilege today that we have leaders not only in nephrology but also inspiring leaders in healthcare in India here with us as chief guests. So without further ado, I'd like to invite our first chief guest, Dr. Pratima Murthy Madam, to please come and address the audience.
Good evening, everyone. Let me say it's a real pleasure to be here today. First of all, congratulations to WIN, because I think you pipped the neurologists. The women in neurology can't now call themselves WIN. They'll have to probably call themselves WINE now. So it's very good that you beat them to it. Secondly, I thought the logo was something really remarkable, especially the way the eye, is really represents both women and renal disease. So congratulations for whoever actually designed the logo. Congratulations. And of course, the color purple. What better color can you get? So on all these counts, congratulations. I must also express a little twinge of regret at suddenly realizing this program was this evening, because we had another program at NIMHANS, and very, very special, VVS Lakshman is there talking to the faculty at NIMHANS. So, so it is a bit of a competitive interest that I had to decide on. But of course, I made sure I met him and threw a few googlies at him before I came here. So I'm pretty satisfied that that has been attended to. Dr. Sudarshan Ballal, chairman of the Manipal Hospital, whom I've had the pleasure and privilege and honor to interact with on many fora like this. Dr. Urmila Anand, the president of Win India. Dr. Renuka, the president of the Karnataka chapter. Dr. Manjula, the secretary. Dr. Garima, all the wonderful women who have contributed to the development of WIN, both at the India level and in Karnataka. So let me congratulate you on so many things that you've done in just a matter of a little over a decade. You have not only incubated the idea, you've grown it, you've had chapters all over the country, you brought out newsletters, journals, which are, a journal which has been indexed, your participation in so many conferences, the publications in fairly leading journals, and of course, you've done it all together, possibly with just mutual support from one another. So I think all of you deserve a big, round of applause. Of course, I think nephrology, like all other branches of medicine and science, for women to kind of be where they are today I'm sure has not been easy. But what is really heartening for me is to hear that there have been almost 400 registrations at this conference, which I think is a great start and a great beginning. I also think that we're seeing the same trends in other branches of medicine too. I can tell you that when I started my career in psychiatry, when the PGs joined, hardly about 20% of us were women in a batch of 10 or 15. There were just hardly 2 or 3. Now, in the last couple of years, the girls have overtaken the boys. There are more postgraduates in women in psychiatry than men. The second thing is that I can tell you with great pride that all our 3 deans at NIMHANS are women. So it's really wonderful when we see that, people talk about the glass ceiling. And actually, I must say, at least in medicine, if there is capability, I don't know if it exists in the corporate world. People talk about it even in India in the corporate world, but at least in the field of medicine, it's gratifying to see that women achievers have really been able to reach where they are. And it's a proud moment for us to really also understand that 60% of women, of nephrologists are women in the country. Is that what you said, Dr. Urmila? It's coming in now. It's coming in now. So again, a very, very exciting phase. Of course, I think nobody is ever unaware of the challenges very often that women who take careers in medicine have to face. And in that sense, kudos to all the women nephrologists who started off this journey, because I'm sure the challenges were more myriad at those times. Perhaps just having peers in this whole specialty helps us all to be able to deal with, although the challenges continue. I think it's been very important. And I'm very, very glad that your society has been endorsed by the international, society as well, which is great. I do know that your society, and we heard also from Dr. Urmila today, that the goal is really to support young and mid-career women who are, to pursue a
their careers in nephrology, and of course, to mentor them, to support them in their own growth and contribution to this field. And I'm sure this provides an opportunity for many of you to actually not just develop yourself as an individual, as somebody who's contributing in the field of nephrology, but really make sure that we build teams. And I'm sure when we talk about teams, it's not particularly gender specific, because I think teams, override all aspects of gender, age, and so on. But I think having teams working as team members, working as multidisciplinary teams is very, very critical. Again, coming from the mental health space, I know how important it is to have a multidisciplinary approach. And I'm sure it's the same way here. I saw so many topics on nutrition, on anemia, on, of course, transplantation, on ethics, on so many diverse topics that you've been discussing. So I think strengthening not just the participants or the women in core nephrology, but really getting together all the kind of players who need to be supportive to you becomes very important. I was asking Dr. Garima to tell me a little bit about the women who have contributed in this particular area, because I think it's very important to take individual names. I already heard one mentioned by Dr. Urmila Anand, and that was Dr. Vidya Acharya. I understand she's affectionately called the mother of nephrology in India and one of the first lady nephrologists in the country. And of course, I'm sure she entered into this journey when the whole field was perhaps completely male dominated, I'm sure that was the way it was. And therefore, to make a niche for herself, to really have the passion, the energy, and the enthusiasm to establish and develop both departments of medicine and nephrology. And I think this was in Mumbai, in the King Edward's Hospital in Mumbai. So that's really very, very commendable. And also she was the first to start the dialysis and transplantation facilities in that region, in the western part of the country. And of course, closer home, madam, it's such an honor to meet you, Dr. Akka Mahadevi, the ex-professor and HOD of medicine of KMC Hubli. We just heard your inspiring story and how you were instrumental in setting up the first dialysis unit outside of Victoria Hospital.
The only thing I want to mention.
Certainly,
we
madam.
started a transplantation of the kidney transplants in 2019. But afterwards, because of Corona, it was blocked down up to 21, 22.
Yes.
But subsequently, within few months, already we have done 27 live donor and 13 cadaver. Totally 50 transplantations have been done. That is function. We are going to have a function on 12th of August. A celebration is going to be because of 50th century, half century.
The poster girl for women in nephrology.
Thank you.
Her enthusiasm, continuing to date, I think is such an inspiration, marvelous inspiration to all of us. Thank you very much, madam. And of course, we heard also from Dr. Renuka, the wonderful things that you have initiated in WIN Karnataka. And of course, working in St. John's and having this program today in St. John's. Again, congratulations. So it's really, really very nice that you brought in people from all over the country, people of all ages, people at various stages in their careers. And really the website, the journal, the newsletter, and the song, I think, lend themselves to this celebration that you're on. And I love the gupshup part of your newsletters. I think these are all great. Of course, there are inevitably, any field of medicine has its challenges. As there are more players in the field, one has to find the niche for oneself. I already mentioned the importance of team building. Mentorship is also extremely critical. So I want to just say that one has to be really careful in the way one defines success in one's profession, because I think that's critical to happiness. And there is no single definition of success.
So I think one has to really look for what is being successful. I think having contentment in the profession that you've chosen, making a change in the lives of people, playing a preventive role in this very, very important area because it's associated with so much disability and suffering. So being there, developing all the sister areas around nephrology so that one can provide succor and support to people from all developmental ages is very important. Of course, the other thing is really to develop a work-life balance at the end of the day, because again, success in one area very often means compromises in another. So I think that's where all of us perhaps need to kind of really cultivate our support systems, whether it's at home or whether it's at work. So it's about really making sure you sprout roots, and these roots are well embedded in the community, in the family, so that at times when we need to really extend ourselves, we can do so with a sense of security, without a sense of guilt, and be sure that we make the kind of contributions that we're all capable of. There will be times when one has to really see how this balance perhaps alters, because certain times in our lives, certain other things may take precedence. And that is why it is again very important to define what is achievement and how can we go forward. This is true for both men and women. I'm just using women here because we are women here. And I think the same challenges in different kinds are there for all of us who are in the field of medicine. One thing that concerns me is, of course, the amount of stress that has almost pervaded all our lives. I was actually reading a letter to the editor. I think it was in the Indian, one of the journals on cardiology from India. And this was an observation about the increased risk to death among young cardiologists. So this gentleman has analyzed the reasons perhaps and attributes stress as one of the major reasons, for death. I mean, one used to think of genetic risk as one of the most important risks, but this was quite an eye-opener for me as well, because he was talking particularly of interventional cardiology, where there is so much competition between people. There is so much of a pressure to kind of succeed and be at the beginning of the race. And I think some of these aspects are real eye-openers to all of us on how we need to develop perspective when we actually participate in our careers. So I do hope that one of the areas that you will discuss, if not in this conference, in other conferences as well, is really to look at how we can take care of ourselves as physicians, as people who care for others, because unless you take care of yourself, it becomes very, very challenging to be able to take care of others. And I think this is something that as physicians, we don't really pay enough attention. And if we do that, I'm sure all of us will be the better off. Congratulations, madam, on the song, which I believe you kind of contributed to. So while I met some old friends, I just made a new friend, Dr. Sundar, on the dais. So great meeting you. And of course, I'm sure all of you will have a great time at this conference. For those of you who come from other parts of the country, Bangalore, in spite of all its challenges, the traffic, the pollution, is still a wonderful city with still wonderful weather. So on that note, again, let me wish the conference all success and thank you very much for having me. Thank you.
Thank you, madam, for those insightful and inspiring words. You forgot to mention we have great weather, nothing else. So, and now it's my great privilege to invite Dr. Sudarshan Ballal, sir, a leader and a voice in healthcare all over the country, as well as a nephrologist himself, sir, please.
The very elegant super achiever, director of NIMHANS, Professor Pratima Murthy, our inspirational leader in medicine nephrology, Professor Akkamahadevi, the one and only Urmila. You probably do not know a lot of things about Urmila, but I'll share some of the things that I can share. Urmila was instrumental in me setting up the first training institute of nephrology in Karnataka. And thanks to our initiatives, we have over 100 nephrologists trained in Karnataka. And now there are many of them, and many of them I see here. And that's one of the reasons I'm here to say hello to all the students and friends that I had here. Dr. Renuka, Dr. Manisha, Garima, Maitri, Pooja, and where was Purnima? And all my friends. Anupama is somewhere here. Manisha is there too. It's a great privilege for me to be at the inauguration of the Women in Nephrology Conference in Bangalore. This momentous occasion celebrates the significant contributions and accomplishments of women in the field of nephrology. At the outset, I would like to congratulate the organizing team for hosting this meet in Bangalore, and also say a big thank you to all of you, particularly the 3 young women who drove all the way to Manipal Hospital in spite of the busy traffic. Doctors Renuka, Garima, Maitri, to invite me personally. All that they needed was send me a mail or a message. I'd have accepted the invitation anyway because it's so close to my heart. But they came all the way to invite me. Thank you very much. When I first came back to India, of course, the only nephrologist I knew those days, it was Dr. Sundar. So I asked him, what is so special about nephrology? He said, Balal, you will be 1 in a million. So we had about 800 nephrologists for the country of over 1 billion. And truly, nephrologists were 1 in a million or even more than that. But that has changed now. We have close to 2,500 nephrologists in the country, I'm told. The number has gone up 3 times over the last few decades. But there is still a shortage of nephrologists, especially in the semi-urban and rural areas. Sometimes I get criticized by some of my colleagues that we have produced too many nephrologists in Bangalore, and now it's very difficult to get a job. I have to use a lot of influence to get my fellows to get a job in Bangalore. But they go 50 miles away from Bangalore, there are plenty of jobs, but no one wants to do that for various reasons. Unfortunately, the number of women nephrologists have been quite low, in spite of the huge progress we have seen. Less than 20%, I'm told, about 400 nephrologists, women nephrologists in the country. But the silver lining is that more and more women are getting into nephrology, as Urmila said. At one time in our unit, it was difficult to find a man. So things have changed, certainly, and now most of the trainees are women, and I think women have overtaken men in the field of nephrology. I get invited to many convocations for various reasons. And over the last few years, what I've seen is that women have completely overtaken the men, not only in the entry to medical colleges. And when you come to distribute the ranks, it's impossible to find a man. It's only the women who get the ranks and the gold medals. Maybe they don't get distracted as much as men. So be as it may, they've done very well, and I'm sure they'll continue to do well. We now have a whole galaxy of stars of women in nephrology, many of whom are here with us at this conclave. Many women have attained great feats and contributed to the realms of nephrology across the globe. Their work towards clinical and research-based enrichment of the subject has been exemplary. An offshoot of the International Society of Nephrology, Women in Nephrology, was founded in the 80s, I was told, and has successfully helped women to nurture their careers in the field. As we already heard from our chief guest and from Urmila, India has its share too of many great women nephrologists, including Dr. Vidyacharya, who's fondly called as the mother of nephrology in India. In addition to a professional association, I also took care of some of her family members at our hospital, and she was a tough taskmaster. She would treat me like a student. And I was used to people following when I go for rounds. Then she'd say, hey, Sudarshan, come here. what's happening with my brother? Why didn't you do this? Why didn't you do that? That was her kind of personality, but a great lady. She was not only the first woman nephrologist in India, but also the first woman president of the Indian Society of Nephrology, the founding member of Indian Society of Nephrology, and many other accolades that followed. However, in spite of all the progress that has happened, something that bothers me day in and day out is that even today, there's a skewed ratio of women seeking and getting treatment for kidney diseases, including transplant, as compared to men, since our society is still very patriarchal in many ways. I think the solid example of this is the number of people who come to donate a kidney, men versus women, where 70 to 80% of the kidney donations come from women, and there are only a few good men who donate their kidneys to women. It's almost always wife, mother, sister donating, and very rarely do we see the father, brother, or husband donating. So any husband who donates, I sort of felicitate him, saying that you are one of the few good men that I've seen in recent times, which happened last week, I think. One of our patients got a husband to donate. This needs to change. All of us as a society need to work together to change this. This gender discrimination cannot go on and should change. I extend my heartfelt gratitude to the organizers and all the attendees for making this event possible. Together, let us pave the way for a brighter and more equitable future in nephrology, where talent knows no gender boundaries. My heartfelt congratulations once again to Professor Akka Mahadevi for achieving the Lifetime Award for her outstanding contribution to this field in the last few decades. Congratulations, ma'am. We have a feast of scientific sessions during this meeting, conducted by many women, eminent women nephrologists and scientific leaders, with, of course, a few men sprinkled in between. You can see Dr. Sundar here. I don't see any other men in the first row. Sir? Oh, okay, there we go. Of course, Ravi is there, Ravindra is there, so that's good to see. I want to make sure that men don't feel left out, so that we need to start another MIN to counter the win. We started MINU about 30 years ago, but at that time we never knew we would have this intense competition from women. But it's a healthy competition, and that's the way to be. May this conference be a resounding success, and may the impact of our collective efforts resonate far beyond these walls. Thank you, and let us embark on this remarkable journey of growth and empowerment together. Thank you again. God bless. Jai Hind.
Thank you, sir, for those inspiring words. And now, any big event, when it happens, everyone says, have faith, have faith. So yes, of course, there is faith and blessings, but if there is a superhuman force that's binding the entire WIN icon, WIN Karnataka, even the chai wala who gave you coffee and the video wala sitting up there, it is our extremely enthusiastic and dynamic secretary of WIN Karnataka, my dear friend Maitri. So now I'd like to invite Maitri to give the vote of thanks.
Good evening, ladies and gentlemen. It has been an immense pleasure to host this event. On behalf of Women in Nephrology India, Karnataka chapter, I would like to thank Women in Nephrology India team for giving us the opportunity to conduct this event. Dr. Urmila Anand ma'am, Dr. Manisha Sahai ma'am, Dr. Manjusha Yadla ma'am, Dr. Shruti ma'am, Dr. Swarnalata ma'am, Dr. Arpita ma'am, Dr. Sonal Dalal ma'am, Dr. Arpana ma'am, Dr. Manjuri, Dr. Anupama ma'am, Dr. Kalpana, and Dr. Saumita Bakchi ma'am. Our heartfelt thanks to our esteemed chief guest, Dr. Pratima Murthy ma'am and Dr. Sudarshan Ballal sir for gracing this occasion and sharing their words of wisdom. May I request Dr. Urmila Anand ma'am to facilitate Dr. Sudarshan Ballal sir.
He's my teacher. Thank you, sir.
Always.
I'm finishing the process. I might have learned from.
Thank you. Thank you.
He's my teacher. You know, 56. Oh, thank you.
Thank you very much.
Thank you.
I'll do it.
Very well.
We can't take the plaque back.
That will give it.
May I invite Dr. Manisha Sahai ma'am to felicitate Dr. Pratima Murthy ma'am.
Excellent, sir. Always pleasure to see both of you. We are in awe.
Our heartfelt thanks to our esteemed Lifetime Achievement Award winner, Dr. Akka Mahadevi ma'am, for her exceptional contributions to the field of nephrology. We are grateful to Team St. John's Medical College and Research Institute for providing us the venue filled with lush greenery amidst the city chaos. Dr. George D'Souza, Dr. John Verghese, Dr. Paul Partharam, Dr. Tony H.A., Father Jesudas Rajamanikam. Our scientific committee for creating the robust scientific program filled with debates, panel discussions, international speaker talks, quiz, and so on. Chair, Dr. Manisha Sahai ma'am, Dr. Arpita Ray, Dr. Arpana Iyengar, Dr. Srilata, Dr. Sonal Dalal, Dr. Smriti Sinha, and Dr. Rajiv Alochana. Sincere thanks to all the speakers and chairpersons for sharing their valuable time and expertise with us. Our social media team, which has been working very hard to bring Win Icon to your fingertips, creating all the promotional videos and interviews back to back. Dr. Urmila Anand, Dr. Manjusha, Dr. Divya, Dr. Preeti, Dr. Jyoti, Dr. Priya John, Dr. Saurabha, Dr. Kristen, Dr. Smriti, Dr. Isha Tiwari, Dr. Kavita, Dr. Shubhashri, and Dr. Kushbu. Please follow all of them in your Twitter account. Don't forget. Our beloved postgraduate students for their active participation in the poster competitions, in the platform presentations, in the quiz competition. Our Vidu Technologies and Team Ekana, our event management team, for their unconditional support. All the pharma companies for the support in sponsoring this event. And please do visit their stalls. They have lots of exciting goodies stored in for you. Please make sure you just go and drop in a visit there. Well, such an event cannot happen overnight. Wheels started rolling a few months ago, and it requires a lot of planning and a bird's eye for details. Women in Nephrology India, Karnataka chapter, has been fortunate enough to be supported by very motivated and dedicated colleagues from all across Karnataka. Dr. Renuka Satish ma'am, our organizing chairperson, Dr. Anupama YJ, our organizing co-chairperson, Dr. Anita A, lead abstract committee, Dr. Tapoti Mukherjee, treasurer, Dr. Garima Agarwal, the lead of inaugural committee, Dr. Kritika Mohan, joint organizing secretary, Dr. Kritika Murli, lead souvenir committee, Dr. Saurabha Rajana, cultural committee, and also Dr. Pooja Prabhu in the cultural committee, Dr. Kristen George and Dr. Anika Shri, both in the registration committee.
Thank you so much. This event would not have been possible without your immense and unconditional support. We cordially invite you to our cultural event happening tonight at 7:30 p.m. in Hall B. Hope you all enjoy this event. Thank you so much.
Thank you.
And Dr. Sundar also.
Thank you. Thank you, madam. Thank you so much. Thank you very much.
Whenever I'm really alone.
Yes, yes, sir. Can you do
Sure.
that?
Thank you for coming.
Thanks.
My husband sends you.
Thank you, sir.
Thank you. Thank you.
You take me all over the
Famous most wanted. Because she keeps traveling all over. Different places.
So that's probably India. Traveling Gujarat for me was an enormous hospital. I got restricted to the and then so
Yes. We can now.
thank you.
Sure. I'd like you to come. Sure. I'll give you a call before I come. I'd love to see the face.
You and we'll leave it. Please come.
Sure. Will do.
Thank you.
So thank you very much.
Thank you.
Thank you. Good to see you also.
See you there.
Oh, okay. Okay, great.
She brought me here.
I know.
The opportunity.
Good. Sure, we'll catch up.
It's a pleasure.
Thank you. Thank
I request everyone to join for a group photo. Group photo.
Probably come in the way, so we'll have some.
We need to. I thought you were going to dance. You should be starting there or something.
Yeah, I think there.
I've seen videos of them.
All the chapters are contributing.
Can everybody please come in for a group photo? We have sessions after this as well, so if we can finish the group photo, we can move on to the next session. The speakers and chairpersons are already ready for the next session.
Okay, next session. Susina madam. This should be okay. Hello.
Yeah.
Come. Susina, come. Come.
You have to take it from there, I think. Yeah. I think you have to go. Yeah, yeah, we can see it after 30-40 years.
Manisha, neither would I be.
Thank you very much.
Wait, sir.
No, you can come here also. No, but it's right to third position.
I didn't see you. Thank you.
Thank you all. Bye-bye.
We now move on to our next session.
Let's take it out.
Someone has left their phone at the registration counter, please collect it.
I'll call my.
कोई स्क्रीन enable thing they were doing.
We will move on to our next session. It is a panel discussion on Leonard's Metropathy case scenario. The chairpersons are Dr. Pushkara, Professor and Head Department of Nephrology, AIIMS Mangalgiri, Dr. Mukherjee, ma'am, Lead Consultant Nephrologist as the Whiteley
वो स्क्रीन का
India,
मतलब ये निकालो वो स्क्रीन नहीं है
and Dr. Ravindra Prabhu, sir, Professor, Department of Nephrology, KIMS Manipal, India.
निकाल दो his presentation now coming in full screen now you can remove this
Sir, scan.
full screen
Sir, scan.
then
The next scientific program is a panel discussion, and the topic is membranous nephropathy, a case scenario. I would like to invite our chairpersons, Dr. Ravindra Prabhu, Professor, Department of Nephrology, KFC Manipal. Yes, sir. Dr. Uttara Das, Professor and Head of Department, AIMS, Mangalgiri. Dr. Tapoti Mukherjee, Lead Consultant Nephrologist, Aster Whitefield, Bengaluru. Dr. Ishtiaq Ahmed, Consultant Nephrologist at Transplant Division. I request the panelists, the chairpersons to introduce the moderator and panelists.
Good evening. Good evening and welcome to the panel discussion on membranous nephropathy. And it's a privilege to invite the moderator for the session, Dr. Saxena Alexander, Professor of Nephrology at the Christian Medical College, Bengaluru, India, who has the breadth of knowledge and experience in this topic. I request my co-chair to introduce the panelists.
Thank you, Benicon 2023, for inviting us as a chairperson for the session. I would like to introduce the other panelists. Dr. Manju Thampi, Chief Consultant Nephrologist, NIMS Hospital, Thiruvananthapuram, Kerala. Is he here? Dr. Isha Tiwari, Assistant Professor, NGM, Super Specialty Hospital. She's not here. Dr. Kritika Mohan, nephrologist and transplant conditioning, Transplant Hospitals, Bangalore. Dr. Ravindra Prabhu, Professor, Department of Nephrology, PNC, India. Welcome, sir. Dr. Uttara Das, is she here? Dr. Uttara Das is Professor and Head of Department, NIMS, Hyderabad. Is Madam here? Okay. Me, Dr. Tapoti Mukherjee, I'm from Aster Whitefield Hospital. And Dr. Ishtiaq Ahmed, the Consultant Nephrologist and Transplant Division, is not here. He's from NH Bangalore. So we can go and we can begin the session. Dr. Saxena.
Good evening. Thank you, Win India and Win Karnataka, for giving us this opportunity.
Can somebody show us how the slides will move? Right, so this panel discussion is going to be on membranous nephropathy. This will be the format of the presentation. We'll have case presentation. Dr. Isha has sent her apologies. She's sick and she couldn't make it, but we got to know that very late. It was only yesterday that we got to know, but gladly Dr. Manju has agreed to step in and she will be doing Dr. Isha's role also. Followed by that, there'll be certain questions and the panelists will be answering that and it will be open to discussion. Now I invite Dr. Manju on behalf of Dr. Isha to present the case. Okay, thank you. Good evening, everyone. Thank you, Vinicon, for the opportunity. We'll go straight, as we are running late, we'll go straight into the case scenario. A 71-year-old man, non-diabetic, non-hypertensive, non-smoker, non-alcoholic, absolutely nice man from a suburb of Indore, MP, presented with chief complaints of pedal edema extending up to mid-calf since 4 months and easy fatigability for a month. There's no history of any of these recurrent or chronic infections, including tuberculosis, dysuria, lower urinary tract symptoms, hematuria, oliguria, frothuria, joint pains, rashes, jaundice, melena, dizziness, headache, chronic cough, and hemoptysis. It doesn't have any of these symptoms. Clinical examination is notable for pallor and presence of pedal edema. His blood pressure is normal, pulse is normal, so organs are normal, organ systems are normal. And investigations show anemia, which is very surprising for a patient with nephrotic syndrome. Peripheral smear shows microcytic hypochromic anemia with a few pencil cells, which is suggestive of iron deficiency anemia. And there is a decrease in the total protein and serum albumin. Urine microscopy is remarkable for urine shows 3+ proteinuria, and microscopy is remarkable for 6 to 8 pus cells and microscopic hematuria as well, 8 to 10 RBCs per hyper field. Complements viral screening are normal. Total cholesterol is high, 278. Urine spot PC ratio is increased, 6.9. ECG, chest X-ray, serum PSA is normal, and ultrasound shows normal kidneys. So a provisional diagnosis of adult onset nephrotic syndrome with iron deficiency anemia was made. And a serum PLA2 receptor was done. The levels were negative, and stool for occult blood turned out to be positive. So the differential diagnosis would be membranous nephropathy versus all the others. Membranous nephropathy points in favor is age of onset with a slight male preponderance. The point against is the negative PLA2 receptor. Minimal change disease, point in favor is no hypertension, but point against is the age of onset. Amyloidosis could be possible with the age, but points against is no organomegaly and no lab evidence pointing to monoclonal gammopathy. FSGS, again, point in favor is adult onset nephrotic syndrome. Point against is no hypertension and no evident causes at this age of secondary FSGS. So this was a biopsy. The LM showed a stiff, uniform thickening of the capillary walls with little or no proliferation. The immunofluorescence tissue included renal medulla only, so that was inconclusive. And IHC for all the primary membranous nephropathy antigens, PLA2 receptor, thrombospondin 7A, NEL1, and SEMA3B were negative. So again, the impression showed a membranous pattern, glomerulopathy. A colonoscopy was done since the patient had a stool occult blood positive, and the colonoscopy revealed a mass lesion located at the sigmoid colon approximately 25 centimeters from the anal verge. The lesion appeared to be circumferential, irregular, and friable, causing partial luminal obstruction.
Biopsies were obtained from the lesion, which showed features highly suggestive of colon carcinoma, most likely an adenocarcinoma. So the final diagnosis is a nephrotic syndrome with secondary membranous nephropathy due to adenocarcinoma of colon.
Yeah, so I'm sure that everybody will agree with this diagnosis. Now, just imagine this was a pre-Plateau era, okay? Or a Plateau was not available to you. Would you have still suspected secondary in this case? Anybody who wants to answer, you can speak into the mic.
Anemia.
Yes, definitely. So iron deficiency anemia is one of the biggest clues here, especially in an elderly male. So yes, so if you see iron deficiency anemia, even if you don't do stool local blood, you have to go ahead and do stool local blood, because iron deficiency anemia in an elderly male, definitely the most probable cause is GI blood loss. So even in a pre-Plateau era where you do, or if you don't have the assay, still you would go ahead and suspect a secondary cause, and you will have to do the necessary workup. Now I invite my question to Dr. Manju now is, what are the other ways to distinguish between primary and secondary membranous nephropathy with emphasis on pathology?
I'm using Dr. Isha's slides. So she's classified this into primary, secondary, and alloimmune membranous nephropathy. Primary is usually associated with one of the primary antigens, PLA2 receptor associated thrombospondin type 1 domain containing 7A associated NEL1, neural EGF-like protein 1, semaphorin 3B, or uncharacterized. Secondary can be due to a host of reasons like autoimmune or collagen vascular diseases, like SLE and mixed connective tissue diseases, usually associated with exostosin 1 and 2, Sjogren's, thyroiditis, sarcoiditis, and dermatitis herpetiformis, as well as infections, hepatitis B, C, HIV, malaria, secondary or congenital syphilis and leprosy, drugs, toxins, and other adulterants, like NSAIDs, gold salts, penicillamine, mercury, cationic bovine serum albumin in infant formula. So all these have to be asked for in patients in whom we are suspecting a secondary membranous nephropathy. Malignancy, and more commonly solid organ carcinomas like lung, breast, colon, and kidney, as well as NHL, leukemia, can be associated with membranous nephropathy. It's rarely associated with thrombospondin 7A expression in tumor. NEL1 associated is also linked to underlying malignancy. Alloimmune membranous nephropathy is an antenatal alloimmune membranous nephropathy caused by anti-NEP antibodies. It also refers to alloimmune membranous can also be de novo membranous nephropathy in a kidney allograft or a graft versus host disease. Microscopically, this is how you differentiate between a primary and secondary. On light microscopy, usually in primary, there'll be absence of proliferative features, whereas in secondary, there'll be a lot of proliferative features like mesangial proliferation and endocapillary proliferation. Immunofluorescence, normally in a primary membranous, will show IgG, especially IgG4 subclass, and 1+ usually for C3, kappa, lambda, and light chain, and very minimal for the other immunoglobulins and C1q. Whereas in the secondary type, especially related to connective tissue diseases, there may be a full house immunofluorescence, including IgM, IgA, or C1q. On electron microscopy, primary is characterized by the presence of electron-dense subepithelial immune deposits separated by GBM spikes. Here in secondary, the subepithelial deposits can be seen plus mesangial and subendothelial deposits, along with podocyte foot process effacement. Membranous nephropathy is pathologically defined as a disorder of the glomerular basement membrane, and the specific lesion is an apparent thickening of the glomerular capillary walls, which results from immune complex formation on the outer aspect of the basement membrane, that is subepithelial. In primary, the reason is thought to be circulating autoantibodies, which bind to endogenous antigens on the surface of glomerular podocytes, activating complement and inducing podocyte injury. Whereas in secondary membranous, the circulating antigens, which may be endogenous or exogenous, immune complexes or even monoclonal IGs may become planted on the subepithelial side of the glomerular basement membrane and initiate immune complex formation. Studies of the Heymann nephritis model of membranous nephritis in rats established that the subepithelial immune deposits form in situ when circulating antibodies bind to an intrinsic or fixed antigen in the glomerular capillary wall. The antigen was subsequently identified as megalin, which is a large transmembrane receptor of the LDL receptor family expressed on the basal surface of rat podocytes. So circulating antibodies target the endocytic receptor megalin on podocyte foot processes. Subepithelial immune deposits activate complement, which leads to the assembly of C5b to 9, which is a membrane attack complex, and the insertion into the podocyte plasma membrane. Proteinuria via activation of signaling pathways in the podocyte that results in redistribution of actin and loss of the slit diaphragm integrity is what happens. And the GBM expansion occurs by the overproduction of type 4 collagen and laminin by the injured podocytes. PLA2 receptor is highly expressed in the glomerular podocytes and it's a major target antigen in human primary membranous nephropathy in up to 80% of cases. And specific role, what the PLA2 receptor exactly does in the glomerulus is not known. And the antibodies, as I said, are predominantly IgG4 subclass, which is most abundant in the glomerular immune deposits in primary MN. Its target is the N-terminal cysteine-rich region of the PLA2 receptor protein. There's something called, I'll just go to the, this is a picture. There is a large extracellular domain. There is a cytoplasmic intramembranous portion and a cytoplasmic portion. The extracellular portion has mainly got 3 domains. It's got a cysteine-rich domain where primarily the antibodies attack. It's got a fibronectin 2 domain. There are 2 domains for fibronectin and 8 C-type lectin domains. So there is something called epitope spreading, wherein primarily antibodies are produced against the N-terminal 3 domains, and most especially against the cysteine-rich domain. And as many as 80% of patients exhibit reactivity to epitopes within the 1st and 7th C-type lectin-like domains, in addition to the N-terminal cysteine-rich domain. This is by a process called epitope spreading, wherein newer epitopes get exposed when the antibodies attack the primary antigen. Smaller proportion of patients display reactivity to the 8th C-type lectin-like domain. Epitope spreading is associated with 3 bad things. Once it's got a lower spontaneous remission rate, higher risk of chronic kidney disease, and a lower response rate to treatment with rituximab. Clinical presentations from a renal standpoint are similar in primary and secondary. Membranous nephropathy can have an indolent course. Features tend to develop slowly and can be overlooked for months. So 70 to 80% presents as non-selective proteinuria in the nephrotic range. 20 to 30% can present as asymptomatic subnephrotic proteinuria. And microscopic hematuria is common in around 30 to 40% patients, but RBC casts are rare, and that should suggest a different glomerular pathologic process. Urinary sediment usually shows evidence of lipiduria with oval fat bodies and fatty casts, and BP is usually normal in 2/3 of patients. GFR is preserved in most patients, 90%. Only less than 10% present with renal impairment. Venous thromboembolic events may be the first reason why a patient presents for clinical attention, and serum complement levels are normal. It occurs in all regions and all ethnicities. The mean age of diagnosis is 50 to 60 years, with a predominant male preponderance with unknown reason. And in very young children, the SEMA3B or the cationic bovine serum albumin is associated in membranous nephropathy. It's strongly associated with HLA-DR3 and HLA-DQA1 in the Caucasian population. So it's the most common cause of idiopathic nephrotic syndrome in non-diabetic adults worldwide, and is uncommon in children, less than 7% of biopsies. And if you have a child with membranous nephropathy, you have to rule out an associated hepatitis B infection. These are the alleles responsible. And DRB11502 is associated with a lower estimated GFR and a higher risk of kidney failure. Light microscopy is characterized by a diffuse thickening of the GBM throughout all glomeruli in the absence of significant hypercellularity. It may appear entirely normal in light microscopy in early stages. The spikes of GBM extending between the immune deposits may be seen with appropriate staining in more advanced cases, and chronic sclerosing glomerular and tubulointerstitial changes develop as the disease progresses. Electron microscopy is characterized by subepithelial, electron-dense deposits on the outer aspect of the glomerular basement membrane. Effacement of food processes occur of the overlying porous site, and expansion of GBM by deposition of new ECM between the deposits. Mesangial deposits of immunoglobulin are infrequently seen. Subendothelial deposits virtually never seen in primary MN, and most patients have globally distributed immune deposits. It's very rare to have segmental immune deposits. IF shows a diffuse granular pattern of IgG and C3 staining along the glomerular basement membrane.
Thank you, Manju, for the comprehensive take of primary and secondary membranous pathology. Now, in this case, serum plateau was negative. Now, my second question to the panelists is, what are the newer antigens that will help you distinguish between the primary and secondary membranous nephropathies?
Well, I seem to be spending more time at the podium than the moderator. The antigens in membranous nephropathy, primarily it is anti-PLA2 receptor antibody. The testing should be done in all patients with suspected membranous nephropathy, which is virtually all adults with nephrotic syndrome. So the antibody testing should be done in everybody because it's a major antigen. Commercially available tests include indirect immunofluorescence assay, which is more sensitive, but it's qualitative. ELISA is less sensitive, but it's quantitative. And it obviates the need for kidney biopsy if it's positive in patients with a normal renal function, no evidence of secondary causes, and in patients who do not have diabetes. Now, we need to remember that a negative test does not include membranous nephropathy. This can happen in 20% cases. The diagnostic utility, as I said, IFA is more sensitive, and negative levels may mean one of three things. One, the target is not PLA2 receptor. That boat is gone already. Number two, it may be PLA2 receptor, but the patient is in immunological remission. Always immunological remission or relapse precedes a clinical remission or relapse. An early stage of disease can cause a negative antibody level because all the antibodies are getting deposited in the glomeruli. There's nothing left for you to test in the blood. So those are the three reasons why you have negative levels. Positive levels may be seen in small percentage of secondary. So this essentially means that it's just a primary membranous with an incidental secondary cause, because many studies sort of imply that membranous due to secondary reasons is a myth. It's just primary membranous which is associated with a secondary, so-called secondary disease. So even in positive cases, PLA2 receptor positive, secondary causes need to be excluded. The false positivity is very rare. So if it is positive, it essentially means it's membranous. So if it is negative, it may need a kidney biopsy for confirmation. Now, higher levels indicate lower rates of complete remission. It's bad to have higher levels, and persistently high levels associated with less favorable outcome, more chance of progression to renal failure. Falling levels indicate impending immunological remission, which usually precedes a clinical remission. So serial assessments are important for treatment decisions. There's no point in adding insult to injury, treating a patient who's already going in for immunological remission. Levels have less association with levels of proteinuria, though. You can have lower levels of anti-PLA2 receptor with massive proteinuria and can predate proteinuria by an approximation of 9 months. So this is how it's defined, a positive result. There are two types of ELISA available. One of that I've used as a guideline. So more than 204 is very high, and it usually indicates the patient is not going to respond to most modalities of treatment. Thrombospondin type 1 domain containing 7 is another antigen which is important in primary membranous nephropathy. It's seen in 10% patients who are negative for a PLA2 receptor, but in overall 3% patients this can be seen. This is because dual positivity has been reported. Methods of assay same as the other, ELISA, IFA, as well as Western blot. It's also positive in secondary membranous due to malignancy. So again, this sort of highlights the fact that you need to rule out secondary causes. NEL1, that is actually the second most common antibody in primary membranous, but the serum levels, assay for serum levels are not available. That's why I put it third. It's seen 16% of membranous nephropathy in older age with no gender predilection and causes segmental staining. So again, you can miss it on this is available for IHC on the biopsy specimen. Since this causes segmental staining, you can even miss it on a biopsy specimen. So that also needs to be kept in mind. Here, the most common IgG subtype is G1. G2, G3 can also be seen. Anti-PLA2 receptor, predominantly G4. So it's not available commercially for serum testing. Here again, you should rule out an underlying malignancy. Semaphorin 3B primarily seen in pediatric cases, seen as granular deposits along GBM. TBM deposits are very few and can recur post-transplant. So if you're considering a pediatric transplant, who's positive for semaphorin 3B, levels need to be monitored. Peri-transplant is detected by Western blot. Protocathier, that's again available for testing on this biopsy specimen. Protocathiarin 7 is seen more in men, older men, and there is a very little complement activation, so absent of 1+C3 staining only. And it's got a good prognosis if you see it. All the IgG subtypes are seen, IgG1 through G4 may be seen in this. Exosusin 1 and 2 classically associated with autoimmune diseases, especially lupus nephritis. So that means younger patients, more in females, preserved renal function, higher levels of proteinuria, less chronicity on biopsy, lower rate of progression to ESRD, and ultimately a good outcome. NCAM1 is overexpressed again in lupus nephritis, so females, younger age group. FAT1 is protocathiarin FAT1 in patients who have undergone hematopoietic stem cell therapy. It's usually seen around 2.5 years after and seen more in men. A couple of newer antigens, some of them are not really new. The neuron-derived neurotrophic factor seen in MN associated with syphilis. Pro-protein convertase subtlysin kexin type 6. It is seen in NSAID-induced membranous nephropathy. Contactin 1 is seen in membranous nephropathy associated with CIDP, chronic inflammatory demyelinating polyneuropathy. HTRA1 is a serine proteinase, high temperature requirement A1. And these like nectin, you can just go on and on and on about newer antigens. Gomdi madam was just telling me about newer antigens which came out a week ago, which has got letters and numbers and like, nobody's going to remember them. And many of them are considered as putative antigens. It's got virtually the same genetic sequence as the already described antigens. It's just that they're slightly different. So they all have got letters and numbers, not going into any of those putative antigens. Yeah, that's it.
Yeah, having heard the various new modalities of diagnosing primary and secondary membranous, I pose a next question to the panelist, Dr. Kritika, which is, what are the current and prospective drugs in the horizon for the treatment of membranous nephropathy?
Thank you, ma'am. So I think among all the glomerulonephritis in the past decade, the major strides have been in membranous nephropathy. And this is because of two things. One is newer antigens have been identified, which has helped us understand pathogenesis better. And second thing is a number of clinical trials that have come out that has helped us treat the disease better. So if we look at all the antigens, Madam just extensively discussed it. But here I want to emphasize that majority of these antigens are specific for primary membranous nephropathy, not only in the diagnosis, but also in risk stratification, prognosis, and monitoring of a patient responding to treatment or not. Apart from this, there are several antigens which have been detected, which are specific to either malignancies or lupus, apart from primary membranous nephropathy, which has helped diagnosis better. So if you look at KDIGO 2012 and compare it to the recent 2021 guidelines, apart from the diagnosis, which has moved from only biopsy to use of antibodies in the diagnosis of membranous nephropathy, apart from the risk stratification and treatment based on the risk stratification, there has been a paradigm shift in the type of treatment that has been given for membranous nephropathy from the 2012 guidelines to the 2021 guidelines. So the first line of therapy according to the 2012 guidelines was the Ponticelli or the modified Ponticelli, followed by either cyclosporin with glucocorticoids or a CNI. But now, based on the stratification, based on several markers, serological, GFR, albumin, based on the risk categorization, they're grouped into 4. And even in the lower risk strata, we can administer immunosuppression. And rituximab is always a possible choice in most of the categories, unless there is life-threatening complication, where still cyclophosphamide is a drug of choice. Second is relapse. In the KDIGO 2012 guideline, they talked about re-administrating the same regimen initially, which induced remission. But now there have been changes in this guidelines. So if it was first, if rituximab was used as a first line, you give another trial of rituximab. If that doesn't help, you move on to either cyclophosphamide or glucocorticoids. If CNIs and glucocorticoids were the first line, you change over to rituximab. And if cyclophosphamide was the first choice, you give another trial of cyclophosphamide with steroids or rituximab or a combination with CNI. So in cases of resistance disease, again, it was the same thing. It was either an alkalizing agent or a CNI and pulses of methylprednisolone. But now, if the eGFR is stable, you can either start off with the CNI or a cyclophosphamide with steroids and move on to rituximab, or the other way, start off with the rituximab. If they don't respond, move on to a CNI with rituximab, reevaluate the response, and then decide on what to give next. But if the GFR declines, the treatment is always cyclophosphamide. This paradigm change in treatment happened because of 4 trials. One is the GEM-RITUX, second is the MENTOR, third is the STARMAN, and fourth was a ReCyclo. So briefly talking about these trials, GEM-RITUX evaluated if rituximab was superior to non-immunosuppressive antiproteinuric treatment for severe membranous nephropathy. It was a multi-center study, included 80 patients with membranous nephropathy who had nephrotic proteinuria, hypoalbuminemia, and a GFR of more than 45. So they were randomized to 2 groups. One was the rituximab with non-immunosuppressive antiproteinuric treatment, and the other was only non-immunosuppressive antiproteinuric treatment. So when you looked at the complete remission or partial remission at 6 months, it was higher in the rituximab group at 35%, and this persisted at even 17 months of about 64%, which was statistically significant when you compared it to the other group. Apart from this, there was also a depletion of anti-PLA2R antibodies at 3 months and 6 months, which was significant when compared to the other group. So they concluded that there was a positive effect of rituximab and proteinuria remission, which occurred at 6 months. And there were also decrease in anti-PLA2R receptors and PLA2R antibodies are early markers of rituximab effect, and the addition of rituximab to non-immunosuppressive antiproteinuric therapy does not affect safety. Moving on to the next trial was MENTOR, membranous nephropathy trial of rituximab. This was again conducted in 22 sites in patients with membranous nephropathy on biopsy who had massive proteinuria and a GFR of creatinine clearance of more than 40. So in this trial, they had a run-in period of 3 months where all of them, BP was optimized, were on RAS blockade, and were on a dietary restriction. And then they were randomized to 2 groups, either to receive rituximab or cyclosporin. Again, this was a non-inferiority trial. So at 12 months, 60% of the patients in the rituximab had remission as compared to the 52% in the cyclosporin group. And this was significant for a non-inferiority trial. And when you looked at the same numbers at 24 months, it was superior to the remission in the cyclosporin group. So they concluded that in this randomized non-inferiority trial comparing cyclosporin to rituximab for the treatment of membranous nephropathy, rituximab was non-inferior at 6 months and was superior in maintaining long-term proteinuria up to 24 months. The other trial that came out was a STARMAN trial, which is a sequential therapy with tacrolimus rituximab superior to cyclical alternating treatment with steroids and cyclophosphamide in inducing persistent remission in primary membranous nephropathy. This includes biopsy-proven membranous nephropathy with a GFR of more than 45, with proteinuria of more than 4, and serum albumin less than 3.5. again randomized to 2 groups, which received either cyclical methylprednisolone and cyclophosphamide, or a sequential therapy where tacrolimus was given at full dose for 6 months, followed by 1 gram of rituximab. So this at 24 months showed that the cyclical therapy had better complete or partial remission at 84%. This persisted at 24%, and it was better than the sequential therapy group. And depletion of antibodies was also greater in the cyclical group as compared to the sequential therapy group. The adverse effects in the sequential therapy group were higher as compared to those in the cyclical group. So treatment was of corticosteroid cyclophosphamide induced remission, mostly complete, of nephrotic syndrome in a significantly greater number of patients than tacrolimus and rituximab.
We have 5 minutes left for the discussion.
And so I'm just going to skip this then. So when you look at how they compare, we know that all these drugs and trials have shown a good amount of complete and partial remission. But what about those that have not responded, and what about the relapses? So the limitations of the current drugs. So most importantly, when you use a cyclophosphamide and glucocorticoid, 15 to 20% of the patients may not have response. About 3 to 30% may have relapses. Then the usual side effects: cytopenia, infections, Cushing syndrome, infertility, cancer. And also patient tolerance is low, and adherence is variable because of the prolonged therapy. When you look at CNIs, here the no responses are high, as much as 80%, relapses up to about 50 to 60%, side effects such as nephrotoxicity, hyperkalemia, metabolic disorders, and patient tolerance is moderate, and adherence is again variable because of the long course of treatment. And coming to rituximab, it has about 20 to 30% no response, 5 to 13% of relapses, infections such as side effects such as infusion reactions, leukopenia, infections. And coming to although the patient tolerance and adherence is high, the costs are quite high for the patients. Coming to resistant membranous nephropathy, despite all the overall significant response rates of these new therapies, 20 to 30% are still resistant. And this is defined as persistence of nephrotic syndrome despite immunosuppression, or persistence or increased proteinuria in presence of unchanged or increasing antibody levels after 3 months of appropriate immunosuppression therapy. So what do we do about these patients? So this calls for a need of newer drugs to address the relapses, the safety profile, tolerance, adherence, cost, and this is mainly targeted at refractory and resistant cases of membranous nephropathy. So the solution for this is newer drugs, targeted therapy, and innovative techniques. So plenty of novel drugs and techniques are being studied to address these issues. Some of them are anti-CD20, proteasome inhibitors, BLyS inhibitors, anti-complement therapies, Burton's tyrosine kinase inhibitors, CAR T cells, immunoadsorption techniques, and sweeping antibody techniques. So I'm not going to talk too much about this because Madam has covered the pathogenesis. So just this image just shows us that every aspect of the complement pathway or T or B cell mediation, if we could target the specific antigen or the antibody producing sites, it could sort of help us target these relapses and resistant cases. Coming to the anti-CD20 antibodies, anti-CD20 is a transmembrane phosphoprotein on the cell surface of B cells. It's involved in T cell independent antibody response. It consists of an amino terminal and a carboxy terminal, and it also has 2 extracellular loops, which represents the targets of most of the CD20 monoclonal antibodies. So rituximab is a chimeric immunoglobulin, binds to the large loop of the distal loop. So this induces B cell death through 3 major mechanisms. One is the complement-mediated cytotoxicity. Second thing is antibody-dependent cellular cytotoxicity. And third is triggering apoptosis, that is direct lysis. So the need for novel CD20. This is because 35 to 40% of the patients treated with rituximab can show treatment failure. This is because of because they are sensitized to the murine portion of the drug, causing delayed serum sickness. So the newer CD20 antibodies, ofatumumab, not going into the details, I think we're running out of time. Then is the obinutuzumab. So there are several ongoing trials which have looked at these two drugs in not only primary membranous nephropathy, but also in rituximab-dependent nephrotic syndrome or resistant nephrotic syndrome. Proteasome inhibitors have been largely used in cancer. They can be a potential use of rituximab in resistant primary nephropathy, membranous nephropathy. There are no studies, but there have been case reports. Anti-CD38, they are present in long-lived plasma cells. These are daratumumab, isatuximab, and felzartumab. So again, there are plenty of trials in place. Belimumab. So belimumab again, should I continue? Okay. So I think for the lack of time, I'm going to stop my presentation. Maybe just go on to the last slide. I think we are running behind schedule. We have yeah. So this is a summary of my slide, looking at the different aspects of treatment and what they act on. So summary, there's been a dramatic improvement in understanding of pathogenesis, along with the paradigm shift in therapeutic management. Despite this, many patients have resistant membranous nephropathy which need alternative approaches. Novel anti-CD20, CD38, and complement inhibitors are most promising approaches. And new technologies such as CAR T cell sweeping antibody will definitely move the management towards a more precision-based approach. Thank you.
Thank you, Kritika. Now we have 5 minutes for discussion. So my question to the audience now is, what is the first-line therapy for treating primary membranous nephropathy? Anybody can speak into the mic. First-line therapy for treating primary membranous nephropathy. Yeah. So never go into immunosuppression. The first-line therapy is always non-immunological and lifestyle optimization. Only after that, try. Yes, and so how long should you try? How long should you try this non-immunological therapy? 6 months at least, 3 to 6 months.
Antibody, then we'll treat for 3 months, then we'll again do the immunological sample, then we'll go.
Yeah, so what is KDIGO risk stratification? How does KDIGO risk stratify the patient? And when does the risk stratification happen? Does it happen at baseline or does it happen after the optimization of non-immunological therapy? It happens at baseline, and at baseline there are 4 categories. There is mild, moderate, severe, and very severe. In mild and moderate, the first-line therapy is still non-immunological. In severe, you will have a choice of immunosuppression. But again, what immunosuppression? Is it going to be cyclophosphamide? Is it going to be CN9? Or is it going to be rituximab?
It's just a case. People of recently, they're very young and not completed the family, then we cannot even know that.
So which drug has the most evidence in literature? Yeah, so even now, even after all these trials, the strongest evidence in literature is for modified Ponticelli regimen, at least the long-term follow-up. Short-term, we still do have trials that have shown rituximab as non-inferior, but if you consider long-term, still the evidence is strong for modified Ponticelli regimen. But of course, there are situations where you cannot use that and you will have to go in for rituximab. And rituximab is also not a preferred drug for a very severe disease category, where again, it is a modified Ponticelli that works. Coming to cyclosporin, though the remission rates are similar, the problem with cyclosporin is the relapses. It has a very high relapse rate on discontinuation. And of course, long-term usage is associated with nephrotoxicity. So these are some of the take-home messages from this panel discussion. Thank you to all my panelists and to the chairpersons. Thank you.
Thank you very much, Dr. Manju, Dr. Saxena, and Dr. Mohan. It was a wonderful overview of membranous nephropathy. Since we know that membranous nephropathy is one disease that can take a trajectory that can vary from spontaneous remission to progression. I think you're over, especially with the newer antigens available and the newer strains available. I think you have covered everything. It's time constraint is always there, but thank you very much for your wonderful overview. Thank you.
Thank you for calling us, and I think the last 2 minutes you covered it completely.
Yes, slides were also very good.
We missed some of the new things because of the time, especially the speaking antibody. But I think we can bring it. Thank you.
Thank you, chairpersons, friends, panelists. Moving on to our last session of the scientific program, and the topic is evaluation of voiding disorder. And I would like to invite the chairpersons on stage, Dr. Vatsala Trivedi, senior urologist and transplant surgeon, Mumbai, Dr. Anupama Kaul, professor nephrology, SGPGI, Dr. Nivedita Kamat, associate professor, Department of Pediatric Nephrology, St. John's, Dr. Soumya, pediatric nephrologist, St. John's Medical College. I request ma'am to introduce the speaker.
Good evening. We are at the last session of the first day of WinICon 2, that is second year. My gratitude to the organizing committee of WinICon for giving me this opportunity to be a part of this unique conference, and we unfortunately be standing between you and the cultural extravaganza that is being planned. But I hope you will wait to listen to one of the important conditions that is so common in children and is often goes undetected and may present in late stages with complications. It's my privilege to introduce the speaker for today, Dr. Veda Kaur, who is an associate professor in the Laboratory of Clinical Pediatrics, Laboratory of Medical Research, Clinical Hospital, and Faculty of Medicine at the University of Sao Paulo, Brazil.
Joining us virtually.
Over to you, Dr. Veda.
Hi, good morning. You have my video. I taped my presentation.
We can see you on your slides here.
Do you have my presentation? You got it.
Hello, I'm Vera from Brazil. It's an honor and a pleasure to participate in this symposium. And we are going to talk about the evaluation of voiding disorders. And this presentation is divided in 3 parts. Nomenclature, which is basically ICCS and Rome 3 definitions. ICCS is the International Children's Continence Society, and which are really the basis for defining the features of clinical diagnosis and the clinical presentation. Urinary incontinence is the first definition, very important definition. It's an involuntary loss of urine in a socially unacceptable place and time by a child who is either 5 years of age or older or toilet trained. A child who has day and night incontinence has enuresis, the night problem, and daytime incontinence, so another problem. Always remember that when you have this, we have this condition, the daytime incontinence has to be treated before we treat the night incontinence or enuresis. When we talk about non-monosymptomatic nocturnal enuresis, we mean that there is nocturnal enuresis, but it's associated with lower urinary tract dysfunction. And sometimes it's also associated with intestinal dysfunction, which is named bladder bowel dysfunction, BBD. BBD is established when children who hold their bladders by choice for longer periods of time exhibit a reduced sensation to evacuate, which results in constipation or encopresis. Fecal incontinence is defined by the Rome 3 classification by OS, voluntary and involuntary passage of feces at inappropriate times and places from 4 years of age on, after excluding organic causes. And this is very important, especially because some organic conditions like irritable bowel syndrome may have the same presentation symptoms as fecal incontinence. So we really have to be careful in taking the history details and physical examination details of the patient. According to Rome 3 classification, there are two subtypes of fecal incontinence: functional constipation and non-retentive fecal incontinence. And the one which pertains to this lecture is functional constipation, that can be defined by the presence of at least 2 of the following criteria for at least 2 months of duration. So less than 2 defecations in the toilet per week, less equal or more than 1 episode of fecal incontinence per week, history of retentive posturing or excessive volitional stool retention, history of painful or hard bowel movements, presence of a large fecal mass in the rectum, history of large diameter stools that may obstruct the toilet, and exclusion of irritable bowel syndrome. We also need to define urine volume, and we do that at first by calculating what's the expected bladder capacity. I show you the equation here. It's age in years plus 1 times 30, which for children between 4 and 12 years of age, this is very useful. So we use this formula for this age range. In children above 12 years of age, we consider the bladder capacity to be of approximately 390 ml. So when we do our diaries, and I will show you the elimination diary, the family will write down the volume of urination. So if this, the same thing when we do an ultrasound, we can estimate the EBC by ultrasound. So when we have a volume that's less than 65% of the estimated amount, we have a small micturition volume. When it's above 150% of the calculated amount, we have a large micturition. We also have to define what's a normal frequency of urination, and it's between 3 and 8 per day. So less or equal than 3 and is decreased voiding frequency, and equal or more than 8 micturations per day is considered increased voiding frequency. Polyuria is defined by a volume above 5 or equal or above 5 ml per kilo per hour. And night polyuria is a volume above 20 times H plus 9 in ml. So now we use what we have learned with these definitions to define the clinical presentation of LUTD. Storage symptoms are increased or decreased voiding frequency, intermittent incontinence, urgency, and nocturia, always in children who are at least 5 years of age or after successful toilet training. So what's the other presentation? Voiding symptoms. So hesitation, also in children 5 years of age or more, or after successful toilet training, or at any age, voiding effort, poor flow, intermittence, dysuria, and other presentations such as containment maneuvers, post-void, urinary drip, sensation of incomplete urination, bladder, urethral, genital pain. So we always have to remember that when we have a voiding disorder, we have to differentiate between what's functional, which is what we are talking about in this lecture, and what's organic. So we really need a very detailed history and physical examination to do that. What are the entities we are talking about? So when we have predominant storage symptoms, we can have overactive bladder, delayed urination, underactive bladder. We are going to define all these entities later on in this talk. When we have voiding symptoms, what's the entity we're talking about? Dysfunctional voiding. Other entities we won't have the time to explore: stress incontinence, laughter incontinence, vaginal reflux, extraordinary daytime urinary frequency. It's important to know that you can have a concomitance of these entities, especially with BBD and with post-void residual volume, which is a volume of at least 20 ml after urination. And this is easily evaluated by ultrasound. How do we make the clinical diagnosis? We have to have a very carefully taken clinical history and a physical examination at all appointments. Why? Because the information may change when the patient or the family has more confidence in the medical profession. So the more we are in contact with this patient and the family, they know us and they know how we are going to behave towards the information they give us. So they are able to give us more and more details of what the clinical picture is all about. We need an elimination diary where we write down for 2 or 3 days on an hourly basis what's the volume of urination, what's the volume of liquid that was ingested, if there was or not urinary or fecal incontinence. And we can also add information on enuresis, so any night leak. I'm going to show you what's the elimination diary we use in our service. We also can add specific questionnaires, and now I will show you one of the more used ones. It's very useful. It's the dysfunctional voiding symptom score, which is presented to the patient when the patient is old enough to answer these questions, and to the family. So we have 2 different sets of answers to the questions. I'm going to show the questionnaire to you. So this is a model of clinical history. It's from a paper published by a group of Dr. Van der Waal. And as you can see, it's the characterization of the presence of nocturnal enuresis, of symptoms suggestive of bladder dysfunction, so leakage, urinary frequency, the presence of voiding postponement, sudden and urgent need to urinate, holding maneuvers, needs to push in order to urinate, interrupted urinary stream. There are other models, but I would like to call your attention to this manuscript, which is very useful to elucidate all the questions we have to pose during clinical history taking. What about physical examination? Oh, it also has to be very, very careful, and we have to take into consideration body weight and height, because growth retardation or failure to thrive do not belong in the kind of entities we are talking about, which are dysfunctional, but they belong in organic diseases. Inspection of lumbosacral spine, also to rule out any neurogenic cause of bladder dysfunction. Left bowel palpation to notice if there are fecal masses in the abdomen. Genital examination is very important. It includes examination of the underwear to verify if there were leaks, if there are stains from urine leaks, or if there is fecal incontinence. And also to evaluate for physical abnormalities such as hypospadias, phimosis, labial adhesions, which would be an organic cause to the disorder we are investigating. Rectal inspection is also very important, as well as a complete neurological examination and assessment of posturing. I'd like to call your attention for the genital and rectal inspection, because many times through careful inspection, we may suspect sexual abuse, which may be a cause of voiding disorders in children. A very silent manifestation of this disorder. So this is the dysfunctional voiding scoring system. It's 0 for almost never during the last month, 1 for less than 50% of the time, and 2 for more than 50% of the time. And this is for the patient to answer. And the questions are about the presence of wet clothes or wet underwear, the volume of leakage, if it's the underwear is soaked or not. It's questions about bowel movements and about the characteristics of maturation. So I only pee once or twice a day. I can hold my pee by crossing my legs, squatting, or doing the pee dance. So holding maneuvers here. When I have to pee, I can't wait, so urgency. I have to push the pee, it hurts when I pee. And we have questions for parents as well, with the same scoring. So during the last month, has your child experienced anything stressful, such as new baby, new home, new school, school problems, abuse, problems at home, special events, accident, injury, others? We use the Bristol stool chart. So this is part of the elimination diary, because it's a very useful way for the family to characterize the kind of stool, from constipation to diarrhea. It's important to know that when you have encopresis, you have constipation, and at the same time you have a wet leakage, you know, from the anus, which is some fecal material that flows around the fecal mass. And it's not, this should call our attention as well. This is the elimination diary. This is from our service here. And so you can see it's on an hourly basis. We do it for 3 days, and the caretaker or the patient should write down the volume of each urination, the volume of liquid ingestion on an hourly basis, if there were leaks or not, the pattern of stools, and you can add another column, for the night, for the enuresis evaluation. How do you complement your diagnosis? Usually with ultrasound. So ultrasound is mandatory. It's another way, as I told you, to verify the estimated bladder capacity, for which I gave you the equation as well. So you compare whatever you found during ultrasound with the equation, and you can see if the volume is adequate or not. And also you can check for post-void residual urine volume. So ultrasound is usually the first complementary diagnosis you ask for, and we always combine it with the evaluation of rectal diameter, because the rectal diameter above 3 centimeters is more associated with constipation. The second evaluation we make is through uroflowmetry, which is an evaluation of the micturition curve. I'm going to show it to you, and it's important to do it with electromyography. So placement of electrodes in the perineal area at 3 and 9 o'clock positions. The urodynamic study is in general not necessary. It's ordered when treatment has persistently failed or in cases of underactive bladder. So when you suspect underactive bladder, from your elimination questionnaire plus whatever you found during ultrasound, you order an urodynamic investigation. And I have to call your attention to the possibility of video urodynamic study, where you combine a VCUG with the urodynamics study, and so you can check also for VUR. I'm going to show this to you. So this is the normal, this is an uroflowmetry chair. So the child sits and urinates, and you generate the urine flow, the curve. This is the normal curve. It has the form of a bell. And you have here different flows. This staccato flow is very common in dysfunctional voiding. We are going to show it to you in other slides. This intermittent flow is very important, is very useful, because this is the pattern you have when the child is using the abdomen to urinate. And this flat curve is very common in obstructive disease. So when you have organic obstructive disease, such as, for instance, posterior urethral valves. This is the initial urofluxometry of a child who has dysfunctional voiding. You see here activity during voiding, and you see how the urinary curve is abnormal. Here you see a much better urinary flow curve. This is normal because using biofeedback, we were able to treat the dysfunctional voiding, and the child is clinically improved from from all other aspects that caused the dysfunctional voiding. I mean, it's multiple step treatment that we won't be able to explore in this presentation. This is the urodynamic machine. Here it's you can see the video urodynamic study where you have the VCUG here with the urodynamic study, which I can show you better here. This is the bladder curve, which is a summation of the pressures that are acting in the bladder, so the detrusor pressure plus the abdominal pressure. And here is the detrusor pressure. So this is dependent only on the bladder muscle. And here you see the electromyography pattern of muscle contraction, and this contraction is happening during urination. Okay, so and this is a Hinman syndrome, which is a very extreme case of dysfunctional voiding. What are the comorbidities? As I told you already about bladder bowel dysfunction, urinary infection, but we also have asymptomatic bacteriuria, VUR, which here is secondary to the condition, tendency to overweight and obesity, sleep disturbances, neuropsychiatric conditions. So in children with ADHD, it's very frequent to have voiding disorders, and also in children with intellectual deficiency. Behavioral problems are common in these children. So 30 to 50% of children with fecal incontinence have behavioral problems. 20 to 40% of children with diurnal urinary incontinence present also with behavioral problems, and 20 to 30% with children with nocturnal enuresis also need to be evaluated for behavioral problems. So going to the entities themselves, what do you have in overactive bladder? The clinical presentation is with urgency or urge incontinence, small volume urination, a high urinary frequency, enuresis or nocturia, containment maneuvers, and urinary tract infections. What's the complementary investigation? In the ultrasound, you have absence of bladder urinary residue, so no urinary residue, and the uroflowmetry is normal. You normally do not need a neurodynamic study. If you do it, you will see detrusor hyperactivity and uninhibited contractions on cystometry. Dysfunctional voiding, what's the clinical presentation? Discordant bladder and perineal activity with or without post-void urinary residue, normal or decreased urinary frequency, avoiding effort, hesitation, or intermittent jet, and frequent urinary tract infections. What do you have in complementary investigation? A decreased flow in uroflowmetry and staccato curve. And urodynamics, you are going to see pelvic floor contraction during urination and incoordination between the detrusor and sternal sphincter activities. And here again is the staccato curve. Other clinical entities, very, very quickly, voiding postponement is usually present in children who perform holding maneuvers to postpone voiding, and these children usually have a lower number of urinations per day. Underactive bladder, low voiding frequency, large amount of post-void urinary residue. So the detrusor function is abnormal at urodynamic testing, and this is the situation in which this testing, urodynamic testing, has to be performed as part of the initial workup so that you have a very quick diagnosis of this condition. Giggle incontinence, incontinence while the child laughs. Vaginal reflux is really not a disorder. It's a consequence of obesity. So when the child, the female child sits to urinate, you know, because of obesity, the legs end up pressing against the urinary flow. So part of the flow goes up the vagina. So when the child gets up, urinary dribbles from the vagina. So what you do, you teach the child to urinate with the legs very, very far apart, so that there is no pressure against the urinary flow. And of course, you have to give orientation for the child to lose weight. Extraordinary daytime urinary frequency is a condition of sudden increase in daytime voiding, in general associated with anxiety or a stressful event. What's the therapeutic management? Very, very quickly as well. Urotherapy, which is really, you teach the child to urinate, you teach good habits, you know, to have normal urination and normal intestinal function. You frequently you need an evaluation, and if necessary, psychological support. And what are the pharmacological and non-pharmacological measures? First, you have to treat constipation. So you have to, if necessary, you need disimpaction, which is with the PEG solution or Bisacodyl. And after disimpaction, whatever you used, in general, I think it's better to use the PEG solution. You keep it as maintenance for 6 to 24 months. So you avoid constipation while you are dealing with the urine problems. You have to treat urinary tract infection, and in this circumstance, you have recurrent urinary tract infection. So we have to use whatever we use for recurrent urinary tract infection here. Also, to give support to the treatment of the urinary incontinence. If there is a residual urine, we have to teach the child how to manage that. Double urination is one possibility. If, for instance, you have a situation of underactive detrusor activity, you need to use intermittent catheterization. For overactive bladder, in general, we use anticholinergics. And after all the daily manifestations that are treated in a child with normal urination and normal intestinal function, we manage nocturnal enuresis. Thank you very much. And I hope you appreciated the talk, and I'm ready to answer questions. Thank you.
Are there any questions from the audience? Thank you, Dr. Vera, for a very insightful talk, for emphasizing on the importance of clinical history and simple examination, which we often overlook, and also emphasizing that every child who has a UTI or a reflux, we need to take a detailed history using simple tools like the elimination diary and some scoring systems for understanding the bowel and bladder habits. Thank you so much.
Thank you, ma'am. Thanks to the chairpersons and speakers. With this, we come to the end of day 1 of the scientific program. Thanks to all of you, and looking forward to meeting all of you tomorrow. Please do join us for the cultural program in Hall B now, followed by dinner. Thank you. Thank you.